So welcome to our Merck Foundation Cancer Access Program, Oncology Session Day 2. Might be our only scientific session, so I welcome all of you to make the good use of what we have. So to our participating speakers, panelists, moderators, Merck Foundation alumni, distinguished members from oncology societies, and other healthcare professionals, you are all welcome to the Merck Foundation Cancer Access Program. As you know, Merck Foundation aims to improve access to quality and equitable cancer care in underserved communities, especially in low and middle income countries, by strengthening local capacities and enhancing the clinical management process by providing various scholarship programs under the Merck Foundation Cancer Access Program. So we are delighted to have you here and be informed that currently Merck is offering 1-year and 2-year fellowship programs and 3-year master's degree program at various partnership institutions across India, Kenya, and Egypt. And recently, Merck Foundation also launched a host of new online courses in 32 critically underserved specialties, including postgraduate diploma programs in cancer and clinical oncology from Queen Mary University of London and University of Buckingham, both in the United Kingdom. So I'll be moderating this session along with my colleagues, if they have time, Dr. Paul Rajkumar, the Scientific and Medical Manager at Merck Foundation, and Dr. Luminary, Scientific and Medical Manager also at Merck Foundation. So we'll get our first presenter of the day. I would like to introduce to you Dr. Jerry Ndumbaro, my colleague, longtime colleague, a clinical oncologist, the first set of young clinical oncologists in Tanzania, to us about the prevalence, challenges, strategies, solutions, guidelines, and treatment. And Broad is going to talk about cancer care in Tanzania. Please.
Good morning again. So thanks, Professor, for that great introduction. I don't want to repeat anything about that. My topic was long, as you could see. It has everything regarding cancer care in Tanzania. So I hesitated which things to put in and which things to leave. But at the end, I decided to put on this. My outline. So this is basically epidemiology of cancer worldwide, as we all know. It's the second common cause of death. We're almost approaching 20 million a year new cases and almost 10 million number of deaths. And it's projected that by 2045, we will almost double. I mean, it will do almost 1.5 times the prevalence that we are having now. In Tanzania, this is our profile. So we have the most common one being, so this is what the worldwide that I was talking about. And what I wanted to point out here is you can see, apart from Asia, just because of the larger population, but basically Africa, you have red here. Look at the incidence in Africa and look at the mortality. And you can get a picture that majority of our patients, we are taking a very big jump in mortality rather than the incidence rates in the world. So we have this problem, and that is how it is presenting in our setting. So the rates and the trend is increasing in our setting. And as projected, as I said, in 2045, we're expecting to have almost 1.5 times the prevalence that and the incidence that we are having now. And most of these, there are different reasons that are there, including now the lifestyle that are coming up, genetics, environment, social, cultural, behavioral change, and all these now are playing a role, especially in our African setting, where the lifestyle was now part that increasing some of the cancers, especially here in Tanzania. You can see in less developed versus developed countries. So this is what I was talking about. Compared to less developed and developed countries, the trends will increase in our developing countries, and the trend seems to be decreasing in the more developed countries. So we're expecting the burden of cancer to still increase in our setting. So there are several risk factors that are there. And now we are having this physical inactivity and obesity and basically change of lifestyle. So initially we just had these other risk factors, especially infectious one. We had hepatitis, we have human papilloma virus. That's why you see in our epidemiology, I will show you later that our leading cancer will be cervical cancer there. And also we have number of cancer that are associated with the hepatitis. Those are infectious one. But now the burden is coupled with these cancers that are increasing in terms of lifestyle change. And this is not only in Tanzania, but around our sub-Saharan Africa as well. So you can see the burden in all these risk factors. So tobacco use, there is a trend of increasing tobacco use in our settings these days. Very young girls and young boys are using, especially shisha. It's the trend that is increasing, and we're expecting probably several years to come, we'll have an increase in burden, especially on the head and neck and other cancers that are associated mostly with the tobacco use. But otherwise, the alcohol has also been abused. And I think last 2 weeks, there was a report that Tanzania was the first or second leading consumer of alcohol in sub-Saharan Africa. Was last week. So there is also increasing alcohol abuse. So we have tobacco, we have alcohol now, we have change in lifestyle, coupled with infectious cause of hepatitis. So you can see the picture 10, 15 years to come if we don't take any action. So this is our burden. So we have almost 44,000 new cases a year, and you can see the death is almost 2/3, 29,000. 44 to 29,000, almost 2/3 of our patients also are dying. And this is, as I said, the epidemiology now. So our leading cancer in female is cervical cancer, then followed by breast cancer, and then we have colorectal. And in male, we have prostate cancer, followed by esophageal cancer, and then we have colorectal. You see colorectal here. In the past 10 years, basically 15 years when I started working in the oncology setting, was not even in 15 or 20, top 20 in our list. It was not even in top 15 in our list. But now, 10 years later, 15 years later, now it's number 3, not only for female, but I mean in both sexes, you can see it's coming and leaving. So as I said, all these risk factors that are coming up now, coupled with other factors that were already there, then this lifestyle type of cancers increasing in our setting. So this is the incidence of our cancer burden in Tanzania, and this is definitely the mortality. Incidence reflects mortality. Directly you can see there. These are according to Global Fund report of 2020. So you can see the picture is not that. Majority of our patients almost, you can even just put a cervical cancer there, and incident rate is standardized almost 64, and almost 42 dying. So you can see the picture of that body. So we Also, we have, apart from this data that are developed in global countries, we have our own data in Tanzania. So we have a population-based cancer registries that are scattered in different parts of Tanzania. So we have the northern zone, northeast zone, we have on the central zone, and we have on Dar es Salaam, and Beira as well. So the data from these our registries also reflects the same. Cervical cancer being the leading, and then followed by prostate, esophageal cancer, breast cancer, and then you can see colorectal cancer, even in our own data. So in female, those are the top 10 for females. Cervical being the first, then followed by breast, and then for male, prostate, followed by esophageal cancer. So that's basically the picture. And now in childhood cancer, this is the picture. So lymphoma being the first, then followed by glaucoma in the eye, and then we have Williams tumor on the third. So this is the burden in our pediatric care. This is followed by leukemia. That's how the presentation. You can see from 2019 to 2023, every year the cases are increasing. Okay, so that's a bit about epidemiology of cancer in Tanzania. That's our burden, and if we don't take any intervention, then that will basically increase. So before going further, as a nation, we took action and have a strategy to combat this problem of cancer. So we had our national cancer control strategy. This ended last year. So in 2013, we had to make a plan on how now to combat this problem. As we saw, the burden are almost increasing every day. So we said we have to make a strategy on how to tackle or to fight with this cancer. So this was ended last year. So we are now currently reviewing it and plan for another 10 years. Okay, these are our founders. You can see here Professor Ngoma and the team. So they developed this in 2013 as a plan, as a roadmap for 10 years. So it had 9 pillars, 9 goals. The first goal was regarding prevention. We said as a nation, we have to have a prevention plans. Okay, so during this time of the whole of the 10 years, what we did was first we introduced HPV vaccination for under 5s. So all our under 5s are getting the vaccination, and also HPV vaccination also, which was started around 2018. But during the COVID era, the uptake was relatively not good, and then it was reintroduced last year. So now they are saying coverage is almost for girls at the age of 9 to 13. They're almost around 70 to 80% coverage for the whole nation. So it's going very, very, very well. And also we introduced tobacco control laws. So you cannot smoke in the public, you cannot advertise anything in the public regarding tobacco. And all those tobacco control ratification that was introduced in 2022. Also, currently ongoing education to the public. So that was the primary goal number 1, which was regarding prevention. So regarding early detection and screening, we've introduced nationwide in all the health centers screening programs, but especially for cervical cancer. And I can say that for the past 10 years, initially we were just getting stage 3s and 4s. I can say even 90% of our patients almost were stage 3 and 4s in cervical cancer. Currently, as I'm speaking, I can say even I have 60-40 regarding the advanced and the area stages. Now, majority of our patients now these days are coming at stage 2, stage 2, stage 2, stage 2. 3 and 4, you can count them, maybe 20 to 30%. So this helps a lot. The screening program that have all over the country, all the healthcare centers in the country, they are doing this screening program. And also they have this nitrogen gas that they are doing also. They are also treating them for all those cancerous. So we have also prostate screening. This was started in 2015, but also it's not going so well. As you all know, means we are lagging behind always. So, but it is also in our plans. The diagnosis also was introduced. Initially, it was just on the national and referral hospitals, but now the diagnosis is starting at the level of district hospital. This is as a plan of the country that we have to diagnose at that lower level so that we can treat each patient as early as possible. That was goal number 2. Goal number 3 was treatment. In 2013, we only had 2 cobalt units that were sitting at Ocean Road as a treatment for radiotherapy services in Tanzania. And the plan now, and the Ocean Road was the only center that was treating the cancer patients. But the plan was now to centralize these services to make available for the whole country. So this has been achieved now. All the zonal hospitals, including Kilimanjaro, Mbeya Referral Hospital, Dodoma, Benjamin Mkapa Hospital, Bugando Medical Center, they are all giving cancer treatment. They are doing surgical services and also they are doing chemotherapy services. And some centers like Bugando, they are also doing radiotherapy services as well. So now it's not only Ocean Road, and also we have been National State, the National Hospital. So not only Ocean Road, but there's the services have been centralized. And also, as I'm speaking currently, we are building bunkers all over the country. Bugando, they have almost like 5 bunkers just waiting for radiotherapy machines. KCMC, they've already built, like they have 4 bunkers. We have Mbeya also is ongoing. Benjamin Mkapa is almost finishing. They've finished building bunkers. So this is the plan now. After sending these medical oncology services, the second will be now radiotherapy services. So that was goal number 3, introducing treatment or decentralize this cancer treatment nationwide. Also, during this treatment as a goal, we had to have our national cancer treatment guideline. Initially, everyone was treating according to where they were trained or their experience or that. But in 2020, we sit down all as a multidisciplinary team of Tanzanians, and then we made our very first cancer treatment guideline. So we have a cancer treatment guideline that guides all the cancer treatment in the time. And then this is also helps us in terms of even the insurance, if they want to pay for their patients, they use it as a guide so that they know this breast cancer patient is treated this way. These are the drugs that they so that also helps streamline the services to streamline the treatment. Because as I said, the treatment now is decentralized, the whole country. So we have to have standard, and we have to have a standard of care. So we also had to make our own treatment guideline. That was goal number 3 regarding our strategy. So we had goal number 4. This was regarding palliative care. Palliative care in Tanzania, initially, the morphine was only available in Ocean Road. And all the palliative care services was only centered at only one center, Ocean Road. As I'm speaking now, even a dispensary can procure morphine directly from our medical stores department. So morphine is accessible to the whole country. You can just put in your medical list in order it directly from our medical. So that is helped at least to improve in terms of pain management and general palliative care. We are still struggling with home-based and also hospice. That is the area that we haven't yet. We are not that good at that yet. Yeah. So that was goal number 5. Number 4, palliative care. We had goal number 5, that was cancer registration. As introduced earlier, we have 5 population-based registries around the country, and all the hospitals, they have their hospital-based registries. So in terms of cancer registrations, that is what we are currently doing, and we are expanding these registries. We want to have almost the whole nation covered with the registries. As for now, as I'm speaking, it's like 30 to 40% coverage only in these 5 centers that are there. So we're expecting that as the years goes by, we have more population-based centers, and then we'll have data directly and we'll have our own. Also, regarding registration and surveillance, so we had a goal number 6, which was training. So as Professor Akoko said initially, when we started working at Oncology, only had, I think there were 4 almost retired oncologists. We are starting as a medical officer. You can see the gap between the professor who is retiring and you was just newly from a medical school. So we didn't have enough oncologists in the country. So the plan now was we have to introduce training program for our own oncologists here in Tanzania. So in 2010, we started a training program of medical clinical oncology program at Masters of Medicine. And as I'm speaking now, we have about 65 oncologists in the country for this past almost 10, 12 years. We have almost like 65 plus clinical, just talking about clinical oncology. So now we don't have a problem in terms of the number of oncologists. Also later we introduce another training of radiotherapists. So also we have number of them, I can say 50 or 60 plus radiotherapists that are available in the country. Last 2 years, we introduced Masters of Program in Nursing Oncology, and this has been ongoing almost now for 3 years. We have, I think, 10 plus graduates already for the Nursing Oncology, and the Medical Physics program. This is in the pipeline. The curriculum has already been set, and we're expecting probably in a year time we'll have a medical physics program. We are struggling with Dr. Koko, Professor. We are struggling with the surgical oncology. Surgical oncology is where we are still struggling. We don't have any program in the country, only program. We are basically depending on funding data to have that training so that we can. So if we still knock your doors regarding surgical oncology, we have to open for excellence. So that's regarding the training. Goal number 6. Goal number 7 was human resource. So this was coupled by our training. As I said, we have almost now 65 plus oncologists in the country. And then we have number of radiotherapists. The problem we have is medical physics, and the problem we have is surgical oncology. But the other clinical oncologists, we have a number of them. So in terms of human resource, that is the picture. So goal number 8 was now to make cancer control activities and basically promoting this cancer prevention. That is when some of the society, like our society, Oncology Society, was introduced. We had a number of societies, surgical society, MEWATA, Women Medical Association, and all other societies were introduced. just to help the government, just to make the education to the public and help working in hand with the government. The last goal was now to integrate all these, integration and coordination of all these services. As I say, Ocean Road was lying on one side, you have other hospital lying on the other side. There was not even a desk at the Ministry of Health that was directly dealing with the cancer. It was just generally everything was there in the clinical services. So we said we have to have a plan and we have to have a coordination center that can take care of all these activities that we are planning as a country. So the past almost 3 years, there was an introduction of national NCD program. So we have like malaria program, like TB program. Now we have a national non-communicable disease program. So under it, we also have cancer directorate in one of its department with the director of cancer in it and the coordinator of cancer. So that also helps at least to streamline and coordinate all these activities that are there in the. So this is that was our plan, and this is how far we have reached. We are basically last year. What we did last year was to evaluate ourselves, and now we are making another goal for another 10 years. So probably next year, early next year, we'll have national cancer control strategy for another 10 years, 2025 to 20. And we'll have our goals to take us through those another 10 years. So this is where the center that I was talking about. We have a Muhimbili National Center. This is our national center. We have Ocean Road Cancer Institute. So Muhimbili National Center, they're basically doing surgical services, they're doing medical services. And this is the National Cancer Center that will doing all the tertiary services, public. We have Ocean Road, as I said, as a tertiary center. We have now 2 linear accelerators and CT scanner. We have MRI at Ocean Road, and currently we have just installed and started using a new PET CT scan. So we have a PET CT scan in the country with a cyclotron at Ocean Road. Just started this month. We've just opened for service this month at Ocean. So also we have some private centers like Besta. Facilities here in Dar es Salaam with 1 linear accelerator, and the clinical oncologist is there. And they are doing also chemotherapy, medical oncology services. We have Aga Khan Hospital. So this is doing medical oncology, and they've just also installed 2 new linear accelerators, and they are expecting to start surgical radiotherapy services just as soon as possible. That is Aga Khan. And then we have these other, as I said, Bugando Medical Center on the northern zone. We have Kilimanjaro Christian Medical Center on northeast. We have Benjamin Mkapa. So that's all I wanted to talk about cancer care in Tanzania.
So Banavali is going to present. And may I welcome Shripad Banavali now. He's the Director of Academics and Professor, Department of Medical and Pediatric Oncology at Tata Memorial Center, Mumbai in India. So we'll be discussing pediatric oncology, especially bone tumors. Bone tumors are a big problem. We have had our own shares of problems with bone tumors in children. Whether it is osteomyelitis or it is cancer, nobody knows. And different opinions would come with histology because we still rely on histology. And so you amputate a limb and several reviews, and then you say it was osteomyelitis, and the limb is gone, and it's in the court. So let's hear from Indian experience, how they diagnose and treat their bone cancers. Welcome. Yes.
Thank you. So how many of you have been to Tata Hospital? Thank you. So I don't need to show, but even those who have not been there. So this is the Homi Baba building. This is the main building of Tata, and this is the annex building, and there's one more behind that, which is the Golden Jubilee building. So just for those who have not been there. But the other thing is today is Homi Baba. Homi Baba was the architect of the nuclear program of India, and thanks to him, we were taken out from the health ministry and put in the Department of Atomic Energy. This thing which, as all know, there's a lot of fun. So we are what we are today, thanks to Homi Baba. And today is his birth anniversary. So really a great day for us today. Thank you. So I'll be talking about bone tumor. How many of you have treated bone tumor? Very few. So I think principles should be important, though not many of you treat that. But
Again.
thank you, sir. So basically, I'll be talking about bone tumors. Pediatric sarcomas, as you all know, it's divided into soft tissue. I think this is not meant for this screen, so it's not working the pointer. We have another pointer. So soft tissue sarcomas and bone sarcomas. Soft tissue sarcomas is divided into rhabdomyosarcomas and the non-rhabdomyosarcomas, soft tissue sarcomas. And these are all those. We are not going to talk about this today. We are talking about the simple two things: the osteosarcoma and the Ewing sarcoma, which are the common pediatric bone tumors. And this is what it shows. So you see the peak incidence of the bone sarcomas is during the growing period, and it's around 14 to 19 years of age. Actually, there's more osteosarcomas than Ewing. Ewing sarcoma goes down as the age advances, but you see that the osteosarcoma goes down. There's a surge of bone sarcomas again at the end of and as the age advances. Maybe these are the ones which are secondary cancers and also, those who get radiated and all, they get bone osteosarcoma. Or if you have, P53 mutation, then you may get. So there is the surge of those in the later part of the life also. And as you know, the distribution, again, osteosarcomas are more common in the epiphysis and the metaphysis and epiphysis, where the growing areas of the bone. So these are the common areas of osteosarcomas. And the Ewing sarcoma is more in the diaphysis and more basically the axial. And the Ewing sarcoma is more than in the distal bones. So, but this is just to show that osteosarcomas are in the metaphysis and epiphysis region, and the Ewing sarcoma is more in the diaphysis region of the bone. So diagnostic workup, actually we'll talk about it, but very importantly now we know that for the Ewing sarcoma, the FDG PET scan is a good this thing if you want to in one go look at the spread of the extent of the disease all in the body. Whereas in osteosarcomas now we know that the fluoride PET is a better way to do the scans because that picks up the bone picks up that, and even if you have small area of bone in the tumor in the tissue, that picks up, so that this is a more sensitive way to diagnose osteosarcoma. Coming to the workflow, actually, any suspected bone tumor, again, definitely we do the blood test. Begin with for various reasons, including the organ function, but along with that, especially lab score, the alkaline phosphatase increase may help you for diagnosis of osteosarcoma. And we have the other LDH and all as markers. But main thing is it comes to the histopathological diagnosis, and for that we need a biopsy of the tumor. Then you have to stage the patient according to whether it's a localized tumor or a metastatic tumor. We have to do certain tests for the toxicity workup because, as you know, these are young patients, but we have to look at the cardiac function because a lot of anthracyclines are given to this patient, so echo may have to be done. For many of these patients get cisplatinum, so we do the hearing function of this patient. So the toxicity workup is required before we start the actual treatment. And actual treatment, we definitely now the trend is that we give neoadjuvant chemotherapy followed by local treatment, which is maybe in the form of surgery as well as radiation therapy. And then we have adjuvant chemotherapy also. So the trend has changed from starting with surgery and then giving adjuvant therapy to neoadjuvant chemotherapy followed by the other therapy. So we'll talk about osteosarcoma first. This is a rare thing most you get in the as we know in the femur, but osteosarcoma of the humerus in this patient. And these are some of the risk factors, especially osteosarcoma. We know that there are certain hereditary diseases that give rise to genetic diseases, which gives rise to increased incidence of osteosarcoma. So, like you have the retinoblastoma gene involved, in the Leaf-Remini syndrome, where the P53 gene is involved. Then we have some other like Rothman syndrome, Bloom syndrome. These are some of the syndromes where you get increased incidence of bone cancer and especially osteosarcoma. So the basic test in bone tumor is radiology, and we start with simple X-rays because X-rays gives a lot of information. So initial investigation is for the looking at the local extent of tumor. So simple X-ray, which nobody talks nowadays, but plain simple X-ray also gives us a lot of information. And along with that, the investigation of choices, not a CT scan, but in bone tumor, it's an MRI because it gives you, along with the tumor, it gives you a lot of other information, the architecture, involvement of the arteries, the vessels, the nerve. So MRI is the local listing of choice. And then you have the distance spread for that. Again, we used to evaluate simple X-ray in the past, but now we no longer do that. We do along with that a bone scan. If you don't have an MRI or PET scan, I mean, if you don't have a PET scan, we can do a bone scan also. But MRI would be better if it is. PET scan would be better if it is available. So these are just some more X-rays. You can see the secondary appearance of that. And main thing is you have to keep in mind that you have to do scans of the full bone with the adjacent joint, especially if you're thinking of limb salvage surgery and all, the joints have to be involved to do a full scan of the bone with the adjacent joint. And an MRI gives you more better picture and basically more better extent of the disease you can evaluate by doing an MRI. Plain radiograph, again, lot of things to discuss, but for lack of time, so you see the lesion type, whether it's a lytic sclerotic, the zone of transition, the periosteal reaction, and the matrix. So there are a lot of information a plain X-ray can give in bone tumors, and you have to ideally do as X-ray also along with the other tests that you are doing. So again, like I told you, an MRI investigation will give you a lot of information like the relationship to the vital structure, like the nerve vascular bundles, the joint involvement, the skip metastasis. So all this information will get with an MRI. So ideally in bone tumors, get an MRI done if it is available. And for distant, again, we have to look at after the local evaluation, you have to make sure how much is the extent of the disease, because a lot of things depend on that. So, plain radiograph of chest, like I already told, a CT scan of chest, non-contrast or with contrast, bone scan, and the PET scan. So these are the things we do for evaluation of the distant metastasis. So this is a plain X-ray showing the metastasis here, and you can do that on a CT scan also. Then it's a bone scan where you can see a lot of involvement of the bone, but doing a plain bone scan, and if possible, a PET scan will be a better picture at one go of all the involvement of this. So then comes the biopsy. So we have made a diagnosis on a probable diagnosis on a radiograph or a radiology evaluation, but then ultimate this noise on biopsy. So after clinical suspicion, taking a good history, clinical examination, imaging, with all this, you think that there may be a possibility of bone tumor. So that you have to prove by doing a biopsy. But that's very important to keep in mind that we should do it. Because nowadays we no longer do the amputation, a lot of limb salvage is done. So if we want to do a limb salvage, you have to make sure that the biopsy is done properly. We do not contaminate the area from which we want to salvage the patient. So basically, it should be carried out by a bone tumor treating center. So where you're going to treat, ideally a biopsy should be done there so that you know exactly through which veins they have gone and which are not contaminated. The adequate material in the least traumatic way without jeopardizing the limb salvage, the aim of doing the biopsy in this patient. Coming to the prognostic factors, there are established factors and there are probable factors and prognostic factors, but there are very important established factors already. The first one is, the site of the disease, whether it's axial, appendicular, or craniofacial. These are areas where you cannot see that the still the most outcome in most of the series at that time. And it's not. This all we should do after that talk. I will decide in between. So if you see here, if you give chemotherapy, the outcome, this is one of the initial papers of using neoadjuvant chemotherapy, but you see of patients who receive chemotherapy, outcome was much better than those who did not receive chemotherapy. So definitely it improves the outcome. And now it has become standard of care. So nobody will treat a bone tumor without chemotherapy. So only thing is whether to use it in neoadjuvant way or use it adjuvant after the surgery. So in neoadjuvant, we give chemotherapy, and after 10-14 weeks of therapy, we go down and operate on the patient. And in adjuvant setting, we start with the surgery, then do the local treatment, and then continue with chemotherapy. So advantages are many with neoadjuvant, and that's why actually if you give neoadjuvant chemotherapy, maybe you control the micrometastasis because there are already micrometastasis. We know when you used to operate in the past and not give chemotherapy, by the time the wound is healed, patient used to come with cannonball metastasis in the lung. So definitely there are micrometastasis. So that may take the neoadjuvant chemo may take care of that. It may decrease the need of radiation therapy, especially Ewing sarcomas. Smaller RT volume will be required if the tumor shrinks. More limb salvage preparation. That's very important. Processes, Nowadays we don't do amputation, we do limb salvage with prostheses, which are individual prostheses. So at the time of diagnosis, we take the measurements and all, give it to the company to make the prosthesis for that patient. So by the time it takes time to make the prosthesis, you give the neoadjuvant chemotherapy. So it gives you time to prepare the prosthesis. And again, like I told you, very, very important is the most important prognostic factor is the tumor necrosis. So if you give that upfront, then only we'll know whether you can, how much is the necrosis. So this helps us to even prognosticate the patient. Disadvantage are some of those which are mentioned here, but most important, which happens in a very minor patient number, is that the tumor may increase and then a tumor which was resectable becomes unresectable. So this happens occasionally, but this is definitely a risk factor. But overall, it shows that if you give neoadjuvant chemotherapy, that is better than doing the primary surgery. So now what is the standard of care is you usually give 10-14 weeks of neoadjuvant chemotherapy, then do the local therapy, and osteosarcoma, as we know, there's no role of radiation therapy per se, so it's only the surgery. And then there is adjuvant chemotherapy. So this is now the standard of care for osteosarcoma. Again, this is a one slide. Everything, whatever has been done with chemo has been included in this slide. But what you can see is that two things is here. This blue line is the outcome of patients who received 4 chemotherapeutic drugs. The green line is the one which patients have received only 3 chemotherapeutic drugs. And this is the red line is those who received 2 chemotherapeutic drugs. So what this graph shows really is that 3 drugs is as good as 4 drugs. So you really don't need a 4th drug in the management of osteosarcomas. And this is what it is. So 3 drugs are better than 2 drugs. No need of benefit of adding the 4th drug. And what are the 2 most important drugs in osteosarcoma? It is the cisplatinum and doxorubicin. And the 3rd drug, which is debatable again, is especially the West, the developed countries use high-dose methotrexate, but as we all know, in many of the low and middle income countries, including in India till some time back, we really couldn't give the high-dose methotrexate because of various reasons. The logistics, nurse ratio, you need 1:1. So you have to check the pH, you have to check the IV input, output. Then you have to do the drug levels. The drug levels have to come immediately. So all that was not there. So it was very difficult to give high-dose methotrexate. And the 4th drug is ifosfamide. And I will show you that, though the West says high-dose methotrexate is a very important drug for osteosarcoma, our data shows that it's not important. Ifosfamide is as good as high-dose methotrexate. And maybe in many of our, Africa and India, it is still more easier to give ifosfamide than to give high-dose methotrexate. Then again, what it shows is that metastatic disease was prognostic. If you had more metastatic disease, more than 1 or 2 mets, those were the patients who did not do well as compared to those who had only local disease. And again, this is a very important thing which came out of the neoadjuvant chemotherapy was the degree of tumor necrosis. So importantly, as you can see here, if you had more than 90% tumor necrosis, the outcome was better. But more importantly, if you go down and see at the tumor necrosis further, if you had more than 98% tumor necrosis, those were the best. So more than 80% outcome in those who had more than 98% tumor necrosis. Tumor necrosis became a very important prognostic factor. Now, one thing you can do is instead of 14 weeks, you 24 weeks of chemotherapy. And the Italian study found that 100% necrosis in most of the tumors. But actually, it worsened the outcome. So that's very important how much you do. If you delay the surgery by giving, and that happens many times in like in Tata, those who have worked, there's no slot available. If the surgeons tell us, or in the multidisciplinary team, we decide, let us give 1 or 2 more cycles by the time we'll get the date for surgery. That's not good. You have to operate this patient within 14 weeks, because if you delay, and even if you get 100% necrosis, that group of tumor did poorly than those who got operated on time. So operating after around 12 to 14 weeks is very, very important. And tumor necrosis at the time of 12, 14 weeks is what this graph shows. And the most important trial in Ewing sarcoma is a Euromos. So Euromos is basically Europe and American came together, and the EUR is Europe, AM is America, osteosarcoma trial. So what this helped them to treat hundreds of patients on this trial, so that they really got some good data. So 2 things important came out of this study is that, especially if you had a good risk patient, that means localized disease, good necrosis post therapy, they are the ones who did better. And again, 3 drugs were good enough for them. What they did in the poor risk patients, that means patients who had local disease but less than 90% tumor necrosis, they thought, let us improve their outcome by adding the more drugs. So along with the methotrexate, adria, and platinum, they added the IFOS and etoposide also. But very importantly, the data showed that again, 3 drugs was as good as the 5 drugs, and there was no absolutely improvement in outcome. So it doesn't help us to improve or increase the intensity of treatment once we see tumor necrosis is poor. So that is one thing. So we no longer do that. And the other thing it showed us that the metastatic disease definitely did poorer than the non-metastatic disease, which was expected. But this once again proved that metastatic disease was not good in this patient. So this is our data, our own Tata hospital, which has been multiply. We have published this extensively, but this is one of the paper which showed that again we used cisplatinum adriamycin. So our neoadjuvant chemotherapy was cisplatinum adriamycin, and followed by cisplatinum and ifosfamide. So 4 drugs here, and after that, so no high dose methotrexate in our protocol, and then basically the post adjuvant chemotherapy was cisplatinum and ifosfamide. So this was our protocol, and you can see here the outcome was as good as the other the Euromos data, where there is high dose methotrexate is the event-free outcome, and that is the overall survival. And we saw that there is no difference at all in what has been published by the European Euromos protocol as compared to our protocol. And the same way, you can see the graphs being superimposed on each other. This is for the metastatic disease, which again shows that for metastatic disease, you need to do better. And at present, our outcome is not that good. So local treatment is again amputation versus ablative surgery. But many times in our countries, we get patients with large tumors, and it is very difficult to give them neoadjuvant chemotherapy or limb salvage surgery. So sometimes in those patients, we have to do an ablative surgery in the form of amputation. 80% of the patients get the limb salvage, and limb salvage is in the form of either prosthesis, or we do rotation plasty. This is basically we turn the ankle into make it as a knee joint. And this thing, I don't know how many of you have seen those photographs, but rotation plasty is where you don't have prosthesis available. I think this is a good way to do the practical way to do functional surgery. And sometimes you do extracorporeal radiation therapy to that. You take out the tumor, give it high dose radiation, and then put back the same thing inside. This sometimes we do. We have already published on that also, but this is sometimes we do that. And only one drug that over the years that we have found anything improvement is the muramil tripeptide. Basically, adding to chemotherapy, can increase the outcome. You can see here the muramil tripeptide improved 6-year overall survival from 70 to 78%. But we still don't, it's still hardly used anywhere in the world. But at least one trial showed that you can use it to improve the outcome. Then these are various drugs that have been used in patients with recurrent refractory osteosarcomas, but you see a basically response is zero. So bone tumors with these 3-4 drugs is really good to treat, but there's really no new drug that is path breaking or that has helped us improve the outcome in both advanced refractory cancer or recurrent cancer. There are many new molecules coming, a lot of antibodies and CAR T cells. Many of these antibodies you see are already negative trials. The antibody treatment like anti-HER2 new or basically this dinutuximab. There are so many of those which trials have been done are negative, but there are other CAR T cells that are basically coming out in this thing. So a lot of CAR T cell work going on at present. The anti-GD2 CAR T cell, which is used in neuroblastoma also, lot of work going on, but still there's no definitive data to say that it will help. So that was osteosarcoma. Now some slides on Ewing sarcoma. Again, like I told you, Ewing sarcoma is more in the diaphysis as compared to metaphysis and epiphysis in osteosarcoma. And one of it's a molecular marker is there, the EWS FL1 translocation, the 1122 translocation, which is there. This is seen in nearly 85% of the Ewing sarcoma. And there are some other translocations also which are noted in patients with Ewing sarcoma. The common one is the 1122 EWSR1 FL1 translocation, and the additional thing. But all this can be detected by FISH or RT-PCR. And this is the Ewing, we first described it way back in 1921. That time we called it diffuse endothelium of the bone. But very importantly, even at that time, we saw that basically response to radium pack, basically it helps to get a remission. But even that time, they saw that there was systemic recurrence after that. So though these tumors are very radiosensitive, if you don't give systemic therapy, there is a chance of recurrence. So again, in Ewing sarcoma also, though it's a very, very radiation sensitive tumor, along with radiation and chemotherapy surgery, they require systemic therapy in the form of chemotherapy. So Ewing sarcoma is divided into localized and metastatic tumors. So standard risk localized, which is small tumors, localized, good Ewing, its response to the chemotherapy, that is necrosis. And these are the high risk localized, is basically the ones, large ones are with less than 90%, the tumor necrosis. Then you have metastatic lung only do better than if you have metastasis at other side, like bone marrow. So this is how you divide them. All of them receive neoadjuvant chemotherapy and followed by surgery if possible. Surgery is done. And depending on the surgery as well as basically the response to your therapy, that is tumor necrosis, they may or may not require radiation therapy, but all of them require maintenance chemotherapy after the initial treatment. So for osteo and this is everything else the same except these tumors are radiosensitive. So you can you need to add radiation therapy where it is required. So again, the same prognostic factors, whether it's metastatic disease, if it's metastatic, whether only to lungs or other sites, the tumor site, whether it can be operated or not, age of the patient, tumor volume, response to chemotherapy, choice of and expertise of local. So all the same criteria actually are here even for Ewing sarcoma. And there are multiple trials. I would not go into that, but there are multiple trials which have been published in that. In Ewing sarcoma, I'll just give you the gist of that maybe in the later. But basically, again, tumor necrosis is an important aspect here. And here, so we even consider 100% tumor necrosis is what, if it's there, then we don't even need to give radiation therapy to these patients. So, like you had Euromos there, we have a Ewing trial, which is the most landmark trial in Ewing sarcoma. And what this showed is that basically compared the VAI, that is the vincristine actinomycin ifosfamide versus vincristine actinomycin cyclophosphamide for broad race patients, and whether the high risk patients benefited with autologous bone marrow transplantation and again to develop therapies for high-risk metastatic disease and evaluate the prognostic factors in this the various translocations in Ewing. So if you can see here, basically the first randomization was after the VID, the initial 6 cycles of chemotherapy, local therapy was given, and this was read. Then post chemo local therapy, the randomization was whether you can give VAI back or you can give VAI as the adjuvant therapy here, whereas here the randomization was between chemotherapy and high dose therapy, that is the autologous transplant, and here this high dose transplant. The high dose was given to all patients of high risk Ewing sarcoma. And this is what it shows. So this is the same one which is depicted here, but this is in the unresectable tumor. What this showed that VAC versus VI, actually the outcome was same. So you don't need to change you can give just VI also. So this same 3-year outcome was there in both the this thing. And here it showed that basically if you have a high risk local disease, that means large tumor volume, less necrosis, they benefit with the autologous transplantation in that group of patients. So that was proven in this trial. Whereas the one which showed that if you had metastatic disease, even doing autologous does not improve the outcome. So you don't need to do autologous transplant in metastatic disease, only in high risk local disease, the autologous transplant helps. And this is a present Ewing study which they have removed VAI, so now they get only back after that, and the high risk localized disease with poor risk, they get the autologous transplant here, and basically this is the metastatic, this is VAI only they get, but very importantly, they have now randomized between zoledronic acid in that. So the data is still under this thing, so we will see after some time that is here. But what they have seen, the first analysis shows that instead of just giving VID chemotherapy upfront, if you give VDC and IE as alternating this thing, the outcomes are better. So this is what is still the full data is not published. And this is again our protocol at Tata where we give doublets. So VI, so instead of giving alternate, we give them in doublets so that increases the tumor intensity. So vincristine, ifosfamide, etoposide, followed by vincristine, doxorubicin, we give that in doublets and followed by the same. Otherwise, the thing is same, surgery or definitive radiation therapy. But you can see here our outcome is as good as what has been published by others. And this is for patients with no metastatic disease and those with metastatic disease. So we have more than 75-80% now outcome in patients with Ewing sarcoma who have localized disease, and even those with metastasis, the outcomes have improved. So this is just to take home message is that VAC is as good as VAI. High dose chemotherapy is beneficial in patients with localized high risk disease. No definitive benefit of doing autologous transplant in metastatic disease or other patients. And the EWS, ETS transcripts are of diagnostic value only, they are not prognostic. And post-op RT, this is most important that has happened is now we have decreased the indication for giving post-op radiation therapy, like what we used to do before. So definitely radiation we are using less now. And so in recurrent disease, lot of studies going on. Various drugs are being tried, topotecan, cyclo combination, irinotecan, temozolomide combination, gemcite, docetaxel. But at present, the data is basically the study is ongoing. We are doing on that, but unlike in in osteosarcoma, patients with recurrent or metastatic disease still they can respond to treatment and they can do well. So we are still working on it, but which one will be best will. Last is we going to palliate. So basically bone marrow plus bone marrow metastasis in Ewing sarcoma outcome is very poor. So especially where you have limited infrastructure, please palliate this patient. Early metastatic relapse, less than 2 years, doesn't do well, palliate them. Unresectable osteosarcoma, primary metastatic. So if you can't remove that tumor, whatever you do, they don't do well. So start palliation upfront only. And recurrent unresectable osteosarcoma, whatever we do, outcomes are poor. So these are certain things where you should not be heroic and to try to treat them. Please palliate this patient. So again, I'll end again with the Homeopathy block. And thank you very much.
And now I'm welcoming my very mentor and teacher, Sir Professor Shailesh Shrikande, who is head of GI surgery at Tata Memorial Hospital, himself being a pancreatic and upper GI surgery by default. And it's also by choice, by choice, because they divided the GI amongst the three of them. So he took the upper GI, and Mahesh Goel took liver and gallbladder, and Saklani took colorectal. So both of them are in the GI surgical division of Tata Memorial Hospital, and he will be discussing with us driving the provision of quality surgical cancer services in Africa through Merck Foundation Fellowship. How many did their surgical fellowship at Tata Memorial? So we are 4 of us here. And tell us more how you want to engage us.
Good morning to all of you. And the best thing I thought of trying to share with you with this kind of a topic that is driving the provision of quality surgical cancer services in Africa through the Merck Foundation Fellowships. I've had the pleasure of having to train some of you in GI surgery at the Tata Memorial Hospital. And I'm sure that you have taken back some points with you which has enabled you to do a better job at whatever you have chosen to do in your circumstances. Having said that, the topic is very vast, and I thought that I should just share with you what we have experienced in Tata in the last 20 years, where we ourselves have continued to grow. If you see Tata Memorial today, it was much different 2 decades ago. At a time when I'm of course much younger to Professor Banavli, but I've joined 22 years ago, and my colleague Dr. Amita Maheshwari has also more or less joined the same time. And we both have ourselves seen a sea change in our own cancer services. So I thought I'm going to first share with you what we have done in India. It might enable you to get some insights as you progress in terms of developing further. And I'm sure then we can have an engaging discussion as to what are the various avenues by which we can collaborate and learn from each other. So when we speak about what's the challenge in India, this is one of the papers published more than 12 years ago. This is like the million death study, but this was a study which looked at the common cancers on the left side in the blue panel and the relatively uncommon but increasing incidence of cancers, which requires more complex multidisciplinary treatment, not just complex surgery. This talk will certainly focus a little bit more about driving surgical quality, but I have ended up choosing a specialty which is digestive cancer surgery, and almost all of them. We have kept stomach here, which is the more common one, but even gastric cancer surgery is complex surgery. So you see for esophagus, stomach, pancreas, liver, gallbladder cancer, a problem unique to India, especially North and Northeastern India, rectal cancer. All these cancers require specialized training and specialized treatment to improve outcomes. We have the same challenges which you perhaps have here, and perhaps your challenges are even a little bit more, but we are not exempt from those. You will see this report which shows what happens when it comes to our demand, which is in blue, and our supply, which is in orange. And this is in 2022 and 2030. So this is the demand, this is the supply, this is the demand, this is the supply. When it comes to comprehensive cancer centers, when it comes to requirement of medical oncologists, Dr. Banavli, I do look after medical oncologists and I care for them. I have the same problem with surgical oncology. I have a big problem with medical physicists. The radiation oncologists are a little bit better, but availability of radiotherapy machines, even in a country like India, India is a low middle income country. I know there would be many countries which are LMIC and low income countries in Africa, but this is what India was for the last 30, 40 years, and it's gradually changing. Now, when we speak of quality, what is quality? If one goes to try and understand what is really quality, there are 3 areas of quality. product improvement, the process improvement, and people-based improvement. And the three pillars of true high quality is integrity, honesty, and courtesy. All this is a part of quality, is what we must understand beyond what we do in cancer treatment. And there are three C's for total quality management. You require a culture, you require a commitment, and you require communication to ensure that there is quality in medicine. And is this me who is talking about it? No. We are talking about a very well-known man who was an eminent scholar and teacher in American academia, and this is Edward Deming. 85% of the reasons for failures are deficiencies in other than the employee. The role of the management, that is we leaders, is to change the process rather than badgering individuals to do better. So if you improve your systems, individuals will gradually start to do better. No two individuals are the same, and no individual is always at the best level to keep on functioning. It's the processes that we need to focus on. So he was the one who is considered to be the father of total quality management. And if you know of Toyota, he's the man who has inspired what is known as the Japanese post-war economic miracle. So when you speak of assembly line or Toyota, it's actually the inspiration is from Edward Deming. Now, the other problem is the Dunning-Kruger effect. The peak of the graph is often called as Mount Stupid. I apologize, but you know what I mean when I show a picture of a, in inverted commas, beautiful lady or whatever. The expert is less confident than the novice. That's wisdom. The expert is paradoxically always a student. We should be remaining grounded on our feet all the time. The dangerous one is the one who thinks they know enough. Sometimes medical oncologists think like that about surgeons, but that's fine. That combination of ignorance and arrogance is only visible from the outside. This lack of total confidence is essential to keep our patients safe. So we don't know, we can keep on learning for the whole of our lives as students of medicine. And it's very essential to know that we are not God, we are just grounded. We need to be good human beings. All this is a part of process excellence and quality in medicine. So a little deviation from a regular talk, but I thought it was relevant for the talk assigned to me. The other part is the quality planning cycle. You need to define what is the opportunity and what are the requirements of the stakeholders. Then you need to design and pilot a service and establish processes. But it's not just good to have a good idea and put a communication on paper or on some nice slides. You need to actually monitor and audit the results and the impact of what you do. And then based on that, once you measure your outputs and outcomes, you need to take action to make sure that you have actually achieved and completed a cycle. Very often we make a mistake of starting off on the greatest of ideas or on a cycle, but we do not complete that cycle, and then we do not really achieve quality the way it is to be defined. And this is the last before I go on to actual gastric cancer, pancreatic cancer, etc. You know, the father and the founder of quality improvement in surgery is Dr. Ernest Codman, 1901. So I'm talking of something which was established 123 years ago. Every hospital should follow every patient long enough to determine whether or not the treatment has been successful. The shorter I follow up after pancreatic cancer, the more I will show you that everybody survives. The longer I follow up, then I really know where I stand. And that's the message here. And then to inquire, if not, why not, with a view to preventing similar failures in the future. I'm a great believer in self-audit. That's the only way to self-improvement. So audit of outcome is more important than the audit of structure and processes. So all of us in our own areas of work, wherever we come from, can keep on constantly improving is what I genuinely feel because others have said so. Now let's look at the impact of surgical training, for example, on rectal cancer. You know that we have got a team, many of you have been in Tata, that we have divided into 3 units so that we can do more and more of less and less in a more focused fashion. Plus we have the volumes. So today you all know of Unit C, which is a colorectal unit led by my colleague, Dr. Saklari. But I must show you this, that what did I write just 12 years ago when I was doing everything from stomach down to rectum, that complications as indicators of quality assurance after 400 consecutive colorectal dissections, the importance of surgeon volume in developing colorectal cancer units in India. The same, I'm sure, is applicable in your varying environments that you come across from Africa. So I had suggested and published that we need to plan and develop dedicated colorectal cancer units. At that time, the only colorectal cancer unit in the country was at CMC Vellore, where I visited in 2004 as a colorectal invited faculty. But soon we realized we needed to move in that direction. And you see the results, what has happened in the last 12 years at Tata Hospital. Do I say this just because I have volumes? No. Look at the example from Scandinavia, always famous for high quality randomized controlled trials, either the Dutch or the Scandinavians, small populations, high levels of education, high levels of technology, and people working together in Norway, Sweden, Finland, all those countries. But what did they show? And this is an old publication, 19 years ago. Before training, permanent stoma 60%, after training 27%. 5-year local recurrence comes down to less than half in the hands of a general surgeon and a specialist colorectal surgeon. Patients also live longer. So you can't say that there is a chance for doing suboptimal surgery in any specialty, not just in rectal cancer surgery. Gastric cancer. I saw that it's one of the commoner cancers in the presentation about the cancer burden in Tanzania. Ignore the complex diagram. The important thing is it's not about removing the stomach. It's also about removing the draining lymph nodes around. But when you remove the stomach, behind the stomach, you have these complex blood vessels from the celiac axis. And that's where gastric cancer drains. So you need to get all these lymph nodes out because radical surgery is the only chance of a cure in gastric cancer as far as a surgeon is concerned. So we did look at this. And this is an example of defining the opportunity. And I give credit to my colleague Parul Shukla, who's now in New York. But we decided that we must standardize gastric resections at Tata. We took experience from Japan, from the National Cancer Center. We started documenting our data. We started looking at how well we do D2 gastrectomy. This is common hepatic artery, left gastric artery, splenic artery. This is a tumor along the left gastric. And then you can see the divided duodenum. The arteries are preserved, the so-called flying bird or Mercedes-Benz sign. Pancreas is safeguarded and the disease is out. So here we started looking at how safely we can do the operation. And in 159 operations, this was the outcome. But the other important outcome was, if me and Parul were assisting some of the more well-known consultants, he's a transplant surgeon in UK. He's one of the finest surgeons that I've seen, a pediatric cancer surgeon. He's an HPB surgeon in Bangalore. All of them, the mortality in the hands of residents and consultants, there was no difference in outcome. So our art and our skill is transferable with proper training is the other message I wish to give you. So it's important to identify the challenge that you face and then put a process, learn, go after it, document it, audit it, and get better. That's the other message that I wish to give. Is this only about surgery? Not at all. Finally, Dr. Banavli will look at me a little happily. That McDonald's published in 2001, that surgery alone, this is the survival. And then perioperative treatment, the survival improves. Yes, we identified that D2 is very important. But then came the magic protocol of perioperative chemotherapy, survival improved. And then further, when you looked at other treatment regimens, especially FLOT, you see that today you will perhaps have close to 50% of gastric cancer patients with chemotherapy and good surgery who have a chance to live for 5 years or longer. But this is world data. I have to tell you what we do in Tata Hospital. And this is where my other medical oncology colleague, Anant Ramaswamy, a young medical oncologist, and this is our whole team, so to say. And there you again see the red line and you will see the blue line. And again, we have shown you that there is a difference of using FLOT. And is that a large study? Anant will of course discuss with you. But I think a total of 593 patients is a large number to tell you that patients are doing better. This is our prospective data despite our high volume work. The excuse given in our countries is often that we have too much of workload and we data entry operators or software. I started off with data on paper. Then I started off till about 2011. I was maintaining my own data on Excel sheets myself on a day-to-day basis. That's the only way to do it. Don't expect the systems to change. You change and the systems around you start changing. Today, there is SPSS, there are more fellows, there are more people, there are data entry operators. The data starts to come in from everywhere. Everyone wants one hospital comprehensive database recording system where you click a button and you get all the data. This doesn't happen in Japan. This doesn't happen in Germany. This happens nowhere. We need to do that extra effort, and then we start getting the necessary results. The end result of that, the ABC story was gradually developing. There was one single team, 56 gastrectomies a year. The team got divided into two, with the colorectal team gradually coming up close to 100 gastrectomies a year. And now just 3 consultant surgeons, we do about 156 radical, but that number is even more. And yes, this is, I don't boast, but I share with you what I did not expect when I joined as a consultant in 2002, that this is what we published thanks to having data with us and learning what we have done. This is purely surgical, where you will see what has happened, that our mortality, despite more complexity as a surgeon. Now, this is a quality indicator. This is also a quality indicator with more surgeons operating, more people getting trained. But the biggest outcome is also what we want. It's not about our skills. It's about making people live long in a meaningful way when they get the bad news of a cancer like a gastric cancer. So this is what we have done. Moving on, can I get 10 minutes more? Is that okay? Do I have Dr. Larry? Thank you. So this is what I learned as far as pancreatic surgery is concerned in Heidelberg. Pancreatic surgery, you can see what they said in New York in 1986. Congress should pass a law making it illegal to do a Whipple's operation because it's considered to be high morbidity and high mortality. There have also been surgeons who have said in the 70s that Whipple's is a beautiful operation without an indication. We must understand that these are things when I was, in school. So it's not 100 years ago, it is now. But what did I learn? That if you have a fistula, the chances of hemorrhage increases and 4 out of 10 people are going to die. Now, this is a direct technical effort. Your efforts, your skill and understanding the tumor, the patient, the center, and the surgical team. 4 things matter for good outcomes. So the one thought was train with a master surgeon. And there are master surgeons all over the world in different environments. I was fortunate enough to be in Germany. And this is one way of cutting the pancreas, joining it back. And this is not a technical lecture. I will go beyond that. Again, what did I learn from my master? He has been to Tata Memorial, Marcus Pupila, one of the foremost pancreatic surgeons in the world. I had coffee with him in a meeting in Chennai. He was a busy man then, and I was a young surgeon, just getting appointed in Tata a year before. He said, people don't come to listen to your talk about how well you have studied Medscape and PubMed and present data. That can be done on computers. They don't need you. If they call you as an expert, they call you because they want to know what do you do. So just now, just collect your data, do your first operation well, do your 10th operation well, do your 100th operation well, and then after 100, you publish, and then people start to know who you are and what do you do. So I started in 2002, and I published in 2008 a series of 123 standardized anastomosis, thanks to standardizing, documenting, and then publishing. The mortality rate in Tata or 6.3 came to 3.2. Yes, there is a selection bias. We would choose the simple cases. We are less confident surgeons. If you take the simplest of cases, you will always have the best outcomes. But that was the beginning. Similarly, the way we have excelled in different specialties. So head and neck surgery, you can see the kind of service we have, the education we have, and the opportunities we have, including observers, which are national and international, and dedicated oncology trainings. I'll keep a part of my talk for the Merck fellowships in terms of what more Merck should do or can be done. And I also want to hear from you so that we convey that to Merck as well. Research should not be left out, and it's not just the domain of researchers in the lab. We have to be clinical researchers as well. With simpler studies and more complex studies, it's a gradual process. Unless you publish a C category paper, you will not publish a C plus. Unless you don't publish a C plus, you will not publish a B plus. Unless you're a genius, then you publish A category papers on day one. But that's a small number of population. Most of us are ordinary people who need time to think, plan, and then execute a research project. But here, Professor De Cruz, one of the foremost head neck surgeons in Tata Memorial, along with the whole team, you find our director, Dr. Badwe, the present director, Sudeep Gupta. So many of these names you would know, those who are in head neck surgery, that they published this trial in New England Journal of Medicine, investigator-initiated clinical randomized controlled trial. Breast cancer service, same. I'm not going to get into details. This presentation, I will leave it here for all of you to take it. So do not worry, but we have an extensive quality control as well as volumes and variety in breast cancer, head and neck cancer. You can see the kind of surgeries that we do, both minimal access and open, for esophageal, mediastinal masses, lung cancer. Smoking is a big problem in India as well. Urology cancers is also the same. 30% of surgeries today are done endoscopic, laparoscopic, and also means that 70% are done open. And open surgery is not to be viewed as bad surgery. It's very fashionable, and surgeons almost start to become embarrassed to say that they do open surgery. Please don't feel embarrassed. This is not some beauty contest here. There is no cosmetic surgery here. Making people who are really ill well with true evidence of benefit is very uncommon in endoscopic and laparoscopic and robotic surgeries. Plus, it's expensive. If it's expensive even for India, I'm sure it can't be cheap for you in Africa. But the principles of surgery do not change. I don't want to kind of take a high moral ground, but we can't change principles, and there are no shortcuts to good quality surgery. So please do not take the risk of taking shortcut because you are under pressure of industry, hospitals, colleagues to start doing endoscopic, laparoscopic robotic. You can do it well, you are trained well, it's economically viable, please do it. I'm not an anti-minimal invasive surgeon, but let's first be good human beings if we want to ensure good quality. Dr. Banavli just now gave a great lecture, and he also showed you many of the other publications. These are some of the surgical publications when it comes to bone and soft tissue cancer. It's a highly specialized disease and a specialized niche area for development. Dr. Amita Maheshwari will anyway speak to you, so I am no one to speak about the fact, but she leads a very dynamic service coupled with education as well as a lot of preventive oncology work as well. Cervical cancer, when I joined Tata Hospital, was one of the dominant common cancers that we saw. But there is a clear, definite decline in 2 decades in cervical cancer. I appreciate that there is a challenge of cervical cancer here as well. I'm sure that you can exchange a lot of notes and learn from each other to see what you can do so that when we are again meeting in 5 and 10 years down the line, we have many more positive stories to hear and exchange with each other. Same thing applies with neurosurgical oncology at Tata Memorial. It has a global leadership role. It's considered to be a center of excellence for training, and we run global courses. So those who are interested, please understand that there are 5 major neurosurgical OTs and a skull-based OT. We have now 4 full-time neurosurgeons. We have worked for perhaps 10. But that's the usual story of Tata Hospital. We need more people because patients are always there. So this is about neurosurgical OT. Now some general philosophy again, which I emphasized before about quality in surgery. This is an example of a complex operation like a Whipple's operation. And we have studied that when you speak about a learning curve, there are two curves. There is a learning curve and there is a proficiency and a mastery curve. People often confuse a learning curve with a mastery curve, not at all. Learning goes on forever. For example, in open Whipple resection, it will take you about 60 operations to reduce your blood loss, to make sure that you do more R0 resections, to make sure your patients go home early. So when you look at that, you actually need to make sure that you standardize your surgical technique that will help you. And there are different learning curves for open, laparoscopic, and robotic pancreatic surgery. I've been a part of this work group. And when you look at learning curves, you please understand what is the minimum information required for a standardized reporting of learning curves, surgeon-specific characteristics, institution, patient, disease, complexity of that pancreatic operation, complexity of that pancreas joining, and the complexity of a left pancreatectomy and not just a right pancreatectomy, which is a Whipple's resection. What am I trying to bring to your notice? Our science is endless. And the more detailed you study, the more you realize how little you know. So have I learned 3 years ago while doing this study? I think I've learned a lot, despite having more than 2 decades of experience in pancreatic surgery. So this is where we are today. And Dr. Larry and some of you have seen us. My friend from Senegal has also seen this, that if you come and spend a week with us in Tata, you will see 5, 6, 7 pancreatic operations, 5, 6, 7 radical gastrectomies, 3, 4, 5 liver and gallbladder operations, and a large number of colorectal operations. Why? Quality surgery in 1 week from a Monday to a Saturday at Tata Hospital. So one can plan well, decide what is required in your environment, and then you plan to come there, whether it's a short-term observership or whether it's for training. It can't be a long-term observership of 3 months and 6 months and 1 year, because if you're already a reasonably good qualified surgeon, no surgeon likes to just observe for too long. That's why I say that you need to plan accordingly. Surgeons finally need to work with their own hands. But plan what is required for your ecosystem so that you don't only go and see something nice. You see something nice, get some new ideas, and come back and get the opportunity to implement. So that way we can plan our time and energies, utilize it to the benefit of your patients and your ecosystems. So when I started out, my Warren Fellowship was in Germany in 2012. You see how there has been a gradual increase in pancreatic resection. 5 new ORs this year. So we are on schedule within 2 months to be reaching 300 pancreatic resections this year. So this makes us one of the highest volume centers in the world for pancreatic surgery. But that's not important. The important is this. And of course, you need people to live longer. It's much more tougher in pancreas cancer as compared to periampullary cancer. And it's much more tougher in pancreas cancer as compared to gastric cancer. But Martin Smith is based in South Africa, the former IHPBA president. When we published 1200, we had shared this with him. So he says, thanks for sharing this. This is remarkable coming out of a middle income country. So he thinks India is middle income, which we are not. And he says, you are a leading light. What I wish to show is, we don't need to be in Europe or America or Japan. We can develop our own systems by working together and get great results. So this is, say, the pancreas journey from 2007 to now. This doesn't happen overnight. Removing veins, arteries. I will talk about it in the afternoon when we speak about unresectable pancreas cancer. I won't talk about it. So far, I spoke to you about Tata, but is that enough? It's not enough. I learned something in Germany. We managed to establish it and over a period of time become a good center. I think the biggest satisfaction is that you have surgeons and doctors who are treated in different parts of the world. And when I get these pictures on Teachers' Day, I've just got another one 2 days ago. With all your guidance, it's not about me, but when someone says that they remembered 1,000 times while doing a pancreas in a small place in Solapur, where this was not being done. Latur, everywhere we have this change. Was this there 2 decades ago? It was not there. I can confidently and happily tell you that. So today you see this change. And this is not about me. It's always about a team. You have all our GI consultants, anesthetists, you have our nutritionists, you have so many people. So we have again our own ERAS team without any funding for a dedicated ERAS nurse. This was done by my anesthesia colleagues. We have dedicated GI anesthesia, and our anesthesia colleagues, 4 of them, have led this protocol, which has also enabled us to improve outcomes. So on one hand, you might feel that I'm talking about centralization, that in 23 years, India had less than 1,000 patients and 17 studies published. And in 11 years, only twice I've published on this subject. We had 36 studies and more than 6,000 patients. Does this mean that we are going to push for centralization? It's a combination of both. On one hand, you centralize and get better. On the other hand, you decentralize when you have so many variations in your countries and your continents. Very similar in Africa. India also lives in different centuries at the same time, not really different. So to be able to do the same operation I learned in Germany, in Vizag, in Varanasi, in Raipur, is trying to address this concept, where I was fortunate enough to work as a part of the Lancet Commission a few years ago. So yes, we train people with live workshops. We operate during COVID. It's good to know that people live long even after doing workshops. You go and exchange and teach even in the advanced West. But it's important that you create tumor boards, you have national guidelines, and you operate in your place and have a video connectivity. That's where technology has made our life much more easier. You operate in your and you can have video connectivity, something that we can again engage in. Are the problems solved with this? Not at all. These are the problems which face India today. We still have 25% illiteracy. So it's not that we should just be a part of a good process, is what I'm trying to share with you. I stop. This is what our Prime Minister has been doing. This is our hospital in Varanasi. Dr. Banavdi showed you the Homi Baba block and the current one, but I can show you, does this video play? This video doesn't play. But this will be another new hospital across the Homi Baba block, which you will see in 2027 for 5 specialized disease management groups. I've had the privilege and honor to lead this project, and hopefully many of you will also get to see another state-of-the-art center built by the government of India. We lost Mr. Tata. I'm sure you all know who he was, a great philanthropist and a great businessman, but a businessman with a heart, which is not so common. And that's why he was so well known. He built this hospital in 9 months and then handed it over to the government to operate. So it's now our hospital, but the entire hospital was built by his company in 9 months. So I stop here, and anybody is welcome to visit us. And also we will have an interaction whenever there is time for questions. Thank you.
So with that, I'm just reminding you that refreshments are absent, and we are moving on with our next presenter, who is going to be Dr.
Just open the
De-
presentation and
Debabrata
which button?
Bamon, who is a professor in the Department of Gynecologic Oncology at the Borough Center Institute, a unit of TMC, Mumbai, India. He will be discussing the topic fertility preservation in the management of gynecological cancers, the concerns and solutions. So welcome, Dr. Bamon.
So, thank you very much. So, since we are already going behind time, so I'll start with my presentation. So, thank you for giving me this opportunity. So, how many of you are working in gynae oncology or for the gynecology of cancer? So, I had 4 of them. Oh, yes. Yeah. Okay. So, okay. So, basically, I'll be talking on fertility preservation in the management of hereditary gynecological cancer. So, what are the concerns and how we can solve those problems? So, as you all know, that this hereditary gynecological cancer is coming up in a big way. All the countries around the world are now looking at it. So if you see the worldwide, it's more prominent in the Western countries, but in a country like India, we have our data where we have seen around 15 to 20% of our cancers, the gynecological cancers, are hereditary. And I don't know whether you have any data in the African countries. I do not find that, but then it should be around 20%. The hereditary cancer that is common all over the world. So now, if you see the path that is traveled in the, so if you see any young patient coming to you with gynecological cancer, so what thing we do? We look at the family history. So that's the number one step which we do, because every patient, we cannot just go on writing those tests. The heredity tests, which are not found in all over the places. And so that's the first thing we do, look at the family and we try to find out who are the patients who we actually want to order this test. So once we identify those patients, then we sit with the family, and there's a thing called the pre-test counseling. We do the counseling and we discuss with them what we are thinking about their cancer and what test we are going to do and how this test may affect the future of this, the future screening protocol or any risk-reducing procedure that we can do for them, all these things. And then we order the test. Once these tests are ordered, the results come. Again, if these results are positive, then we again have to sit back at the post-test counseling, and then finally we discuss with them what else to be done for this group of patients. So now, once the tests are done, there will be two groups. One is the patient who is affected, what has to be done for them, and those who are their first degree relative or their close relatives, for them, what has to be done. So now, you can see for those women who are affected and if the test results comes out with positive, for them the screening is different. And also there are some reproductive and lifestyle modifications for this group of patients. We talk about chemo prevention, whether it is really helpful, and for the other effects that can produce if we start this chemo prevention, and some risk-reducing surgery in the form of risk-reducing mastectomy, risk-reducing salpingo-oophorectomy, or total hysterectomy, bilateral salpingo-oophorectomy, and also some fertility techniques like the PND and PGT, which I'll be discussing in the later part of the presentation. So these are already told, around 15 to 20% of all the gynecological cancer are hereditary at present. So basically, inherited pathologic variants that are associated with gynecological cancer are particularly unique because they may require interventions that interrupt the normal reproductive function, including hormone production and family. So now, what are these concerns? So as I've already told, to do this cancer prevention activity, so we need to start some chemoprophylaxis for this group of women for some particular cancers. We may have to go for these risk-reducing surgeries. They are concerned about the future fertility. Once we perform the risk-reducing surgeries, maybe salpingo-oophorectomy perform, then what will be their fertility concern, future fertility? We need to take care of those problems. Then all these are generally autosomal dominant. So 50% of their offspring will be affected by this pathogenic variant. So they are concerned about that. How we take care of that? Then potential use of hormone therapy. Once we perform the oophorectomy at a very young age, now we need to give them hormone support. So is there any problem when we start the hormone support for them? So the purpose of this talk is to highlight the reproductive and hormonal consequences that women who are at high risk of developing a gynecological cancer face, and to unite efforts of the gynecology, oncology, and reproductive medicine specialists. Basically, we have to have a bridge between the gynecology, oncologist, and the infertility reproductive specialist to solve this problem. So this is basically when we are taking care of this familial cancer problem, we need to have a very close contact or keep a rapport with our fertility specialist, and we should not start this treatment alone. They should be in the loop. Okay. So now, the concerns, as I've already told, all these are the concerns. So let us discuss one by one. So now we know that oral contraceptive pill has shown to reduce the risk of ovarian cancer by approximately half in women at average risk of this about the general population. But what happens to those women who carry this pathogenic variant in the form of BRCA1, BRCA2? There was a study, they have shown that the protective effect of oral contraceptive pills increases with duration of use in this group of population also. So now, what any woman with a gynecological, hereditary gynecological cancer or not, OCP we know has got a protective effect on the ovarian cancer reduction. At the same time, we have been hearing that whether it has an effect on the breast cancer, there are reports which have shown that there is increased incidence of breast cancer if you give OCP. So you see this meta-analysis was based on 2,855 breast and 1,503 ovarian cancer cases with BRCA1 and BRCA2 mutation. They have found no evidence of significant increased breast cancer risk in OC users overall for recent formulation of OC in the first 10 years after situation. Another data where they have shown slightly higher increased risk of the recent use of oral contraceptive pills for breast cancer. So we have data supporting both. One says there is no here, other publication, other study have shown that it has some increased risk of breast cancer. So safety of OCP use with regard to the development of breast cancer in BRCA mutation area is not entirely clear. But ovarian cancer is clear. So OCP can be used to reduce the risk of ovarian cancer in BRCA1, BRCA2 mutation area without a personal history of breast cancer. If there is no personal history of breast cancer, then OCP you can use. Then chemoprophylaxis and Lynch syndrome. This is another hereditary cancer. We know that endometrial cancer comes in the Lynch category for us, gynecological cancer, apart from the colonic cancer. So what is the evidence? So there are conflicting reports here. There is no solid evidence in Lynch syndrome. We know that progesterone decreases the incidence of endometrial cancer. It has been tried in early endometrial cancer also to reduce as a part of treatment. But its effect in the Lynch syndrome is coming. Okay. So now, this is another study, the NOAC study, but they have also concluded in the this is also a population-based prospective cohort study, where the ever users of LNG IUS, basically intrauterine device, has strongly reduced the risk of ovarian cancer and endometrial cancer compared to never user with no increased risk of breast cancer. Although they have said this, so as of now, we are not using progesterone as a risk-reducing initiative. What is a management? So now another thing that is used for this Lynch syndrome is the aspirin. We know that aspirin reduces the risk of colonic cancer. That is known. When this CAP2 trial came initially, they showed that it had some impact on the endometrial cancer in reducing the endometrial cancer. But the follow-up data, which came a 10-year follow-up data, which was published in 2020, they showed that in the intention to treat per protocol analysis, the aspirin have no role in reducing endometrial cancer, but it has definitely has a role in reducing the colorectal cancer. Okay? So for in Lynch, there is no role of hormonal. So what we see that limited data on actual reduction in the risk of endometrial cancer in this group of population. Okay, for progesterone. So what we can do is that we should consider hysterectomy, bilateral salpingo-oophorectomy in and around 40 years of age, or whenever they have completed the family. One thing is that before doing the hysterectomy, do a pre-operative endometrial biopsy. Okay, so now risk-reducing surgery. So what are the defined risk-reducing surgery as far as gynecological cancer is concerned? You see, whenever you think of ovarian cancer, we know that BRCA1 is one of the important carrier status. So whenever a woman will be detected with BRCA1 positive, so we should perform the risk-reducing salpingo-oophorectomy by 35 to 45 days. If she is BRCA2 carrier, we should perform the risk-reducing surgery by salpingo-oophorectomy by 40 to 45 years. And other genetic mutations in the form of RAD51C, RAD51D, BRIP1, by 45 to 50 years, we should complete the risk-reducing salpingo-oophorectomy. And other HRD where the risk is more than 5%, then you should do in and around 45 to 50 years. So if you see, if you do the risk-reducing salpingo-oophorectomy in BRCA1 carriers, it reduces the incidence of ovarian cancer, there is no doubt, but then it reduces the incidence of breast cancer by 56%. And if she is a BRCA2, then it reduces the chances of breast cancer by 42%. Okay, so performing this risk-reducing salpingo-oophorectomy can reduce the ovarian cancer by 96%, not 100%. Around 4% of the patient may still have peritoneal carcinoma. So that should be kept in mind. Patient should not be told that I'll do a receiving salpingoprectomy at a young age and she should be 100% safe, but not that. 96% you can reduce. So patient without reducing salpingoprectomy, you know now she's carrier of BRCA1, BRCA2. She doesn't want to do the reducing salpingoprectomy. In those cases, PVS CA-125 may be considered at the clinician's discretion starting at age 30 to 35 years. She is ready to undergo those procedures. So, another important, suppose you are doing a risk-reducing salpingoprectomy, studies have shown that in those salpingoprectomy specimens, up to 10% there is a chance of occult gynecological cancer. So, important thing is that when you are doing this procedure, first thing is that procedure should be done correctly. What is the procedure? The thing is that you should take a peritoneal washing before starting the procedure actual. Then entire ovary, fallopian tube with surrounding peritoneum should be removed when you are doing this procedure. And the IP should be ligated 2 centimeters from the insertion of the ovary. Okay, so these are the 3 steps that should be done. And then once I have already told that occult gynecological neoplasia were identified in up to 4 to 9% of the cases. So all these specimens, particularly you have to write that they have to be examined following the CFM protocol. Those who are pathologists, they will know. So you should also know that you should particularly mention that it should be examined following the CFM protocol. I'll come to the next one. So you perform this procedure, you send to the pathologist, ordering that this is the protocol that should follow while reporting, and you should tell the patient that I'm performing this surgery, but it's not 100% here, 96%. It is but 4% there will be a chance of doing this, of getting a peritoneal carcinoma even after this procedure. So the concern, occult underlying ovarian cancer has been identified in pathology specimen from risk-reducing salpingoprectomy procedure up to 10%. This woman may have neoplasia. So what is the solution? I have already told pathologists should section the ovaries and fallopian tube serially at 2 mm interval using the CFM protocol. So that is important. Okay, so this is important. Now, is hormone replacement therapy safe in ovarian BRCA mutation? A systemic review of the contemporary literature, they have suggested that risk of subsequent cancer diagnosis appears small, particularly in regard to benefits of treatment. So, if you remove the bilateral salpingoprectomy is done, whether it can be done in ovarian cancer, sometimes they can do, but in endometrial cancer, recommended. We try to avoid the hormone therapy in this group of patients. So, this reducing salpingoprectomy, which is a sequelae of surgical menopause, and this woman will come to you with complaints of vasomotor symptom, osteoporosis, decreased libido, symptoms of vaginal atrophy and cardiovascular disease. So in selected patients, you can start with hormone therapy, but non-hormonal treatment strategies like SSRI, alpha-2 adrenergic agonist, dietary and lifestyle modifications, and alternative medicine approaches find hormone therapy is contraindicated. And sometimes you have to do individualized treatment based on case-to-case basis. Hysterectomy may be considered to simplify and lower the risk of post-op hormone therapy, allowing replacement of estrogen only instead of E plus T. Okay. So now, there is again, people are now trying with salpingectomy, keeping the ovary, and at a later date, you do salpingoprectomy. So does that decrease breast cancer risk? But bilateral salpingectomy only is encouraged to undergo. Ultimately, they have to tell that ultimately they have to remove the ovary. For the time being, they can remove they can just remove the bilateral tube. So the use of salpingectomy followed by delayed oophorectomy is now under investigation. There are 3-4 trials which are currently undergoing: the WISP, the Protector, and the Sorok trial and the Tuber trial. These things. I think one result has come now. So now the risk-reducing surgeries, as far as the Lynch syndrome is concerned. So we know in the Lynch syndrome, colorectal cancer mostly affected. They get colorectal cancer, then endometrial cancer, and also some few women will get ovarian cancer in this group of patients. So what are the risk-reducing strategies? For colonic cancer, we have the colonoscopy, which has to be done. from 20 to 25 years onwards every year or biannually 2 to 5 years prior to the youngest affected member in their family. For endometrial cancer, initially you can give them the awareness of abnormal uterine bleeding, then TBS plus minus endometrial biopsy every year or biannually from 30 onwards. And once the family is completed, you can they can be asked to undergo the hysterectomy based on their MMR. For ovarian cancer, as I already told, bilateral salpingo-oophorectomy and it has to be individualized place-to-place basis, and estrogen replacement therapy is same. So, for this reducing strategy, for this syndrome, total hysterectomy plus bilateral salpingo-oophorectomy at the completion of childbearing. So they may get this premature menopause. So especially we try to do this at around 40 years of age, but the exact age has to be determined based on the additional factors, including menopausal status, comorbidities, and systemic genetic mutations. Future childbearing options. So if we perform this reducing salpingo-oophorectomy, now you have to tell them this some of the women may not have any children. So what you need to do? So there comes the role of this fertility specialist. Nowadays, there are options where you can preserve the oocyte, or if they are married, you can preserve the embryo. So this oocyte and embryo cryopreservation can be done, which can be used later on. Okay. So then there is some controversial data on diminished ovarian reserve and response to stimulation in BRCA1, BRCA2 mutation carrier. In those patients, that's why they say that if you give them chemotherapy, then after that sometimes the ovarian reserve goes down and you don't have any ovum or ovum left. So in those patients also, you can go ahead and do the oocyte and embryo cryopreservation for this group of patients. Then again, there are some reports where they have said that mutation carriers diagnosed with cancer that require chemotherapy may be at risk of experiencing treatment-related infertility and premature ovarian insufficiency or menopause. So sometimes GnRH analog is used with chemotherapy. Okay, that is what. Then again, there are concerns that affect the high estradiol levels that are generated during ovarian stimulation on cancer risk. Fortunately, the use of fertility medication does not appear to increase the risk of breast cancer in breast cancer patients or BRCA mutation carriers. Nevertheless, the solution is that the effort should be made to minimize the rise of estradiol level by using aromatase inhibitor. We use letrozole plus gonadotropin stimulation protocol, which results in estradiol level that are physiological. So the additional options for parenthood, if you see options for women with risk-reducing salpingo-oophorectomy, if a woman has cryopreserved her oocyte or embryo, if she is married, prior to risk-reducing salpingo-oophorectomy, pregnancy can be achieved by hormonally priming her uterus and performing an embryo transfer, maybe time. Okay. And if the woman does not have her own oocyte or embryos available to her, then you can consider using a donor oocyte or donor embryo or partial adoption. In those group of patients who had a hysterectomy, in those patients, you need a gestational carrier or the surrogate mother, whatever you say, and uterine transplantation, which may not be feasible in countries like India or very difficult to find. Now, another problem which is found in this group of patients is that these are all, these are autosomal dominant. So 50% of their offspring will be affected by this pathogenic variant. So they are always concerned whether I am transmitting my condition to my future, to my offspring. So these are the concerns. Now, how to solve this problem? So now we have this procedure of doing a PGT or PNGT. I'll tell you. So PGT allows identification of embryos that are both euploid or unaffected, non-pathogenic carrier. You select those and then you transfer. The thing is that you need IVF. Even if she is fertile, you cannot do it. You have to do IVF procedure in this. And prenatal genetic testing, I'll just complete. Okay, so the pre-implantation genetic testing, PGT, what you do in the 1 or 2 cell from the embryos in early stage of development, 6 to 8 weeks, to take out, you biopsy these cells and select only those cells which are unaffected, those ovum. and then you do the IVF and transfer. So even if she is fertile, IVF is must. Okay. Then you can select those. Then this concern is taken care of. So all our offsprings will have the normal DNA without any genetic pathogenic variants. Other one is suppose she has come to you and she is already pregnant. So in this group of patients, early embryo chorionic villi or amniotic fluid at 16 to 12 to 16 weeks of gestation, it has to be done, centrifuged, cultured, and if the test has to be performed on the cultured cell, and analysis has to be done, DNA analysis, and then if it is found that that child is a carrier, then you discuss with that, with the patient, what has to be done. MTP consent, maybe they can give for MTP consent. So ultimately, so all these things, as I've already told, 50% chance of transmission. So there are a lot of concerns. Ethically, culturally, may not be acceptable for all the women all over the world. So all these socioeconomic factors will be there. So ultimately, you have to sit, discuss with the attendant, and take a final call how to tackle with this group of patients. So if you see, it is basically a bridge between the gynecologic oncologist and the fertility specialist. You need to know why you need to refer these patients to your reproductive specialist colleague, and then what they need to tell to this patient, what are the options that we can help, how we can help them from our end, and how our reproductive specialist can help this woman. Ultimately, with this coordination, we can solve a lot of these concerns which are facing in this group of patients. Thank you so much.
Yeah, thank you, sir, for the enlightening presentation. Happy to inform you that we have the first bovine sperm bank in Tanzania at an IVF center for the first time. Now, may I welcome Amita Meshwari to come and give us a talk on surgical management of cervical cancer. Amita, as was introduced already by Shailesh, has been at Tata Memorial for 22 years plus, maybe. She's professor and head of division of gynecology at Tata Memorial Hospital in Mumbai.
Okay, so a very good afternoon. Actually, yesterday whole day I practiced speaking good morning in Swahili, but I realize it's of no use. So good afternoon again, because we are really late. Okay, so anyways, that's how life is. So thank you very much, Merck Foundation and Dr. Banavali, to have me here, and also giving the opportunity to meet some of old friends. We met some of them last year, and a few are here this year also. So thank you so much. Let me start my presentation with a clinical scenario. We are all, just to activate your gray matter. A young lady with irregular vaginal bleeding, pelvic examination showed a cervical mass. Clinically on examination, vagina, parametria, everything was free. The biopsy was done and it's squamous cell carcinoma. So you just think about how would you manage such a patient in your setup, and how will you further investigate her. Meanwhile, I'll take you through some important issues pertaining to surgical management of cervical cancer. So how do we do pre-treatment workup? What's the current FIGO staging? How do we stage these patients prior to surgery? What are basic principles of management of cervical cancer? What's the standard surgical procedure, and some of recent advances? I'll just give you a brief overview. So we know that cervical cancer is a leading cause globally. It's the fourth most common cancer in women worldwide. And we also know there is a great heterogeneity in the incidence of cervical cancer. It's largely a disease of LMIC, developing nations. And you can see the heat map, the areas where it is more prevalent, essentially African and Asian countries. So we also seen these statistics that in your country, it is the first or the most common cancer in women. If you see overall, like 45,000, and cervical cancer is more than 10,000. So a substantial proportion of actually cancer incidences by cervical cancer. In India, trend is changing. And we have breast cancer, the most common cancer. Cervical cancer is coming down. Also, breast cancer is increasing. So both these factors are responsible for shift in the incidence of or the prevalence of these cancers in our country. So the other question I was thinking, why cervical cancer suddenly has, increased in your country? Could it be because of more awareness and recently started screening methods so that you are picking up more cases? Possibility it was always there in many patients, you were not able to detect it. We know that cervical cancer is caused by certain high-risk types of human papilloma virus. We also know that it is the most preventable cancer. But we also have to remember percentage of cervical cancer are not because of HPV, and especially in adenocarcinoma. So if you have pathologists and if you have facilities, tell pathologists to tell whether adenocarcinoma is HPV associated or independent, because HPV independent cancers have worse outcome than HPV associated. This is very important to know the natural history of cervical cancer, right from HPV infection to the development of precancerous lesion. Extremely important, and Dr. Debrat will cover precancerous lesion in the second lecture. And this also important because when we do screening, we should know which stage of the disease we are trying to pick up. We have HPV-based screening test, which has high sensitivity because it can pick up right from infection to development of cancer. Although it has low specificity because most of the cancer infections are, self-limiting. They do not lead to development of cancer. But if you want a sensitive test, HPV-based screening is the most sensitive. If you want more specific test, it is cytology or VIA-based test. Coming to once you have suspected a cancer, cervical cancer in a lady, what next? So the most important thing to confirm the diagnosis by biopsy. If an overt growth is seen, it's simple. You take a punch biopsy from the most viable looking area. Don't take it from necrotic tissue and send it to pathologist. But if it is a screen detected case where you do not have any lesions seen on the cervix, the way is to do a colposcopic examination. So colposcope is nothing but it's kind of a telescope where you visualize cervix under magnification with the use of certain reagents like acetic acid and Lugol's iodine. And I'm sure Dr. Debrat again will tell a little more about this. So that's how an abnormal colposcopy will look. You can see a lot of abnormal vascularity, some crypt opening, and this is definite an indication to take a biopsy. So if it's invasive cancer on biopsy, what next? Like you are patient, we have reached up to the diagnosis of squamous cell carcinoma. What next we will do? We will do further evaluation. We need to do blood tests, including complete blood count, liver function test, renal function test. In our setup, we always do viral markers, including hepatitis B, C, and HIV test. But I was surprised to know, despite having very high prevalence of HIV in your country, you all don't routinely do HIV for preoperative testing, which is little unusual, but we always do viral marker testing after obtaining consent from the patient. We also need to do some form of imaging. So depending upon facility available, the ideal would be a MRI test if available, if not a good quality contrast CT. If that is also not there, even a good clinical examination and ultrasound also good enough. And that's as per FIGO recommendation. PET CT doesn't have much to play, role to play in early stages. It may be useful in advanced stages, but it is not mandatory for the treatment of cervical cancer. Now, if you are in doubt, do examination under anesthesia. Cystoscopy, proctoscopy, only if you suspect these organs to be involved clinically. A routine test for bladder or rectal involvement not required. So after you have done completed investigations and workup, the next is we want to stage. So important to remember that cervical cancer is still clinically staged disease. We do not do surgical staging. However, the most recent FIGO staging update 2018, it allows certain imaging and pathological features to change the stage, which was not there in previous staging. So I think I won't spend much time here, but just to tell you, stage 1 is when disease is confined to the cervix, which is further subdivided in various substages based on the size of tumor. So stage 1A is essentially microscopic disease, screen detected, we take a biopsy, then diagnosed. And stage 1B is when gross lesion is seen and further divided based on size in 1B1, 1B2, and 1B3. So here tumor size is important. And stage 2 onwards are advanced stages of disease. So what's important is that lymph node involvement has been included in staging, and if nodes are positive, despite the lesion being confined to the cervix, stage becomes stage 3. It's no more stage 1 disease. So either on radiology or on FNAC or on biopsy, if nodes are positive, it upstages the disease to stage 3. Let me give you a brief overview. How do we manage cervical cancer? So all stages, right from stage 1 to stage 4, early 4A, can be treated by radiation therapy. And it was good to know that you have many radiation units available, and many have been installed recently. And for cervical cancer, radiation is a combination of external and brachytherapy. So brachytherapy is extremely important, which I understand only 2 units are there in the entire country. Surgery is possible only for early stage disease, essentially disease which is confined to the cervix and a small volume disease. Even in these patients, surgery and radiation give similar results, where you can treat even early stage disease with radiation therapy. But surgery has certain advantages. I'm not saying that because I'm a surgeon, but these are known advantages. So you get tissue for histopathological assessment. Complications of surgery are usually acute and easy to manage, as opposed to long-term complications of radiation therapy. One can preserve ovaries in a young patient if you are doing surgery, and sexual quality of life is better with surgery. And cervical cancer is a disease of relatively younger women. The median age is 44 years. So all, lower 2 points are important for quality of life of these patients. What is extremely important after your surgery, you have to have a good histopathologist. And these are the minimum parameters which a pathologist must give in the histopathology report, because based on these reports, you will decide whether after radical surgery, patient needs any additional treatment or not. So patients, if nodes are positive, or if disease is in parametria or vaginal cut margin is positive, patients are at increased risk of developing a recurrent disease without any additional treatment. So these patients, we give combination of chemotherapy and radiation therapy. Patients who have more than bigger lesions, deep stromal invasion, or lymph vascular space positive, 2 out of 3, adjuvant radiation therapy. And if none of these factors are positive, then only we keep these patients on observation without any additional treatment. So this is extremely important. You have done a wonderful surgery, but if any poor prognostic factor is present, then patient would require adjuvant treatment, without which the risk of relapse is very high. So that's another, brings to third very important principle of management. Whenever you suspect pre-operatively or pre-treatment assessment says that patient might require additional treatment because size is big, or there is deep stromal invasion, or there are suspicious lymph nodes, it is better not to offer them surgery, treat them by radiation therapy with chemotherapy. Because when we do surgery and then give radiation therapy, complication rates are very high, and there is no added survival benefit of doing 3 modality treatment. So cervical cancer that way is quite unique. There is no point doing surgery and giving radiation. Equal survivals are obtained with less morbidity when we do concurrent chemoradiation. I don't know if there are radiation oncologists here. I'm really talking. So in big lesions, good. So if it's a big lesion, this is debatable, but if you have good radiation facility, we would do radiation. The next question is, how much tumor do we remove? What should be the extent of surgery? I said we do surgery for very, very early stage. You would wonder then why to do radical surgery when you are. So it's based on the basic principle of any cancer surgery where you want to remove central lesion with normal surrounding margins, thinking there may be some microscopic spread which you can't see. So in case of cervix, surrounding margins would be parametrial tissue, vagina, and uterus. And along with that, we also remove draining lymph node. So there is little bit tailoring of surgery which we can do based on stage of disease. It's not that every patient we remove surrounding tissue. So if it is very early stage, we can do simple hysterectomy, but if anything more than that, we need to remove surrounding tissue to take care of microscopic disease. So these are various classes of radical hysterectomy which have been defined in the literature. This is in real life. So when we just remove cervix with little bit of surrounding tissue is class 1. When we remove medial part of parametrial tissue, now I understand most of you are not gynecologists, but surrounding tissue, the cervix is known as parametria. When we remove medial half, it is class 2, and when we remove more, it is class 3. And lymphadenectomy is an important component, like surgery for any other cancer sites, because cervical cancer especially has higher propensity for nodal metastasis. Can I play the video? It's not playing. No, he has to come. Where's that boy? Okay, so let him come, and I'll come. If I have time, I'll show the surgical video, how we do a radical hysterectomy. A well done, well managed patients with early stage have excellent survival, more than 85%, but there can be a lot of complications during surgery or post-operatively. And the major concern is most intraoperative and post-operative complications can be managed well. But most important thing is late complications, especially bladder, bowel, and sexual dysfunctions. And these are related to injury to autonomic nerves to bladder, bowel, which run in close proximity to parametrial tissue. Can you play the video here? This video is not seen as video. No, the previous one. Yeah, I think that's the only way. Maybe I'll show a video at the end of my presentation so that, I'll close the presentation. And so, there is a major change in the philosophy of management of cancers in general. And that's because we have realized with improved survival, quality of life of survivors is extremely important. So as a surgeon, how much we remove is important, but how much we leave behind and how much organ and for function preservation we are able to offer to patient is extremely important, because we have realized that quality of life of survivors is as important as quantity of life. So as a result of this, there are certain surgical nuances in the management of cervical cancer. Some of these I will just, give you a brief overview. So nerve sparing radical hysterectomy to prevent injury to autonomic nerves, sentinel lymph node biopsy to avoid complications associated with the extensive lymphadenectomy, neoadjuvant chemotherapy before surgery to make patients who have large disease to make them operable, fertility preserving surgery, and role of MIS. So nerve sparing is essentially autonomic nerves which run in close association of parametrial tissue are preserved. So when we do a conventional hysterectomy, we take the whole thing, and these nerves are in this. I don't think it's working. Yeah. So in lateral part of parametrial tissue and deeper part of uterosacral and mesenteric ligament, autonomic nerves which supply to bladder and bowel, they run in this area. In conventional hysterectomy, we remove them, but in nerve sparing, we preserve them. So we identify each of them and preserve these nerves. The other big complication is associated with lymphadenectomy. It can be, intraoperative complications because we operate very close to nerve and blood vessels. So there can be injury during surgery, but what is more important is post-operative complications, especially limb edema. I don't know how many of you have experienced this, seen in your patient, but after extensive lymphadenectomy, there can be edema of lower limb. And what's also important, the kind of patients we operate, the incidence of nodal metastasis is pretty low, less than 20%. So in order to balance and avoid extensive lymphadenectomy, the concept of sentinel lymph node, which has been extensively studied in breast cancer, has also been extrapolated to cervical cancer. And we know there are various ways to pick up these sentinel node, blue dye, radioisotope technique, or a combination. And more recently, we have indocyanine green, which requires near infrared fluorescence imaging, little expensive one. So I'm sure this video will also not play. Okay, so the third point is, can we give neoadjuvant chemotherapy to make patients who have advanced disease like stage early 2B or stage 2A disease, so that tumor becomes small and we operate like the way Dr. Srikhande described. Dr. Banavli also said that in certain cancers, neoadjuvant chemotherapy is the standard of care. So the same thing we thought whether it will work in cervical cancer. In fact, we did a large randomized trial at our center where we randomized patients with stage 1B2, that means more than 4 centimeter tumor or little bit parametrial involvement or vaginal involvement, who were not upfront surgery. We gave them 3 cycles of chemotherapy and then, randomized to either they were randomized to 3 cycles of chemotherapy surgery versus concurrent chemoradiation, which is the current standard of care in these patients. And to our disappointment as a surgeon, what these trials results showed that actually chemoradiation is superior in terms of disease-free survival in these patients, but there was no difference in overall survival. So how we took this, that standard of care remains concurrent chemoradiation. However, I just have a thought here, if in countries where radiation facilities are not there, especially if you do not have good quality brachytherapy, or if you have limited brachytherapy access, as in your country, there may be a case, and if you have surgeons who can operate, there may be a case giving neoadjuvant chemotherapy to these patients who are borderline operable, to downsize the tumor and then do surgery. But if you have, of course, good quality radiation oncologists and radiation facilities, patients who can take concurrent chemoradiation, that's the standard of care. But this can be considered as an alternative, because there was a bit about fertility preservation surgery. Just suffice to say that there is a way to preserve fertility. In India, actually, majority patients complete their fertility quite early, and we actually don't see, in cervical cancer patients, the need for fertility preservation. But if you have such a patient, if it's very early disease, there is a way to preserve fertility or the uterus. A young patient, otherwise fertile, desirous of fertility, and lymph nodes are negative, we can do what is known as radical trachelectomy. That means we are just removing cervix, upper vagina, cervical tissue, and lymph nodes without removing the body of the uterus. And this can be done taking a vaginal route or abdominal. So essentially, we remove cervix, vagina, parametrial tissue, and at the end, anastomose body of the uterus to vagina. That's the technique. Of course, this needs little super selective patients, and essentially very, very limited role in patients who have advanced stage of disease. So it has to be a very early stage where and patient is keen for fertility preservation. Otherwise, ovaries can be preserved, and what they describe, oocyte or embryo cryopreservation, and all those things can be opted. The last word about role of minimally invasive surgery. Dr. Srikhande very nicely mentioned, and I always believe, we disagree on many things, but today yeah. So, but I absolutely agree with him when he said about minimally invasive surgery. So we have to follow oncological principle first. Don't be under peer pressure or, to be seen as a fancy surgeon. If you can't do minimally invasive surgery, it's absolutely fine. A good quality open surgery, maintaining oncological principle is extremely important. But when we talk about cervical cancer, even in those patients and excellent surgeons and excellent centers, there is a randomized which showed that in best of hands, minimally invasive surgery, be it laparoscopy or robotic, and this study is from West, US and European centers. So best of the centers, minimally invasive surgery is inferior to open surgery. So currently, the recommendation is not to do minimally invasive surgery in patients of cervical cancer. And this is international recommendation. It's not that you are not an expert and you will not do it. Okay, a word about cervical cancer in pregnancy. I thought maybe you these patients. In our country, it is the most common cancer in women in pregnant. So this chart gives you an overview. How do we manage cervical cancer in pregnancy? So if it's an early pregnancy, patient is for fertility. We do take cancer treatment first. So if it's early stage operable cancer, we do surgery with fetus in situ. So the way I showed this patient was multiparous was not keen. We did radical hysterectomy with fetus in situ. If it is advanced stage of disease, early pregnancy, where surgery is not the treatment, we give them either remove the fetus and then give them chemoradiation, or at times we do start radiation with fetus in situ, but our radiation oncologists, if abortion happens in the middle of EBRT, it becomes little messy. If it is advanced pregnancy, patient is keen to continue with the pregnancy. So we follow them carefully during pregnancy, and there is an option of giving neoadjuvant chemo, Taxol and carboplatin, which is onwards in pregnancy. And once fetal viability is reached, if it's early stage disease, we would do cesarean section, classical cesarean section, and radical hysterectomy. If it is advanced disease after cesarean, once patient's wound is healed, the patient would go for concurrent chemoradiation. So schema for patients with cancer in pregnancy. So to just end, we know that, nowadays it's not just one treatment for every patient. You have to individualize the treatment. The concept of one size fits all is no more valid in oncology and other specialty. You need to have a multidisciplinary team, medical oncologists, radiation oncologists, and GYN oncologists here. And it's essentially a team work, and decisions have to be taken So I'll just quickly take you through. This is the same lady I started with, a 3 centimeter. We did MRI, which showed disease confined to cervix. There were no lymph nodes detected. So she was planned for radical hysterectomy. She was just 45-year-old. As I said, minimal invasive surgery, we don't practice and it's not recommended. So it has to be open surgery. Incision could be a vertical or transverse malar journey. The first step, especially if it's a big lesion, is to mobilize the bladder away from the cervix, because many times you may find dense adhesions between cervix and bladder. The next step is to do lymphadenectomy, and in cervix, you just need to do pelvic lymphadenectomy. So I'm using electrosurgical unit. If you are using that, you have a quality machine, because we just want to be sure there is no collateral damage. So I'm in the retroperitoneum. What we are seeing from lateral was psoas muscle, external iliac vessels, and this is paravesical space. So you need to develop this space first before you can proceed with lymph node dissection. And down there is pelvic floor. And you can see bifurcation here. This is external iliac, internal iliac. So we start lymph node dissection at the level of mid-common iliac and go all the way. So we have to remove tissue from all sides of blood vessels when we are doing. I've stopped removing lowermost external iliac node, which largely drains the lower limb, and our edema rate. One tip for those who are interested in doing radical. So if there is any tissue between external iliac artery and vein, you remove the white structure down there is obturator nerve. Take care not to injure it and manage it, not to touch it with cautery also can lead to post-operative neuropraxia. So whatever tissue present in obturator, you remove few round structures, lymph nodes. So after doing lymphadenectomy, we do send for lymph nodes for frozen. If frozen is positive, to abandon the facility may not be available and proceed with the complete. So the next step was ligating uterine artery at its origin and reflecting it medially. And why we do this is a component of removing paracervical tissue. The belief is that there may be some microscopic lymphatics running in this. area along the vessels. So take uterine at origin, reflect it medially. Next, separate ureter from its attachment to posterior leaf of the round ligament. Mobilize it. Again, if you are using, we do not denudate of blood supply. Young patient ovarian preservation is found. In this lady, we did not preserve ovaries. So infundibulopelvic ligament was ligated and all the way posteriorly down to the level of uterosacral. Okay. So yeah, and this is pararectal space, and when we are doing nerve sparing surgery, we actually, okay, the same steps we repeat on the other side. Lymphadenectomy, this is another way to approach obturator, retracting vessels medially. What we are seeing white structure was obturator nerve. This is obturator. So ligating uterine at origin and reflect it medially, infundibulopelvic ligament. And if you are preserving ovaries, the current recommendation is to remove, whenever you are doing surgery for any benign or malignant, remove fallopian tubes, as Dr. Devrat mentioned, that tubes may be the site for primary ovarian cancer. So self-injectomy is recommended. The next is posterior dissection. So this is what we are developing is uterosacral ligament. And this is rectovaginal septum, where a colorectal surgeon, it's a routine plane for colorectal surgeons. Important to remember is that fat belongs in the specimen, just leave it behind. So that was the entire uterosacral ligament. If you have some other energy device, you clamps, cut and suture. That's the best way. So we have gone right to the sacrum. The next step is, cardinal ligament. So this is all the way we are taking at lateral pelvic wall. This is conventional type 3 radical hysterectomy. And the last bit is about anterior dissection, where we need to mobilize the bladder down. This is bladder pillar. We need to mobilize the ureters as they enter in the blood to damage, the blood supply. And all the way down. Now, how much vagina to remove? So the concept is 2 centimeters of vagina. So 2 centimeters of vagina is important. And if any doubt about vaginal preoperative colposcopy or VIA test is useful to define the extent of lesion. Okay, so this is the last bit. We just, again, take care of ureter. The most common site for ureteric injury is at this level, junction of entry of ureter in the bladder, what we call UVJ. Suture the vagina. Some people prefer keeping it open, but if you have done lymphadenectomy, a lot of lymph will come and lymph will drain from below. So not to worry, not to think it's urine, because that becomes a little messy at times and confusing also. This is the specimen. So you can see, and again, very important, send the entire specimen for pathological review so that, you get prognostic factors. Entire thing should be, so I'll just show this one. This is sentinel lymph node using radiocolloid, combination of radiocolloid and blue dye. So methylene blue, what is available, we do not have isosulfan blue in the country. So we inject this dye at 4 locations or 2 points, like as shown in that figure. 1 ml superficial, don't have to inject deep. And this is a radiocolloid. We inject a couple of hours before, depending what nuclear medicine people suggest. After that, this is done without anesthesia in the side room, you can do, or in nuclear medicine department. After that, patient is shifted to nuclear medicine department for lymphoscintogram. So you can see the center black is primary tumor, and on either side black things are lymph nodes. So we are sure that we will get some lymph nodes. Now, after induction, we use methylene blue dye, which is again injected at 4 locations, same as what we did before. And we inject 1 ml each. And after this has to be done because methylene blue generally takes 10 to 15 minutes to reach. But if you wait for too long, it disappears. So optimum would be after induction, before you open the abdomen, because in 10-15 minutes, most of us will be able to enter the abdomen. Now, what you have to be, open the retroperitoneal spaces, as I showed before, and you have to identify this blue channel. So if you can appreciate, this is the blue channel, which is draining, and this is the blue node. To make sure that this is same node where radiocolloid was, uptake was there, we use intraoperative gamma probe. So this is handheld gamma camera, which is quite, I think it's not that expensive. It's easily available. make sure that you're removing all nodes which are either hot or blue. And that's activity has to be, that's baseline activity. And generally you have above for the sentinel lymph node. Once the node is out, we check for the activity. I think, I think that's of any use, but just to show, thing, we also have just 30 seconds for robotic platform, what we use mainly in endometrial cancer. And this is endocervical lesion. So some of our, robotic systems have inbuilt firefly mode or immunofluorescence camera. So we inject the dye in the cervix and then open retroperitoneal spaces. Now this is inbuilt camera, or we have open or laparoscopic systems also. So you identify the channel and node, whichever, where it's training. So I think with this, I'll end the presentation and thank you very much.
Thank you, ma'am, for your kind presentation. Yeah, we're moving on. Now, may I call upon Dr. Zipora, who is Executive Director, Kenya Hospices and Palliative Care Association, KEPCA. Should be discussing the need to increase palliative care research. What do we need in the region? Do we need clinical research or implementational research or population-based research? Welcome.
Thank you very much for those presentations, especially the last graphic one. That was very illustrative, and at least some of us are not surgeons. I kind of understood what goes on behind the scenes. Usually you bring the patients to us, palliative care providers, when you've done everything, we don't know there is quite a lot of work. Thank you very much for that, and also to all the other presenters. Thank you for your presentations. I just also want to thank Dr. Paul for inviting me to give a talk. It's not very common that when you have a cancer gathering that people from palliative care are invited, because we tend to forget that palliative care is part of cancer care. So it's important that we acknowledge that you cannot have cancer care without having palliative care as part of that service. From the sessions we've observed the whole time, we talk about quality of life, isn't it? Of patients, whether they're doing surgery, providing chemo, or whatever they're doing. But you cannot have quality of life unless you address a patient holistically. And that's where palliative care comes in. So that we support the oncologists, the surgeon, all the healthcare providers in terms of taking care of the patients. So I don't know if you're moving what. So I have no conflict of interest. Not be great to come and talk about certain palliative care. I think from the presenters this morning, we are aware of what palliative care is. I always like to redefine it because most of us think palliative care is equal to end of life care. What we see in palliative care is you doctors wait until the patient is end of life, is when you send that patient to us. Yes, we can do a lot for that patient. We can improve their quality of life. We can, at least even support the families, but we would do a better job if we send the patient from the time of diagnosis. If you actually bring the palliative care team on board from the time you make the diagnosis, because we focus on supporting a patient from that point onwards throughout the trajectory of their illness. So it's really about quality of life for the patient and family, and also the carers of the patient. They might not necessarily be family members, but they're being carers of the patient. And so we talk a lot on emotional, psychosocial, spiritual care of the patient, the physical aspects of care. And again, once the patient moves on or maybe dies, then we also focus a lot on bereavement services for the family and carers, because those are also very important. So one of the things that we need to focus on and remember is that palliative care is about quality of life, and being around care, and what happens. It's about quality of life, better symptom management, that is increased patient satisfaction, improved quality of life, and also reduce health costs. And I mentioned this because over time, since 2010, actually, mostly we had a breakthrough in terms of research in palliative care, where TML and other researchers looked at a patient with small cell lung cancer. They had a cohort where they introduced palliative care from the time of diagnosis, and there are those who did not get any palliative care. And they compared these two. And when they compared this patient, the patients who had received early palliative care from the time of onset of diagnosis actually had better quality of life. They had less distressful symptoms, at end of life. Their symptoms were managed very effectively. They were satisfied, in fact, emotionally, psychologically, because they had all these conversations with their carers, the healthcare providers, in terms of what is the next, way forward from what, like even they're redefining goals of care when the patient is end of life. Also things like writing wills, advanced care planning, what you call 5 wishes. Where do I want to be when I die? Whom do I want to be when I'm dying? What do I want to happen to my body? These are actually very important things to patients. Sometimes we ignore these things, but they're very important to patients. The same study also found out that patients visit the hospital less frequently because their symptoms are managed. They can be taken care of at home. If their symptoms are not, if their pain is not managed, for example, they'll keep on coming to the hospital regularly because they want their pain to be managed. And also the same study also found that people who receive early palliative care live a little bit longer than the other patients. So a minimum of 3 months or above. And for a patient who is at end of life, 3 months can mean a lot. It can give them time to be able to focus on many things, unfinished businesses, breaking up with family members that they have not been talking to for a long time. But also importantly, to reduce costs for the patient because they don't come with them to the hospital, but also reduce costs for our healthcare services. So the hospitals and healthcare system in the country spend less money on patients whose symptoms are well managed. So why are you talking about palliative care research? Unfortunately, we don't have enough research done in Africa on palliative care. A lot of research is done on many other things, but when you look at research in palliative care, there are very few of us who have gone ahead and done some research in palliative care. But it's important to actually recognize if you're researching in medicine, palliative care is part of a health service that you give to patients who need it, not just oncology. And by the way, palliative care is not just oncology patients, it's any patient who has a life-threatening or life-limiting illness or a terminal illness. So again, we focus on research because we want our patients to have the best quality of life. What can we do to improve their quality of life? So to understand the effectiveness, to understand what interventions we can actually use to be able to improve their quality of life, and also even to help us as healthcare providers and our governments and healthcare institutions to understand what are the best models of care that we can give for patients. So there's a lot we can actually learn in terms of what we need for research in palliative care. So it's not just informing our clinical practice, but also informing our healthcare systems and how to integrate palliative care and even to have palliative care as part of our oncology services. So I'm happy to say that in my country, we've actually prioritized palliative care in Kenya. It is recognized as a right to health. It's actually in our patients' rights charter. It's part of our health law. And our clinical guidelines for starting a cancer center insist that you must have a palliative care team within the center for you to be able to provide palliative. So when they come to look at your center and you don't have a palliative care nurse or a palliative care doctor or a palliative care pharmacist, you will actually not be allowed to give those services. So that's a couple of things that also we need to remember. So I just kind of looked at one. We did a study we published a study in 2023, looking at the needs, the priorities in terms of research in palliative care. We actually talked to healthcare workers working in palliative care. We did focus group discussions, we did online surveys. Some of the topics that came up in these conversations, people wanted us to do a lot of research on this about death, disease, and treatment that can inform palliative care. And we know we come from the African continent. We have got very many different cultures, and death is really different almost in every culture. So they wanted us to do some research on death, and also to do research on awareness of palliative care education and training, and also to do research on integration of palliative care within the healthcare system, understanding the caregivers' experiences, because caregivers play a big role in our patients. We have what we call community health volunteers who are part of the system that takes care of patients, especially at the community level, understanding also their challenges and things that they might need for them to be able to support palliative care within the community. And also our healthcare providers, our policy makers wanted us to look at costs and benefits of palliative care. And of course, other treatment approaches, not just the continental treatment approaches, but also looking at complementary therapy, looking at also traditional medicine. All those things also play a big role in our culture. Again, one of the topics that came out here was end-of-life care, so that we can have some research on the needs of patients and families in end-of-life care. I tried to compare this with a study that was done elsewhere. I don't know what I did. Okay. And this technology is just complicated. You should bring those on the to just point at something. So anyway, an international study looked at the same kind, looked at the priorities of palliative care, and it comes out with similar results. The priorities that people want studies to be done on research and service models, continuity of care, training and education, inequality, communication, living well and independently, and then recognize the family care needs and the importance of families. So the similarities within globally are actually almost the same. We want to find about the quality of life, want to find about what the patients need and the family also needs, and what we can do in terms of improving services within our country. So this is just a summary of some of the recent studies that were done in terms of looking for priorities for palliative care research. So just maybe to break down some of these things, understanding patient and family needs, what do we need to do? Why do we need to do this? I mean, it's important for us to understand the patient because sometimes I think we become very clinical. We forget we're treating a human being. If we don't understand that person's needs and the people around them, we might not be actually giving them the best care that we have. And I think since morning we talked about patients, and sometimes we make a diagnosis, we make a treatment plan, but we don't communicate this to the patient effectively. And maybe that's not what the patient wants. I received a call yesterday, someone telling me that my patient has refused to continue dialysis. And I asked, what is the patient? Not my patient, but my colleague's patient, my younger colleague. And I said, what is the, have you talked to the patient? Have you told them what happens if they refuse dialysis? And she said, yes, I've told them everything. How old is the patient? 73 years. Have they had a quality of life here? Then you need to respect their wishes. You don't have to force what you want on the patient because she was like, no, if you die within the next, I don't know how many weeks, I said, explain everything to the patient and let them make the decision. Maybe this dialysis they have been having for so many years is now more, decreasing their quality of life and not necessarily improving their quality of life. So we need to understand the patient and family needs. What do they need for us to do for them? Their specific needs, their preferences. And one of the studies we did some time back, he was stopping people in the street and asking them, where would you like to die? And most people said, I want to die in my home. But in Kenya, you find that most of the time when a patient is nearing end of life, we push the patient to the hospital. We put them in ICU, and this patient is put on all sorts of machines, unnecessarily. Quality of life is completely zero almost. Patients, families have to pay so much money for those costs. So again, patient preferences, what are their goals of care, where would they want to be when they have maybe reached terminal stages. And then of course, even as we're understanding the patient and family, patient experience are always the best. And these days, I think, the slogan is nothing about me without you. You cannot be talking about me when I'm not on the table with you. So again, patients' preferences, family preferences are also very important. So culture, social, economic factors are really important in understanding the patients and family needs of those who are receiving palliative care. So the other thing that I think is important to researching is access to palliative care services. We have very many barriers, and I was listening to the speakers this morning. Somebody said that the reason patients don't come back is not because they don't want to, it's because they are not able to afford transport to come to the center for treatment. This is a photo I took in Kigali the other day when I went to the cancer center, Rwanda Cancer Center. And I was just happy that they actually have a van that brings the patients to the center for treatment. I visited the Tata Memorial Hospital many years ago, like 10 years ago, and I saw these big buses that were bringing patients for treatment. How many of us have such services? Those are very simple things that actually, matter to the patient because they're not able to come back for treatment because of transport. We ignore things like how can we get our patients to access treatment? So barriers, there are many barriers to accessing treatment. Of course, a lot of the barriers are also with our healthcare system, but also with us as clinicians. We don't refer patients adequately or in time for them to receive services. So looking at the barriers for access is also one of the research areas that has been mentioned by many people providing care. So all these things are important. Understanding the geographical, financial, systemic challenges can also guide things like policy in our countries. Education and training of healthcare providers. I think we've learned a lot this morning. I've learned a lot from the study that goes on. So this is part of everyday education. One of the things that again we have realized in our research is that medical curriculum, undergraduate, postgraduate, does not take into account modules on palliative care. You'll find there'll be a sentence or two in terms of palliative care. That is not enough to keep a healthcare provider to provide palliative care. Personally, I think any doctor or nurse or even pharmacist, anybody working in healthcare, at the level of undergraduate should come out of the training with the basic principles of palliative care. We don't have enough specialists in my country. Doctors, we have 4 are retired. My colleague, one of our other colleagues has retired, but we're now doing pro bono because we don't have enough palliative care doctors. We have quite a number of nurses, but education is important because if you train people in the undergraduate at undergraduate level, they can provide palliative care wherever they are. And when there's a need, maybe they can refer to specialist care. So some of the topics that come out, mostly when you're talking about palliative care training, most people will say they want to be trained on communication. And I think those of you who break bad news to patients understand what I mean here. How do we break bad news to our patients? Are we sensitive about it? We use the right language? We might never really have the right language, but how do we do it? So most patients will come back and come to me and say, doctor just told me you've got cancer, you're going to die. And that is the time they start dying actually because of the way the news is broken to them. So even just communication skills are very important in terms of how do we do our own local studies to understand how we can communicate with our people in a very cultural sensitive way. And then of course assessment of and management of cancer pain, and then there are sessions that are going to go on in the afternoon in terms of cancer pain management. Most doctors do not understand how to use opioids for cancer pain. They don't know how to prescribe, they don't know how to assess, and also they have all these myths and misconceptions about opioids. So we need to be able to demystify some of those barriers to cancer pain management. Again, of course, we know that patients with cancer have got more than one symptom. They can come in with very many other symptoms. We need to be able to assess this and treat them. So one of the things that also is important, the legal and ethical issues in cancer patients. And this one, again, we'll come back later on a little bit. For patients who are in palliative care, they are very vulnerable. If you're going to research, if you're going to do clinical trials, you have to be very sensitive. Sometimes, actually, you might not even get approval because you're told this patient is very sick, is dying. So again, that is another challenge in terms of palliative care research. These are the topics, of course, end of life care, advanced care planning. How many of us have got policies care plannings in our country? And you'll find most African countries, we don't talk about end of life, we don't talk about advanced care planning. Bereavement, nutrition, psychosocial and spiritual care are also very important. And I know your clinicians and you're thinking that spiritual care is very important. You can manage that question with all the treatments you've put here. But if you don't address the psychological, emotional, and spiritual needs, you will not be very successful. Sometimes a patient will come into the room and there's so much pain. In fact, they're even breathless. And when I just tell them, have a seat, what is it? Just addressing you as a person, a human person, you find that even their breathing improves, their pain improves. So again, the humanity, the human approach is very important in terms of how we treat our patients. So this is just to also mention that it's now 10 years since the 2014 resolution on palliative care was passed. And we have been looking at countries, what have we done in terms of improving access and integration, access to opioids, research, partnership, and all those things. So that is, of course, coming to the part of public awareness. Most patients will not actually go for palliative care. We find that hospitals are empty because they say that the doctors have given up on me, they are referring me there to go and die. But that's not actually the issue. So we need to sensitize our public and also our policymakers on what palliative care is. And again, a lot of times, initially, palliative care started as a standalone service in Africa and in many parts of the world. And it remained standalone and ignored for a long time. So we have moved the focus in the resolution to integration. Can we integrate palliative care services into our healthcare systems so that it's not an isolated service, but part of what we do on a daily basis for patients who need it across all the other diseases apart from oncology only. So just briefly a little bit about methods. I'm not here to tell you that clinical or implementational or population-based is the best. Every method is okay. But also it depends on what you're researching. What is your research option? What do you want to look at? That you decide which method you are going to use. So there are many different methods. And in palliative care, it can be very complex, like I said, because we're dealing with very, very vulnerable patients who we need to be sensitive about. We're looking at the physical, we're looking at the psychological, spiritual needs of the patients, and your focus is to actually improve the quality of these patients and also looking at things like communication, decision making, and also our teamwork, how do you work as a team. All these are very complex issues. So when you're doing palliative care research, there are many people we need to work with. We don't just work with ourselves, we work with people in the ethics and research. We work with epidemiologists, people who have got humanities, education, economic, and even health. All these are very important in terms of what we do in terms of when we want to do research in palliative care. So clinical research, we all know what clinical research, all of you are clinicians and researchers. I've seen so many presentations on research from India. It's time Africans we caught up also. When we come here, we come with our own statistics. Is that okay? Because I think we also, they have done their research and they see what's working in their own country. The current means doctor, said that every individual is different, not one size fits all, isn't it? So the medication you're giving to a patient in India or in the UK might not necessarily be the best medication that you would give for a person in Africa. So we need to look at also some of those things. How do we localize research and also make it individualized? So treatments. So it's really when you're doing research, clinical research in palliative care, looking at what interventions are you going to use for symptom management, mostly, for example, pain or other symptoms. What interventions are you going to use for psychological support and all those things? So we need evidence from clinical research that can help establish best practices for better quality of life for our patients and their families. So clinical research has got a big role to play in palliative care. I'm not going to go in detail, but this is supposed to just uncover of some of the methods we need. So implementation research has become a very sexy word these days. Even we are involved in a big research. We are doing a 5-year research on breast and cervical cancer in Kenya. We are doing it right in the community, using community health workers, going into homes, giving information, and then doing HPV testing for patients who are willing to. And this is because we want to use this study within the community, with the community, so that we can actually use the result of this study to improve policy, to improve, to improve even screening for cervical cancer, because many people, like we had this morning, many women in Africa are dying from a preventable cancer. So implementation of science is very important, and I think you all know what it does. It actually examines how palliative care practices or how health practices and interventions can be effectively adopted and implemented in real-world settings. So the most important thing is that we are looking at what can we do, what are the gaps, and how do we fill these gaps. So why do we need implementation research? Is because understanding the barriers and facilitators to implement and help tailor strategies that will promote effective integration of palliative care into clinical practice, improving availability and uptake in various clinical contexts. So this is also a very important method that approach that we can use for research. We talked about clinical, but also implementation of science research is also very important in palliative care and other aspects of healthcare as well. So population-based research, I think you all know what it means, is when you're looking at the whole population, or actually you're looking at a group that is representative of population in a country or in a region, and you're looking maybe the demographics, epidemiological trends, utilization patterns, and health disparities. And this can also help us in terms of identifying specific community needs, and also for countries, for health, for policymakers, can help them understand but also manage the resources in terms of population, and also, of course, improve access to quality care for our patients. So we can use either clinical research, we can use population-based research, we can use implemental research in quality care. I would not want to say that one is better than the other. It depends on what you're looking for in terms of your research question. So then all approaches are quite okay for quality care research. So sometimes also some of the things we find that we need to think about is collaboration. And I think academic institutions with healthcare providers, policymakers, community are very important in terms of us doing research in palliative care. One of the things that also is a challenge is resources and funding. I know in Africa, we don't have enough money that is given to research. It's very limited for cancer, and it's even more limited for palliative care. So we need also to increase funding for palliative care. But again, importantly, patient and family involvement is very important. Remember, we are talking about people who are going through an experience. Their experience, the lived experience is very important in terms of improving what the services they're going to give to these people. So lived experience for family members and patients is very important. And I like to say that we avoid what we call tokenism. If you are coming up with a research question, you must bring the people you're going to research on board so that we actually think about this research together and plan it, whatever you're planning, until the end. In fact, at the implementation stage, you actually have to be the patients and the families. And then, of course, as you do policy advocacy and the rest, you also deal with the patient and the family. So technology is also very important. We have seen a lot of technology in the slides today, but again, technology is very useful in terms of research. And I remember during the COVID pandemic, we actually had to come up with apps on how we were going to communicate with our patients, ask them about their pain, ask them to rate their pain. We did a lot of work out there. Just coming up with simple apps that can do what you call them, I don't know what you call them here. Those are the very, very basic forms. So the patients could actually be able to report their symptoms on the form. So again, technology to collect data, telecommunications, all those things are very important. So there are many challenges in palliative care research. Like I said earlier, we are actually focusing on very vulnerable populations. We have to be very sensitive about that. You can't go and research on a patient who's end of life sometimes, but we still need to be able to do some of this research for us to be able to improve care for patients. So some of the biggest challenges that it's a very vulnerable population. So we need to look at how can we actually address those vulnerabilities so that we can still get people involved in research. And I was talking to Professor Chite about he was giving a presentation. Professor is one of the oncologists in Kenya. And he was talking about his research and I was saying, how do I go into a patient who is really, really sick? How ethical is that? And he was saying that even those people need, to be part of the research, because if you don't research them, how are we going to be able to know how to support them? So again, even before you put a patient into any research, you have to also get their concept and the family concept. So that's very important. So there are many barriers. One of them I said is funding. We have lots of funding. We don't have enough capacity in institutions. We are not trained. And for doctors and nurses working in Kenya, we find that they are also seeing the patients, they're also doing the reports. They don't have time when to do any research. So again, working with young researchers is also very important. Of course, topics are also very important. And misunderstanding of palliative care, which is very common even in oncologists. Don't equate palliative care to end of life care because they are not the same. End of life care is just part of palliative care. So this is just what I wanted to share with you today, and it's very important for us to decide which method we are going to use depending on the study we are doing, the question we are asking, and so it will actually help us to understand we need to do clinical, we need to do population care, we need to do implementation research. Those are just some of the things that I thought maybe I'll mention today, but this is a very wide topic, and I think I've been told 15 minutes, so I made it. We don't now see it more. So we need to be able to do research because it helps us improve the quality of life of our patients. It is also helps us to be able to advocate policymakers. Those policymakers become a give us the figures. If you don't have the figures, we will not be able to do anything. So again, as I said, please let us get our patients involved into the research we are doing because it's very important. So thank you very much. I think I'll end there.
So I'll be welcoming Professor Anand Ramaswamy, who is a guru in oncology from Tata Memorial Hospital, and he'll be taking us through the current concepts in advanced colorectal cancer.
So over the next 20 minutes, I'll talk a little on current concepts in advanced colorectal cancer. And it's a large topic. And it was nice to know that you have a lot more medical oncologists here than surgical and radiation oncologists is what I got to understand. So these are some of the topics that I will cover. And over the next 20 minutes, obviously it's a large topic, so covering the entire spectrum is a little tough. So if we talk purely of the cancer itself, these are the 4 points that you have to look at in advanced colorectal cancers. But I think if you look at just these 4 points, you're missing the forest for the trees. Because in advanced colorectal cancers, it's just not what you can do for them, but whether you have resources, whether you have the drugs, whether the drugs are available to a majority of your population. And do you have supportive care? Do you have palliative care? Is the patient involved? These are things that we need to keep in mind when dealing with these cancers. So since I'm speaking to an informed audience, over the last 1.5 decades, These are the four chemotherapeutic regimens that have dominated the landscape, either FOLFOX, CAPOX, or FOLFIRI. Very rarely we use single agent 5-FU or capecitabine. And these regimens have proven to have similar efficacy. And this has been demonstrated almost 1.5 decades back. But as medical oncologists, we generally try and give more to help improve outcomes. And over the last 7 to 10 years, we have tried to put all our eggs in one basket. So it's 5-FU, irinotecan, oxaliplatin, all at one go. And there are 4 to 5 studies which have looked at whether this is an optimal approach. And this was published around 5 years back, where they combined data of almost 5 studies of 1,700 patients in patients who are in the early 7th decade. And what they found was that if you give the FOLFIRINOX combination, if you're able to give the FOLFIRINOX combination, you probably improve survivals by approximately 5 months. So in a disease like advanced colorectal cancers, where in the late 90s, your median survival was 6 months, an improvement of 5 months is actually of therapeutic relevance. The thing to note is that you can't directly extrapolate this data straight into our practice, because almost 80% of these patients had PS0, and they definitely had more complication rates. Almost 1 in 2 patients will have a significant degree of febrile neutropenia and diarrhea. So if you're giving an intensive regimen like this, be prepared to tolerate and treat the side effects as well. The thing is that if you intensify, you might improve survivals, but you also need to de-intensify therapy if you want to maintain quality. And a significant proportion of colorectal cancer patients are older. Neuropathy, which is very common with these drugs, is very common. And patient fatigue and caregiver fatigue with intensive regimens is a thing that we often underestimate. So is just giving 3 to 4 months of intensive chemotherapy and then shifting to something gentler a reasonable choice? It most certainly is. And there is enough data to say that if you give an intensive regimen of approximately 4 months and then shift downward to a single agent of 5-FU or capecitabine, you're actually not losing much. You're maintaining quality of life as well as having a decent overall survival. So in terms of just chemotherapy, which is still the backbone of treatment of advanced colorectal cancers, a majority of us would treat with 2 drug regimens. If you have very fit young patients, you probably can give them multi-agent 4-drug chemo. And continuing intensive chemo beyond 4 to 6 months is really not required. You can come down pretty quickly. And these maintenance strategies with chemo alone have good quality of life without affecting overall survivals. Genomics is come in a big way in all tumors, and so also. And the ESMO guidelines are actually a useful set of guidelines as to what we can do in across scenarios. So what they actually say is that you need 5 tests which you need to be done. You don't need an NGS if you don't have access to it. Simple PCR and IHCs can get you a majority of the information that you need to treat colorectal cancer patients. So your KRAS, NRAS, and BRAF can be done by simple PCR. HER2 and MSI can be done very well by IHC. So if you can get to this, you can obviate the need for an NGS, which is more expensive, more time consuming as well. A quick note on the 2 important targeted therapeutic agents in advanced cancers. One of them is the VEGF inhibitors, and the drug I'm referring to predominantly is bevacizumab. And this is an old drug, has been used in a variety of cancers. The thing to note is that even though it's been around for close to 2 decades, like in other cancers, it has very seldom shown an overall survival benefit. So we will give Bev to our patients with advanced colorectal cancer. It improves progression-free survival to a limited extent. The other group of drugs that are important in advanced colorectal cancers are molecules directed against EGFR, which is cetuximab and panitumumab. And so it's either bevacizumab or panitumumab and or cetuximab, which is common in these cancers. From approximately 2014 onwards, from the West, we had a lot of data to say that colon cancers is not one disease, and you had sidedness, so it's just not colon, but it's left and right colon. And what the idea was that if you have a right-sided colon cancer, you probably do worse off just overall. And in advanced colorectal cancers also, if you have a right-sided colon cancer, you probably do worse off compared to left-sided colon cancers. And the basis for this is probably not sidedness, but the molecular landscape. This is a paper I would recommend to everyone, which was published in 2015, where they demonstrated that you have 4 molecular subtypes. And these 4 molecular subtypes are not just subtypes which have different molecular pathways, but they clearly predict for survivals as well. So if you can see the green line here, which is probably CMS4, it clearly tracks lower than the other 3 types of molecular subtypes of cancers. That said, this has not come into practice across countries, not just in India, but even in the US. This is all only retrospective data. This has not been prospectively used in trials, but it's useful information as we go forward in this set of tumors. So when you add anti-EGFR directed therapies, when you have access to it, you improve survival to some extent. Now, the overall survival improvements are only 2 to 4 months. And the reason for that is probably, the sidedness that I mentioned sometime earlier. You probably should not use anti-EGFR directed therapy in right-sided advanced colorectal cancers. That's the take home. This was a big point of discussion around 7 to 8 years earlier. This has made its way into guidelines as well. And as you can see here, these are the 3 large studies which have looked at anti-EGFR and BEV. In anti-EGFR, if you have a left-sided tumor, the survivals are much better when you use an anti-EGFR agent. But if you have a right-sided tumor, even if it is RAS, you probably don't do as well. And now this is not recommended in right-sided tumors. And of course, in left-sided RAS wild-type tumors, if you add panitumumab therapy, you gain around 3 to 4 months of survival. So the points to remember is that overall right-sided metastatic colorectal cancers do worse off. If you have a RAS mutant tumor or a right-sided RAS wild-type tumor, you're good with chemo plus bevacizumab. But if you have a left-sided RAS wild-type tumor, you probably should add one of the anti-EGFR directed agents to chemotherapy. A couple of words on BRAF mutant tumors. These are the toughest to treat in the overall subset of advanced colorectal cancers. They are around 5 to 8% of your total advanced colorectal cancer population, and they are seen more commonly on the right side. Not all BRAF mutants are bad, and this is something we should know. If you have a V600E, which is a class 1, then you're not going to do as well. But if you have some of the other BRAF mutants, you actually do reasonably well compared to other colorectal cancers. So if you have a BRAF mutant V600E, you survive approximately less than a year. But the others, you actually go beyond 3 years. So look into the subtypes as well. The results with chemo alone in BRAF mutants is a little disappointing. Large studies have said that survivals are just a year. So when you look at other avenues, you probably combine it with BRAF directed therapy. This is an area of work, an area of need. The most promising data is this study, which was again heavily discussed around 3 to 4 years back, where you combine cetuximab, encorafenib, and binimetinib, which is a MET inhibitor. The idea that came out of this is that binimetinib probably is not useful. So it's cetuximab and encorafenib if you have access to it. We don't have access to encorafenib in India except on compassionate basis. And this is now gone on to a phase 3 design, and they are being evaluated in therapy. So not all BRAF is bad. Some BRAF can actually be good. If you don't have access to targeted therapy, probably you will use FOLFIRINOX plus bevacizumab as your initial regimen. Quick word on HER2. It is done, but we don't have effective agents in the first line. 4 to 5 years from now, this will probably enter first-line treatment. There are a number of studies. The 2 drugs that stand out are trastuzumab deruxtecan and probably trastuzumab plus tucatinib. As oncologists, the one area that we've all been excited about is immuno-oncology. MSI high cancers in advanced colorectal cancers are 3 to 5%. Overall, it's around 15%, but in advanced colorectal cancers, it is 3 to 5%. Do look for Lynch when you see MSI high cancers. This is the study which changed the way we treat MSI high cancers. We gave pembrolizumab to those with MSI high cancers, and the survivals almost doubled. What was 6 to 8 months of progression-free survival, doubled to around 16. And the important thing is that approximately 30 to 40% of these patients are actually long-term. They've gone on to survive beyond 5 years. Again, an issue is that it is expensive. It is not easy to give, but if you have access, probably this is the way you treat these cancers. This is the updated analysis for the same. There is also data for combining immuno. Again, I don't know how feasible this is and where they are very, very expensive. So what we've done is that we actually looked at low-dose immunotherapy. This is data from our center where we used 40 milligram every 3 to 4 weekly of nivolumab. And obviously we can't do a direct comparison because we don't have the resources to carry out that kind of trial. But if you look at the survivals, the early survivals are as good as standard dose immunotherapy. The 12-month survival for low dose was 90%. And we are also running a trial looking at this, but this is something that you can think of in scenarios such as ours. So the standard of care in MSI high advanced colorectal cancers is immuno. We need to think of solutions beyond the standard dose is what I think in scenarios such as ours. Older patients in the West, the median age for colorectal cancers is the 7th decade. It is approximately 62 to 65. In our scenario, this population is less, but approximately 23% of patients coming to our hospital actually are older than 60. Just a pointer here, it's not the chronological age, but the physiological age. And there are a number of studies, at least in advanced colorectal cancers, which have said that you can be conservative in the treatment of older, frail patients without losing out on survival. Single agent 5-FU or capecitabine is a good option in patients who are not very fit or who are older, and there is phase 3 data to back this up. This is just some data from India. We have very limited data on advanced colorectal cancers, but as you can see, one of them is from our institution and one of them is from the median survival is around 18 months, just 1.5 years. So a lot of trial data actually quotes 3 years, but in the real world, you're probably looking at 1.5 to 2 years. So that's survival from our center. So I've not discussed many things because this is a rapidly evolving field. It's multidisciplinary. You have more new drugs coming. So that is for another day. With that, I'd like to thank you for your attention. Thank you so much.
We are welcoming again Dr. Bamon.
So thank you so much for giving me this opportunity. So although we have 3 or 4 gynecologists sitting here, but we had 4 gynecological topics. This is very interesting because cervical cancer is #1 cancer in Tanzania, as we can see. So a lot of importance is given on cervical cancer, and I'm happy that you have given that in cervical cancer. And it is a disease which takes not months or years, it takes decades to develop into invasive cancer. Okay, so now, and during this phase, it passes through phases of precancerous events during which you can detect them. And once you have detected them in the precancerous phase, they are very easily treatable. So, and this treatment procedure can be replicated by every one of you. Even if you are a medical oncologist, just 7 days of training and you can treat these patients. You can detect them and treat them. So these are very simple cases, unlike Dr. Shikhande, where he has spent 20 years of long dedication you need to reach that stage. So we are talking about something which will take you just 3-4 days and you are there to treat. So this is the story of the decade. So now treatment of CIN, when do we treat? So why do we treat? Which patients you want to treat? We know that it passes through CIN1, CIN2, CIN3, which takes around a decade time, sometimes even up to 20 years of time. And then you detect them, one fine day she will come to you, and luckily you have inspected her cervix, you have done a VIA test or a colposcopy or a pap test, and you have detected in this precancerous phase, and then you take the decision to treat them. So if that, or if you catch this woman in this stage, we are very lucky because it is 100% curable. So how do you detect? We know with the VIA test. I know many of you will be knowing VIA test, pap smear test, HPV test, colposcopy, which is very important. And a learning of understanding of colposcope is very important. Amita madam has already told you regarding the colposcopy, few slides. She has shown the things that are needed. You need a colposcope, you need some instruments, which are generally the vaginal speculum, the sponge holding forceps, and some punch biopsy forceps. These are normal things which all of you will be having in all the setup, I'm sure. And apart from that, you need normal saline to clean the cervix. You need 3 to 5% glacial acetic acid, which is very easy to prepare. You can prepare it in your own setup. And you need Lugol's iodine, which is also very easy to prepare, and Monses paste if you have. That is okay. So if you see, you just see the cervix, you clean it with normal saline, you look for that white patch, and if once you have got that white patch, you know you are there, you want to treat that patient. Okay. So depending on the density of the whiteness, you label them as CIN1, CIN2, CIN3, and then you treat. Okay, so these slides I'll go fast because I'll be concentrating more on the management. So as you can see, there are 3 shades of white, and depending on the severity of the lesion, the density increases. Okay. So these are some other pictures which I'll show you. These are basically high-grade lesions. Sometimes it may be invasive also. So you need a biopsy to prove. Again, madam has already shown the atypical vessels. So this also you need to look while you are doing a colposcopic examination, and the density of the white. There are various shades of white that you need to see. Then the margin of the white, acetowhite lesion is also very important. How sharp is the margin? If it is raised margin, then then most of them will turn out to be high-grade lesion. Then again, the pattern of the blood vessels, that also you need to see. The size of the lesion is also important, because the more is the greater is the size, the higher is the air, and also it will also tell you what sort of treatment you want to do. Because if more than 3/4 of the cervix is involved by that white lesion, then you cannot do the cryotherapy. Then you need to do the excision. So now, so depending on your colposcopy finding, you will give a score, and then ultimately you tell that you know that whether it is a normal cervix, it is CIN1, CIN2, CIN3, or suspected cancer, and then you plan your treatment. Okay, so now what are the indications of treatment for LCIL or CIN1? We know that for LCIL and CIN1, you can observe, but there will be some situations when you see that the patient may not come back again. She will go back, and you tell that you come after 1 year for a follow-up. You feel that no, she may not come. Then in those cases, you may treat her in the same sitting. Then persistent LCIL lesion or CIN over 1 year, LCIL showing HCIL features on colposcopy. These are the things when you like to treat even in LCIL. But if it is CIN2 or CIN3, we say that all cases should be treated. So what are the treatment modalities? So see this here I start my main presentation. So there are 2 main modalities of treatment. One is the local ablative treatment. Other one is the local excision treatment techniques. So in the local ablative techniques, you have the cold coagulation, electrodiathermy you can do a cryotherapy, or carbon dioxide laser vaporization. And in the local excision technique, you have the large loop excision. You have the large loop excision of the transformation zone, cold light conization, and laser conization. So now this local ablative technique one by one. What is cryotherapy? Many of you must be knowing, but then still, for the sake of completeness of the presentation, I'll just tell that it is an ablative technique for ectocervical lesions. It uses freezing agents like nitrous oxide or carbon dioxide to produce tissue destruction. It uses a cryoprobe, which is made, the tip of which is made of silver or copper. So role of cryotherapy, treatment of CIN1 to CIN3. You can be used as CN3 treatment. You see colposcope, you see, or with a PIA you see, and then you would like to treat in the same setting. It can be sometimes used in treatment of chronic cervicitis or ectropion. It can be used as a low cost. It is a low cost feasible technique. And the eligibility criteria is the anterior extent of the lesion should be visible. It does not extend 2 to 3 mm beyond the endocervical layer. That it should be seen in the canal. If it goes into the canal, it should be seen. And colposcopy and or biopsy should rule out invasive disease, and there is no suggestion of a glandular abnormality on cytology. That is a prerequisite. And the lesion that you have seen, entire lesion should be covered by a probe, by the cryotherapy probe. If that probe, the biggest size of the probe that you have, you cannot cover the whole aceto-white area, then you cannot do. And if there is evidence of PID, cervicitis, vaginal infection, then please don't do now, delay it. And if recently pregnant, she should be at least 3 months post-pregnant. So now, what are the equipments? You need the cryosurgical probe. You need the gas tank that with the liquid nitrogen or the carbon dioxide. You need a colposcope. You need a sterile speculum, Tascos or Graves. Good light source, acetic acid, Lugol's iodine. This is how the cryotherapy machine equipment looks like. These are the different sizes of probe. Then you have the cryo gun, then the conducting tube, and then the gauge that is connected with the nitrous oxide cylinder, and ideally it should be in the green zone. There are three zones, green, red, and yellow. Ideally, it should be in the green zone. And once you've connected with the air and you've seen in the gauge that it is in the green zone, the machine is ready. Patient will be lying down in the lithotomy position. You have taken the consent, everything done, and now you are ready to do the procedure. You expose the cervix with the speculum. You detect the lesion. Take the appropriate size of the probe, connect it with the cryogun, then gently press over the cervix. See that whole of the lesion is covered by the probe. Switch on the machine for 3 minutes, freezing for 3 minutes. Then stop the machine, wait for 5 minutes, let it thaw. Don't pull it out immediately, because if you pull it out, there will be avulsion. And then if you want to a double freezing, again, restart the machine for 3 more minutes, wait for 5 minutes and take it out. So that is the total procedure, either single freeze or double freeze. Okay, so now gas pressure should be around 750 to 830 millimeter mercury. Size and all these things I've already told. So the procedure I've already told. Basically, the thing is that once you have done the procedure, you should explain to the, now. So this is how the service will look like. First is immediately after the procedure, 2 weeks after the procedure, 3 months after the procedure, and 1 year after. That is how it looks like. Okay, so now there are few instructions you have to give to the patient. There may be watery discharge for 3 to 4 weeks, nothing to worry. That is normal. Okay, avoid vaginal intercourse for 3 to 4 weeks, not to douse or use tampon for 3 to 4 weeks, use of symptoms, inform if there is any symptoms like fever, foul smelling, discharge, pain, lower abdomen, they have to immediately inform you. The complications, there may be, these are all mild complications, there may be mild pain, sometimes fatigue attack, but very less than 2%. It happens sometimes because of the nitrous oxide gas and postoperative infection, sometimes delayed complication like cervical stenosis and reduced mucus intake. This is how it may look like. Okay, so now advantage is that it is effective with mild to moderate lesion. It is inexpensive. No physician, a non-physician can also perform. There are many centers in our country also, I believe, but the nursing staff can perform this procedure. Okay. Then no local anesthesia is required, no electricity is required. It is associated with few side effects and complications. Disadvantage, they say, it is variable success rate with large lesions. So we say that if it is more than 3/4, go for LEAP. Don't do cryo. Destruction leaves no tissue sample for confirmatory diagnosis, but you can avoid this by taking a small biopsy from the most white lesion near the SCJ and then do the procedure. That way you get a tissue to rule out any invasive disease. Difficult to determine exact amount of the tissue destroyed and requires access to resupply of refrigerant, that is nitrous oxide or air. And what are the factors that influence the success rate? It's the grade of the lesion. What is the grade? The success rate comes down. That's why they say in grade 2, grade 3 lesion, it's better to do the excision procedure. Size of the lesion more than 3/4, success rate goes down. Visualization of the margin of the lesion, that is very important. Endocervical extension, if there is, then its success rate goes down. Adequate tissue destruction has to be done, and operator's experience is important. And there are 3 RCTs that they have shown that the cure rate by lesion size, if you say the more is the lesion size, the cure rate goes down. Then there is another study where they have shown that the cure rate by endocervical involvement, if the endocervical involvement is more, is there, then the cure rate goes down. And single freeze, double freeze, there are these RCTs where they have shown that double freeze is better. So this is cryo. Now we come to the cold coagulation. The name is cold coagulation, but actually you are using heat. We are using temperature, increased temperature. So here the treatment of the CIN and benign, sometimes benign cervical lesions using a metallic probe heated to 100 or 100 up to 120 degrees centigrade. It leads to thermal destruction of cervical tissue. Although cold coagulation, but it is actually thermal destruction. And depth of destruction is 4 mm after 30 seconds of treatment with cold coagulation. So these are the equipments which are found. One is this SIMS, which is electrically connected. Other than the battery operated, it can be used in the camp. You don't need of any electricity. That is another machine which has come now, handheld machine. So one is the SIMS, other is the WISAP cold coagulator. They have the metallic cervical probe. There is a wire for electricity connection in the SIMS. Other one doesn't need. There's battery operated, or you can power it. You can just plug it and recharge it. And you need a colposcope, cervical speculum, light source, and a couch. So you need it just give the efficacy, detect the lesion, and then just you can do it. So same thing, patient in the lithotomy position. Of course, you take the consent and everything, privacy maintained. So cervix is adequately exposed, delineation of the lesion using 5% acetic acid and leukocidin, colposcopic control where colposcopy is available, set the cold coagulator at 100 degrees centigrade, apply the cold coagulator probe on the cervix and heat for 45 seconds at 500 degrees centigrade. Okay. Up to 5 overlapping you can do. Okay. With this here. One lesion, if it is big, you can treat it with 5 applications, each lasting for around 45 seconds. And more than 90% of the lesion requires 1 to 2 applications. Once you have done, how to sterilize the equipment, wash and clean the probe with the use of cold water, wipe it dry and heat it for 45 seconds at 120 degrees centigrade. It is ready for reuse. That is the best part of it. It can be used in the peripheral center where you can go and see and treat. Side effects and complications are extremely rare. More than 95% effectiveness in curing CIN. Post-procedure instructions are same as cryotherapy. Okay. Another ablative technique is the carbon dioxide laser vaporization. This is how the machine looks like. We also do have one, but then it is, I think, with the cryo and all this cold coagulator, this is just for the sake of presentation, I'm showing you. It is useful in taking care of this VIN or vein lesion. When you've done a hysterectomy, there is a ball, you get a lesion in the ball. In those situations, this comes into play. So I have another video, but I don't know whether it works. Let me see.
You finish.
Not work from sir. Okay, so this is how the laser vaporization works. In these patients, actually, for a the second time, and then the lip excision was done, and then we tried to. This is how it is particularly helpful while dealing with the cases of pain, which I have already told. So now again another one, yeah. So this is again the same, yeah. Here we are trying to the margin. Anyway, same thing, almost same. Here we try to burn the edge of the lesion just to show you. So now this finishes the ablative technique. Now I'll go quickly to the local excision technique. The most important or most widely used is the large loop excision of the transformation zone, LESH, or loop excision of the loop electrosurgical excision procedure or LEEP procedure. Then we have the cold light conization and laser cone biopsy. Okay, so now this LEEP, the carbon dioxide laser and conization. These are 3 techniques which will be discussed. That we know that this Sir Walter Prandewell, he's from Ireland. He's regarded as the father of modern day loop excision surgery. I was fortunate to be trained under him for some time. And he was the person who has told us about this modern technique of using a blended current and the loop, a large loop excision of the transformation zone. So when do you do this excision procedure? When we have got a biopsy proven high-grade lesion. Okay, then you have the type 2 transformation zone with high-grade lesion in pap smear. Then you have the glandular abnormality on pap smear. Then if you have a positive endocervical curettage, biopsy consistent with microinvasive disease, discordant biopsy, and cytology report. Okay, so these are the equipments which you need. A very good couch, then privacy should be maintained. You insulated speculum that is needed with a smoke evacuation system. If you see, there is a the top part, there is a tube. So you connect it to the suction machine or a smoke evacuator, and you get these smokes are all evacuated out. And then you need this dental syringe with a long spinal needle fit and with local anesthesia. Okay. So now these are the various sizes of loop. that you have to acquire before performing this surgery. Okay. Okay. So now the commonly used power setting for the defined loop electrodes are as if the smaller the size of the loop, the electricity power wattage will be less. The larger, if you select the larger loop, the wattage should be increased. Then it works effectively. And the electrosurgical current applied to tissues can be one of the three effects. Generally, they do the cutting by desiccation, cutting, and fulguration. And the key advantage of leap over cryotherapy is that it removes rather than destroys the affected epithelium. So that is what the key advantage. So all this, whatever I have told, is there in a very good book by IARC. It is freely downloaded. You can download it from the IARC website. You can just go there and just find this book and you can download it. Everything is written in such a crisp manner. You can just read it once and you can start doing the next step. Okay. So loop electrosurgical excision procedure of the again video. I think I don't know what's no part, no. So basically, in here, you do the acetic acid, you speculum, everything same. You detect the acetocyte lesion. Then you are planning to excise that part, but with a loop electrode. Okay. So now what you do, you just first step is that just do local anesthesia, 1 to 2 mm just beyond circular pattern, all side. You can give 1 to 2 ml local anesthesia. Okay. That is the injection procedure. Unfortunately, video is not working, but okay. So this is what you do. Once you have done the local anesthesia, you have detected the ear, you have chosen your loop and you excise it out. You see how beautifully it comes out. And once you have excised the thing out, then you use a ball electrode to just cauterize the area. So this was running that time. Let me check. It's so you see, you have chosen the correct loop, and then the lesion was there. Now, of course, you cannot see it here, but then this is the technique. You go from side to side. That is better. Never go from below up, because if you go from below, never come from above up, then the bleeding will obstruct your ear. This is how you beautifully take out the area. It takes hardly 1 minute time, and you will be saving this woman from cervical cancer, which is taking so many lives in both our countries and also in your country. So this is how very simple procedure. You can just go and take it out. Okay. So the same thing. Sometimes you can use the iodine also. That gives you a better visualization. And then you just go from side to side. Finish out. If by 1 year you pass, you can completely take out the lesion, then it's good enough. If you see it one pass, if the whole thing cannot be taken out, you can do multiple pass. You can do multiple pass like this. One pass you have taken, you have seen that little bit of white patch is remaining in both the anterior and the posterior. You can do two small passes. That is multiple pass. You can take out the whole lesion. Okay. Okay. So I had this multiple pass video also. Okay. This first pass they have done. This upper part and lower part will take now the multiple pass. Okay. It is easy once you have seen the procedure. So this is how the diagrammatic representation. Then one is inverted head. That is, you have taken out the lip and the lesion was extending into the canal for some time. So in those cases, the loop you take out and then you take a square loop and go in the os, go in like this. So it is an inverted head technique. Okay. Understand? First pass you have done. The second one, you take the square loop and in the near the os, you just put it like this and come out. So that is the inverted head technique. You can see here. Okay. So I had a beautiful video. Let's see if it works. So you see the first pass was already done. Now we have taken a square loop. It's working. So this just near the os, you go and take a square out. Okay. So that is the extended part of the canal which you have taken out. Okay. See. So that is ultimately a inverted head technique. Is okay. Sometimes the loop may struck. This video, I know I don't want. Leave it. Okay. So that sometimes if you perform from below up, sometimes the loop may get stuck. Then what you do, you take a bigger loop and take the whole chunk out. Okay. So that is what you can do. So this is a wider loop, the same thing. So this is how the specimen will look like. Mark it, which is the 12 o'clock position for the pathologist to tell you that if the margins are all negative or if it is positive, in which direction of the clock it is positive. So that can be, they will give you a very good idea. So women, what you have to tell them, this woman will have a brown or blackish discharge for up to 2 weeks after lip surgery. Women should be advised not to use a vaginal douse, same like the cryotherapy. Okay, so the complications is sometimes this perioperative bleeding, but we have not encountered anything, and neither will do if it can be done very easily. Moderate to severe postoperative bleeding, sometimes they say moderate to worse discomfort 2%, secondary hemorrhage in 4%, vaginal discharge, cervical stenosis less than 1%. So conization, so lesion extending into the endocervical canal, upper end not seen. Loop you cannot use here. Upper end exceeds the excisional capacity of the loop. Okay, so disparity in cytology and colposcopy, atypical glandular cells on cytology, suspicion of microinvasion, and ECC reveals abnormal histology. The technique is basically laser. You can do cold knife. Now I'll show you the cold knife. Okay, I can show you if time permits. So this is basically the conization. Then the last is just hysterectomy. Basically, if you see a positive cone margin, positive lip margin, coexisting gynecological element, or ACIL in postmenopausal adenocarcinoma in situ. There are few techniques which I have shown you. Cochrane review has shown that no technique is superior than the other. Whatever you have to use. Okay, so they don't tell that I don't have a lip, so I didn't do. But whatever you have, do something for these patients, because that is good enough. And follow-up is that at 6 to 12 months post-procedure, followed up with routine screen, HPV test can be combined with cytology. Generally, after 1 year, we call. And as I've already told you, visit the IRC sites and get all these, download all these things. There are videos, all these things you can download and learn. Self-learning can be done, and you can be a master. Okay, so now conclude. Treatment of CIN resolves around taking care of the transformation zone. Pre-invasive lesions should be managed according to their severity. Excisional and ablation equally effective, as I already told. Regular follow-up, following treatment is the key answer to control cervical cancer. So, thank you very much.
So this time is going to take us through managing colorectal cancer in patients with familial adenomatous polyposis and hereditary non-polyposis colorectal cancer. We are exactly not seeing this diagnosis, but we are seeing them because we are not testing them. We have colorectal cancer in people under 30 years of age. You're able to see it. So we must be seeing it, only that we are not testing it. Yeah. Welcome. Technology not working?
Patients with colorectal cancer and FAP and HPNCC. This is again a set of tumors, as you know, we don't see as commonly because it comprises just around 4 to 5% of our oncology practice. So I'll cover these two in two separate headings. I'll cover FAP as well as HNPCC. Now, for FAP, your key gene is APC. This is well known. And for the Lynch or incorrectly labeled Lynch syndrome, it is mutations in MMR protein genes. So the APC gene, this is just theory, is located on the long arm of the 5th chromosome. It is autosomal dominant inheritance, which means that almost 100% of your patients who have this mutation will develop a cancer or at least polyps. And you usually don't need lab methods to diagnose this. It is based on clinical history as well as family history. In the rare case where you have a doubt, you probably will use an RT-PCR to diagnose the APC mutation. And it's responsible for only 1% of all CRCs, which is why we don't see it as commonly. You have some other similar syndromes, which I'll briefly. The diagnostic criteria is pretty standard. If you have more than 100 adenomatous polyps on your colonoscopy, or you have a family history of FAP with adenomas, or you have one of the associated syndromes like a history of adenomas and extracolonic manifestations such as papillary thyroid cancer, osteomas, or epidermal cysts, then that is when you suspect that the person might have an FAP. This is just a list of some of the associated conditions. It's not just adenomas and colorectal cancers. It starts from the neck and ends up in the abdomen. You might have desmoids as well. You rarely have gastric carcinomas, gastric urinary polyps, as well as congenital hypertrophy of the retinal pigment epithelium, which is quite rare in other scenarios. This is how it looks. It is classically described as a carpet of polyps. And these are the pictures that you see on a colonoscopy. In terms of the clinical features, and this is what we are interested in as clinicians, as I said, it's diagnosed on family history or family. Only 20 to 30% actually present later. They usually develop in late childhood, and you generally have more than 100 polyps. If you have less than 100 polyps, you probably have one of the AFAP or attenuated FAP-like syndromes. And if you don't treat these polyps, then you will develop colorectal cancer by the fourth or fifth decade. Now, the screening is that in patients who have a known FAP or a family history, you need to do a complete colonoscopy between the ages of 12 to 14. And that is the minimum age. Less than 12, you have ethical issues, so we generally don't recommend one. And the primary decision here is surgery once this has been diagnosed. So what are the time points or indications for surgery? Because in patients who have a suspected FAP, a lot of them are actually young. So what do? So these are the 4 or 5 definitive indications. When you have severe symptoms related to the cancer, you have a suspected or documented cancer, and the number of polyps is actually increasing on surgery. This is when you definitely go in and do a surgery and don't wait any further. So this is essentially surgical management. There are 3 classical surgeries. I'm not the best person to talk about this, but I will briefly mention what they entail. So the surgery that was done earlier was a whole proctocolectomy with an permanent ileostomy that's on the left. What is currently done is usually a colectomy with an ileorectal anastomosis. Now, the oldest technique, as I said, was a total proctocolectomy with an endoileostomy. So the advantage of the surgery is that it's almost completely protective against colon cancer, but you need an endoileostomy, and for a lot of our younger patients, this is a problem. So the next step was, could you do an extensive pelvic dissection and do an ileal pouch anal anastomosis? This was the next step in the evolution of surgeries. And again, the good part here is that you avoid permanent stoma. You might have a temporary stoma, but there are serious fertility issues with this kind of surgery, and that could be anywhere between 1% to 10%. So what is commonly done now and is considered the standard of care is a total colectomy with an ileorectal. And so you kind of preserve the rectum. The downside to this is that you can have polyps developing in the remnant rectum. So you need surveillance of that if you have undergone the surgery. And the risk does not happen immediately, but in the 4th to 6th decade. So at that point in time, you might have to look at the rectal surgery as well. So there's very limited medical management here in terms of prevention. There are a number of drugs which have been studied, predominantly anti-inflammatories. None of them have worked. So you go in and do the surgery is what generally you do. In terms of the management of cancers, once it has been diagnosed in these patients with FAP, largely it is very similar to how you treat patients without FAP. In stage 1, it is surgery. Stage 2, it is predominantly surgery. And in a few patients, you might give adjuvant chemo. And in stage 3, it is surgery followed by. So the management largely does not differ from non-FAP patients. 2 similar syndromes. One of them is attenuated FAP. This is something that is also autosomal dominant, but patients here have less than 100 polyps. It's around 30 to 40. And the penetrance of this disease is slightly. In FAP, it's almost 100% that you will develop colonic cancers. Here, it is around 70%. But the management principles largely remain the same. The extracolonic manifestations are lesser. This is MAP. This is also a related syndrome. The key here is that you have 10 to 100 polyps. It presents slightly later in the 5th decade or so. And the surveillance can actually be delayed by about a decade. So in FAP, you probably start surveillance from the age of 12 to 15. Here, it is between 25 to 30. The next hereditary syndrome that is a little more common is incorrectly labeled Lynch syndrome, and it is primarily because of mutations in the MMR genes. So the points to remember here is that you have inherited mutations of DNA mismatch repair genes, and these are responsible for correction of DNA mismatches. It is autosomal dominant, and it is the initial method, unlike family history, is more commonly here by IHC or PCR. And the thing to remember is that not all MSI high is Lynch. These are the common genes that are have alterations in. The commonest is MSH2 and MLH1. There is some geographical variance in this, but the top 4 genes are essentially responsible for about 80% HNPCC. So as I said earlier, if you have 100 patients with cancer, 15% of them will be MSI high, and only 5% of that will actually be Lynch. The other 10% will actually be sporadic cancers. This is a flowchart as to how you find out whether this is inherited or not. And the key things to remember here are to do a BRAF mutation analysis and look at methylation status of MLH1. These are the 2 key points that will help you decide on whether this is sporadic or inherited. So there are 2 important criteria that are used in this space. One is, how will you evaluate an individual at risk for Lynch? And these are the Amsterdam criteria. There are a whole list of criteria. The idea is that if you have 2 to 3 relatives with a Lynch-associated cancer, then you think Lynch. You have at least 2 successive generations, you think Lynch, and at least 1 less than 50 years. So this is for an individual in whom you're thinking of Lynch. The other way to diagnose is in a patient who has an MSI high cancer or whom you think MSI testing should be done. So it's a slightly different set of patients, and here you use the revised Bethesda classification. And in patients who are under 50 or those who have a histopathology of MSI or a HPR finding suggestive of MSI, then you screen them for Lynch. And those who have at least 1 or more first or second degree relatives, HNPCC related tumors. So there are many guidelines for screening for HNPCC. The most established is for colorectal. For endometrial and ovarian, it is suspect. So for colon, it's simple. You do a colonoscopy beginning age 20 to 25. For stomach, you do an upper GI endoscopy between 30 to 35. Endometrium and ovary, I think, are more individualized in patients whom you have a Lynch syndrome. The diagnosis is pretty simple. You can use an IHC, good enough in immunohistochemistry, good, but the gold standard is a PCR, where you use 2 mononucleotides and 3 dinucleotides. That said, the correlation between PCR and IHC is almost, so IHC is good and easy to do. You can also do an NGS, but that is rarely required. So these are some of the cancers that are associated with an HNPCC. It's not just CRC, it's endometrial, ovarian, gastric, pancreatobiliary, prostate, gliomas, everything almost. A little bit on what are the common features in MSI high in Lynch syndrome these are more common on the right. They're more commonly poorly differentiated. And as stage of tumor increases, your MSI high rate decreases. So what is around 20% in stage 2 is around 3 to 5% in stage 4. And stage for stage, MSI high cancers probably live longer and do better. Surgical aspects in CRC, the idea is that at some point in time, they actually thought that a total colectomy is mandatory. It is no longer the case. You do a resection for non-HNPCC like you do for HNPCC, and that is good enough. There is Cochrane data to suggest the same as well. Adjuvant therapy, the one major difference is that in patients who have stage 2 cancers, you would go away from adjuvant therapy in eye cancers because they are usually 5FU resistance. Stage 1 and 3 are largely treated similarly. There is very exciting data with regard to immuno, and this has come just a couple of months back. In localized colorectal cancers, 2 doses of immunotherapy and you achieve a pathological response of 70%. So this is up and coming. It's still not standard, but I think this is the way a lot of us will treat patients in the future. There are a whole number of papers and data about why these tumors are so immunogenic. The easy answer is that they probably have more antigens on their tumor cells, and that brings in the whole inflammatory cascade, PD-L1, and then you block PD-L1, and then the drugs act. But I mean, that's a very short, naive way to look at it, but more antigen presentation, more PD-L1, more inflammatory cells better drug activity is probably the way you look at it. The two targets that we currently look at are PD-L1 and CTLA. In the coming years, there are at least 6 to 8 more that will come, like LAG3 as well. In advanced metastatic colorectal cancers, which are MSI high, the standard of care is immunotherapy. You have wonderful responses. 25 to 30% of these patients are long-term survivors. And the current data is for a drug for pembrolizumab. Again, cost is an issue, but if you can treat these patients with that, that will treat. To conclude, FAP and HNPCC are rare causes of CRC, but we need to know them. As our populations are younger, we need to keep regular screening is important. Primary therapeutic approaches for CRCs focus on surgery and the type of surgery. And in HNPCC patients, their MSI high. This is a biomarker for response to immune checkpoint inhibitor. With that, I'd like to thank you for your kind attention. Thank you.
At Tata Memorial Hospital, and is also a professor in the Department of Medical and Pediatric Oncology. And now he'll be coming to us to present about pediatric oncology, focusing on lymphomas. Welcome, sir.
Pediatric lymphomas. Initially, they had given me lymphomas and bone tumors together for 20 minutes, 30 minutes. So, I can't do because lymphomas itself is such a big area. But let me start by telling that, the cancer cases, you have heard this in the first talk also this morning, cancer cases are increasing worldwide. And the same is true even for the African countries. And since in India, Africa, the population is young, there are many pediatric cancer patients in this country. So I think Africa, India, China together will have more than 50-60% of the pediatric cancer cases of the world. Now I have to speak on lymphomas, and it's important to know that lymphomas and pediatric cancer overall, if you see the incidence, are much different in Africa compared to the other part of the world. And especially as you can see on your left-hand side, basically you see that 30% of pediatric cancers in India, in other developed countries, are leukemias, and especially acute lymphoblastic leukemia. And another 20% are basically CNS tumors or the brain tumors. And but if you see here in the African, the data is from Uganda. If you see Burkitt's lymphoma form nearly 28% of the cancers. So that's one of the biggest group there. The ALL on the other hand is only 9%. And the other lymphomas, if you see, are around 10%. And Kaposi sarcoma, which we hardly see in India, is nearly 22%. So the type of lymphomas also that we see in Africa is much different than what we see in the other part of the world. And very, very importantly, this is the first thing, because many cancers, I don't know, in India it still happens, and maybe it is happening in Africa also, that many of the pediatric lymphomas are being treated by adult oncologists. And very big mistake that they do is they treat the pediatric cancers also as they treat the adult lymphomas, and this is wrong. Because it has already been shown that if you treat a pediatric lymphoma with the adult protocols, the outcomes are much, much poorer than what we do when we treat them with the pediatric protocols. And now nearly 85-90% or maybe 95% of the pediatric lymphomas are highly curable. So we cannot do that mistake of treating pediatric lymphomas as adults. And this is the other part of it, that even the type of pediatric lymphomas are much different than the adult lymphomas. And especially as we know, in adults, we have a big chunk of follicular lymphomas, which we hardly see on the pediatric side. So the pediatric follicular lymphomas are very, very rare. On the other hand, if you see, and this happens more in Africa, we have a big chunk of basically Burkitt, the small non-cleaved cell lymphomas, which is a big number as compared to what we see in the adults. And even the lymphoblastic lymphomas are very much there in the pediatric population as compared to adults. So even the type of lymphomas are different. And this, on the other hand, in Africa is much different again, because they hardly see, the lymphoblastic type of lymphomas. They see mostly other Burkitt lymphomas, which is basically treated much differently than the other types of lymphomas. And this is what is important. And I always say this again from somebody from Africa. You all must already have read this note, but it's very important to respect the past. Because if you don't know where you have come from, you'll not know where you are going. And what happens is many times when you see the the such good responses from the West, everyone wants to treat them on the same protocols, and that has failed miserably in many parts of the African countries. And we have to keep in mind that we have to have, though you can think globally, we have to act locally, and that's very important to keep this part in mind. And why I'm telling this is basically I worked in. How many of you have heard about INCTR? Anyone has heard? One person. Anyone has worked with INCTR? So INCTR is in International Networking for Cancer Treatment and Research. So this was an organization set up by the person shown here, who is basically Ian McGrath, who was initially at the NCI in USA, and then he left everything and came to Belgium and set up this institution because he wanted to improve the outcomes of cancers in the African countries. And actually he's one of the first one to develop the blueprint for improving cancers in Africa. And especially the senior people here must have worked with him, because he was really working a lot with people in Africa. And he had set up a protocol initially, the COMP. Actually, the first curable protocol in Burkitt lymphoma was set up by him. And he was lucky enough to work with Burkitt, Dennis Burkitt himself in Africa years back. So really, he has done a lot of work in this area. So, I presenting this because this is a protocol which he developed for India and Egypt actually year back in 1984. That's why it was called the MCP 841 and 842 protocol. The 842 was the 84 protocol second, which was for lymphomas. And you can basically you can see this protocol had no high dose therapy. Unlike most lymphoma protocols have high dose Araci, high dose methotrexate. This protocol had basically lower doses of treatment, but very importantly, it developed this so that it can be used in developing countries. And this, mind you, this is in 1984 that he had developed this protocol. And you give basically 8 cycles of this, 4 cycles of A and 4 cycles of B. So the protocol was A followed by B, followed by A2, B2, A3, B3, and A4, B4. So 8 cycles of therapy, which used to get over within 6 months. And this was a common protocol for all type of lymphomas, so it was not different for this. But very interesting data that came out of it was this. And this is the initial data way back in 84 that you can see here, basically that patients who got the lymphoblastic lymphoma patient who got this protocol did reasonably well for this. Now we are 90, but that time it was 70, 75%. So nearly 70% outcome. On the other hand, the patient with it's the other way around. The patient with non-lymphoblastic lymphoma did well, relatively well, whereas those with lymphoblastic lymphoma did not do well. Because as we know now that lymphoblastic lymphoma has to be treated like ALL, and you have to give a longer therapy and all. But this was way back in 1984 that he did that. And patient with Burkitt's did around 70%, so that was not bad. And this is exactly what was reported at that time, even from the USA. Patients who were treated on the LSA to L2 protocol, which was basically ALL-like protocol, they did really well on the patient with lymphoblastic lymphoma, did really well with that. At the same time, those with non-lymphoblastic lymphoma did poorly. And the other protocol, the COMP protocol, which was again developed by Dr. Ian McGrath, the Burkitt's people did well, and they, basically the Burkitt's did not do well with the ALL type of protocol. So this was, again, we came to know, but this was published later. Like I told you, our protocol was in 84. But then what we did is what to do with this data now. So we thought, rather than changing to a protocol which is from the West, which we knew we couldn't give the high dose because supportive care was not that good that time and a lot of logistic problem. So we changed for the lymphoblastic lymphoma, we changed to the protocol, the BFM protocol. And you see with ALL-like therapy now, our outcomes went to 90%, or more than 90%, which was as what has been reported from the West. So patient with lymphoblastic lymphoma, we thought this is 6 months therapy is not good. So we changed that completely. But what about the other thing that we learned actually again from the West was that the BFM protocols, again, the BFM 90 and 95 was that patients with lymphoblastic lymphoma do not need radiation therapy. Even though you have residual tumor there and all, they don't need They don't need cranial radiation and they don't need medicinal, which was a standard of care at that time. So we removed radiation from that whole protocol. So that was one thing we learned from the West as well as our own data. But the other way around, for the Burkitt's, the standard protocol was LMB protocol, which is a very aggressive protocol with high dose RRC, high dose methotrexate, and 100% of these patients develop mucositis. They require supportive care, TPN, peripheral line, all that. So which was very difficult in our country. And people they couldn't have become standard of care at Tata, at least where we see longer, a high number of patients with hardly 40 beds that we have. So we modified the protocol again, the same MCP protocol, but we did some changes. For example, by that time, uric acid, because uric acid going high is a very important problem in the initial part. Then it requires, dialysis and all that takes a lot of time, and you lose a very important period. So we started using uric acid, which was available in generic form by that time because it was very cheap compared to the original molecule. And then we started giving this concept also came by that time that you have to give pre-phase therapy to this patient, bring down the tumor, make sure they are in good general shape, and then start the regular protocol. So we did that. And again, we make sure that there are no delays in the initial treatment. So all this helped us using the same protocol. We did not change any of the MCP other protocol. And you see here, for stage N1, 2, we had nearly 100% outcome. And for stage 3 and 4, nearly, if you see, a 78%. So using the same protocol, if we improved the supportive care, made sure the patient was in a good shape before starting therapy, we could improve the outcome without becoming really as intensive as what has been reported from the West. And the other thing that came over the years, now this is, I'm giving you a glimpse over next 15 minutes for the last 30, 40 years that has happened. But if you see the next thing that came with the availability of rituximab, people started adding rituximab in patients, especially with the high-risk Burkitt's lymphoma. And this if you see, the outcome of rituximab chemotherapy was better than those that with chemotherapy alone. But again, we have to keep in mind what works for you, not what works for the West. And if you see, this is a Tata, which again we published recently. You see the Tata outcome. The patients who got with Burkitt's lymphoma who got rituximab, the outcome is much lower because we lost many patients with infection. We had a spurt of CMV pneumonitis, and we lost at least 4 or 5 patients of Burkitt's because of CMV pneumonitis. So using rituximab, though it looks so simple, and we are using it for other patients also, but when we gave it to a Burkitt's, the outcomes came down. And if you see the patient who did not get rituximab were doing the same what I showed before, around 80-85% or nearly 90% outcome, long-term outcome. So definitely we have to keep what is your local problem as compared to what has been reported in the West. So that's for the Burkitt's lymphoma. So next comes the ALCL. I don't know, that may not be a big problem here. But again, for ALCL, it is different. Like I told you, for lymphoblastic lymphoma, you have to give, ALL like a delay, a prolonged protocol. But for Burkitt's, you have to give short-term but intensive treatment. Whereas in ALCL, you can do both. So since we couldn't give intensive treatment, we thought whether if we can give less intensive treatment, but give maintenance. So the same 842 protocol, if you add maintenance, whether that will improve the outcome. And what we did by that time, we knew that for ALCL, somehow vinblastine is a better drug than vincristine. So the same 842 protocol, we changed vinblastine for vincristine. Otherwise, we kept the same protocol and only added up to 1 year of maintenance at the end of treatment. And see, our outcome for that was nearly 86% overall survival. But very importantly, we see it for the lower stages, it was even better. And for the stage 3 and 4, it was around 85. So definitely by just changing the protocol, making the changes as per the available information, but not going for the intensive protocols, we could improve the outcome even in this group of patients of anaplastic large cell lymphomas, which is very important. This actually we have been published this data now. So, and the last one is the diffuse large B-cell lymphoma. These were already doing well before also, and they continue to do well. So even the DLBCLs, we are using the same 842 protocol, and with really 86, nearly 93% outcome. So overall, the MCP 842 protocol has been a real boon for us, and it's a non-intensive protocol, does not require a lot of supportive care. And why I'm telling you is, again, unlike that, in Africa, what has happened was they tried to give the LMB protocols and all the intensive protocols. It failed because many patients died of infection and lack of supportive care. So what they did, they went to the other spectrum. And this again, Dr. Megret and all worked. So he had worked with Burkitt, so he knew there's this thing. So you see, this is a typical African Burkitt lymphoma. Now, this type of lymphoma, you can do well with just two drugs, that is cyclo and methotrexate. But what they did was, for all Burkitt's lymphoma patients, they had this less intensive protocol, which failed miserably. So they have already shown that not all Burkitt's lymphoma in Africa is the African Burkitt's. Many of them will be the standard Burkitt lymphoma. So that is one thing. And that they require more intensive protocol. But the other way also, what they showed was that if you do not maintain the intensity, the outcomes are poor. So you can see our outcome of MCP842 not using any intensive therapy is much better than what they've seen, that if you cannot give them intensive supportive care, the outcomes are in the range of 60% compared to what with intensive is around 80. But if you see the number down, nearly half the patients could not get the protocol on time. So the outcome was much poorer. And I feel that the outcome of non-intensive protocol like MCP842 is better. So again, why I'm stressing on this is that basically you have to think about a protocol that is tolerated well. Patients can get treatment on outpatient basis, requires minimal supportive care. None of our patients requires total parenteral nutrition or any nutritional support. Minimal transfusion and growth factor requirement, and no RT. There's absolutely no radiation therapy in our 842 protocol. So this protocol may be more feasible for developing countries with limited resources. Rather than going for the Western protocol, I think we need something that will be okay for our group of patients. So that was the lymphoma, NHL, and last few slides on Hodgkin's lymphoma. Again, Hodgkin's lymphoma is also in the number of cancer cases with Hodgkin's is increasing worldwide. But very importantly, the 5-year overall survival is more than 90%. But the main issue in Hodgkin lymphoma is not getting them cured initially, but many of them after 30 years develop second malignancies, they develop long-term side effects. So main aim in Hodgkin's treatment is to maintain cure rate, but decrease the late effect. And that's very, very important. And same in India, we see more of advanced patients, younger age and different biology. That is, more of our patients are EBV driven. And this may be the case even with the African countries. So what we are doing is we are basically very few patients get ABVD, as we know, but we have more of OIPA and COPDAC therapy, which is a more intensive type of therapy. And basically, very importantly, if you see our outcome, those who had EBV associated Hodgkin lymphoma, the outcome is much better, with p-value being significant than the patients who are not EBV positive. So definitely, it is the outcomes are different in that. But you see here the outcomes with our type of therapy, which is not very intensive, not like BICOP or this thing which has been done in the West. But even with that, we have more than 95, 96% long-term outcomes, overall survival in this group of patients. So very importantly, I think we have to develop protocols which are feasible locally. And one more group of patients is basically those with lymphocyte predominant Hodgkin lymphoma. That also forms a good proportion of Hodgkin lymphoma patient. And even these patients actually with minimal therapy, don't have to be aggressive, just 2 or 4 cycles of therapy, they do really well, and you don't have to be aggressive in this group of patients. So one thing that is important just to take the take-home message would be that treatment of Hodgkin lymphoma has been streamlined over decades from extended field radiation therapy to risk-based therapy. That means we are hardly using now radiation therapy. More and more we are trying to decrease radiation therapy because they are the ones who cause long-term side effects. And we are using multimodal therapy. But in addition to tailoring chemotherapy, radiation techniques also evolved. So if you really require radiation with the improved techniques that we have, improved machines, you have to use that, but at a reduced dose whenever required. And outcomes are excellent, but long-term toxicities mandate the curtailing of therapy as far as feasible. And this is the most important. So, use of immunotherapy. And I feel in next few years, once the immunotherapy is available the checkpoint inhibitors are available in generic form. We are no longer going to use the intensive chemotherapy that we are using. Like Dr. Anand mentioned in the MSI, this thing just 2 doses of immunotherapy and it has made a difference. Same way here, this is a paper published last 15 days back. If you can see here, the outcome, the overall survival is nearly 100%. And this is advanced Hodgkin lymphoma with just 6 doses of nivolumab. There's no bleomycin in this, no radiation. 97-98% patient did not require radiation. So bleomycin and radiation, which really cause long-term effects, they have removed both of that. But even with that 97-98% survival, so less intensive therapy, outpatient-based therapy, less long-term side effects, all this is going to change the way we are treating lymphomas and Hodgkin's disease, especially that, down the line, we will be using much less intensive therapy and, getting cures that we need. So this is what last, food for thought is that, we always say life, actually this is by William Wordsworth, that life is divided into 3 terms, that which was, which is, and which will be. So let us learn from the past to profit by the present, and from the present to live better in the future. So we have to think about what was our past and where we have come now. So unless we keep that in mind, if you just adopt straight away something that is working for the West may not work for us, and we will cause more harm to our children rather than giving non-intensive but basically risk-directed therapy and keeping the biology in mind. So thank you very much for the listening.
So next, we'll take a presentation again from the very Professor Shailesh Shikande, who is a professor of surgery, head of GI, HPB Surgical Services, and Division of Cancer at Cancer Surgery at Tata Memorial Center, Mumbai. You'll be discussing the topic, what is the way out in unresectable pancreatic adenocarcinoma? Basically, we'll be continuing from where I left the question before lunchtime. Welcome, sir.
So good afternoon to all of you. And I think now it's time to discuss an extremely aggressive cancer, about percentage of cases that we operate. And hopefully I'll show you a situation where things are getting slowly better for a very aggressive cancer, where we have not managed to improve the prognosis as much in the last 50 years as compared to, say, other cancers. Dr. Banavli spoke about it, that if we don't learn from the past, we are in trouble. And he's very right. And this is what is the saying: those who cannot remember the past are condemned to repeat it. This operation was described actually in Italy in 1898 by an orthopedic surgeon. But this operation became famous after Alan Oldfather Whipple, because he published 3 cases in 1934 in the Annals of Surgery. But the more important thing is just see what happened to the 3 cases. First case died within 1 day. Second case died on post-operative day 8. Third case took more than 2 months to recover, but did survive for a little over 2 years. So one needs to learn something from this, that this is a dangerous operation. What's the standard of care for resectable pancreatic cancer? And the answer is here. The answer is that if you do good quality surgery and completely take the tumor out, and good quality surgery means standards in pancreatic surgery. It means margins, it means lymphadenectomy, it means optimally choosing patients, optimizing them, and giving them an optimal outcome, which you should be able to achieve in about 70 to 75% patients, where they recover within 2 weeks, and they are in a position to start chemotherapy, say 4 or 5 weeks after surgery. Only giving chemotherapy has no relevance in pancreatic cancer. And the reason is very simple. If you are going to be giving patients less chemotherapy, 1 cycle, 2 cycles, 3 cycles, people are not living long. It's as good as not treating them at all. So you need to treat them fully, and then you see the improvement that we have had in 2018. The red line is modified FOLFIRINOX. The blue line is gemcitabine, the gold standard for 2 decades. So 35 months with gemcitabine, but this was 6 cycles completed. So the key message is complete surgery and complete chemotherapy. There were also other lessons from this particular study, and the lessons are very straightforward. Adjuvant FOLFIRINOX demonstrated a biological effect
indicating that even after surgery done first, there was microscopic disease on which chemotherapy works. We talk so much about circulating tumor cells. We are all aware that there is cancer lurking. We haven't got the diagnostics, but this is telling you that there is cancer even after good surgery. This was one lesson. The second lesson, we have apparently done successful surgery. Even after surgery, why this sudden drop off? So there is an early fall off in survival due to death from disease progression in patients treated with upfront surgery. So you thought you have done your scans, you have done your PET scan, etc. It is localized disease, you have done good surgery, but even then patients die quickly. One, because biologically it's aggressive. Two, it was perhaps already metastatic, unknown to the eye and the way we understand it. And this is what I told you. 50% of the patients, ground reality, these are not the figures of Tata Memorial, but we would have about 20% to 25% patients who may not complete 6 cycles of chemotherapy. But if you give 6 cycles of chemotherapy, patients live much longer. But see what happens between 1 to 5 cycles. People do not live that long. So work very closely in a multidisciplinary setting when it comes to unresectable pancreatic cancer. So now with these challenges, we have thought, should we be giving chemotherapy first? So where would we give it? We would not give it for all the categories of defined pancreatic cancer. For simple purposes, you will divide pancreatic cancer in your brain in the clinic in resectable pancreatic cancer, unresectable locally advanced cancer, and the gray zone in between, the borderline resectable cancer. So now the borderline resectable cancer and locally advanced cancer, if you give them chemotherapy first, where do you see the fact is that your R1 resection rate comes down. So it's very much an advantage that you are able to offer many more R0 resections by giving chemotherapy first. And perhaps we have a better prognosis as well. Now, why is all this important? Because this operation is high morbidity and also some mortality. You have challenges of not just the artery, but also the blood vessels. Head, uncinate process, neck, left side of neck, body, tail. You have multiple vessels from the small intestine, from the jejunum. You have a critical blood vessel, which is the gastrocolic trunk. And in periods of learning and even in expert hands, right at the beginning of the operation, this can be one of the most frequent bleeding points, even in the hands of surgeons. I won't even say residents. So the minute this tumor is growing here, this vasculature is getting compromised. May not be because it is aggressive, but just the inherent location and anatomy of this deep-seated organ. Now we complicate the picture by adding the arterial pictures to it. So now just to the left of the vein is the artery. All critical blood supply, if the superior mesenteric artery is gone, the bowel is gone, and it's a certain mortality. The common hepatic artery is gone, the liver is gone, another certain mortality. So when you have tumors which start involving some vein, we are already worried. When they involve more vein, we are definitely worried. From more vein, they can involve some artery, which is already becoming almost impossible. And then when they take the whole artery, that's what you will say, that what can we do about it? And that's the brief of my talk. Kind of taking a teaching lecture, but just showing you that you see the axial CT scan, just one good high quality triphasic CT scan. You require one interested radiologist and you require one interested surgical person to understand this anatomy. With one good triphasic CT scan, we don't need fancy investigations. A good CT scan of the thorax and abdomen is enough to stage pancreatic cancer. Doing a PET scan is not a must. In some cases, but otherwise it's not a must. So you saw how I can trace the anatomy, and I don't require radiologists for this. I study this myself to be able to trace it. We always visualize a CT scan as if we are watching from the foot end of a patient, and then you can study the whole anatomy, including every single vasculature that you need. So when you do this,
On the left side was a resectable tumor, and on the right side, you see the contact of the tumor with the vein and with the artery. So this is borderline resectable, this is danger zones, and this is where it's very easy to say not operable. And then it's even more easier to say a bad cancer prognosis has not changed in 100 years. Why should I waste my time? Let me go to the next OT and do a breast cancer. I feel good about life. It's a choice. You can do that. But after the venous phase, you do the arterial phase. And again, the same thing. I'm going to study the relationship of the celiac axis, the superior mesenteric artery. Of course, I'm focusing on the right side and the middle pancreas. I'm talking less about the left pancreatectomies for constraints of time, but that's also pancreatic cancer, relatively simpler surgery as compared to right-sided surgery. I won't take so much time, but just to tell you, see the location of the tumor in relationship to the SMA and SMV, but still just a large tumor pushing. But here you will start seeing that there are challenges on the right side. You see the main portal vein, you see the common hepatic artery. That's what you are tracing again. That's the axis. That's the SMA. Now you see the contact of the SMV and the SMA with the tumor. Now, if you're going to cut through this tumor and come outside and tell yourself and the patient you did a Whipple, you have actually done nothing. You have only harmed the patient. So this is what I mean about surgical excellence in the era of better chemotherapy and radiotherapy. So this is again resectable and this is borderline resectable. Till 2008, all these patients were inoperable for me. After doing standard Whipples for 6 years, all the situation that I discussed with you in the previous slide, inoperable. But then with one good radiologist, we started studying length of contact, circumferential contact in terms of degree, and venous deformity. Is the tumor pinching the blood vessel, encasing the blood vessel, or just pushing the blood vessel? So that's how it happened that in this paper, we published a series of 12 patients where we did a little bit more extra, but then your confidence starts to increase. We also realized the other situation that when it is just in contact with the vein, you might be able to scrape it off the vein and you will think, I'm a great surgeon, I saved the vein. But remember, in 40% of patients, even though you take it out, you will be wrong. You will be leaving microscopic disease behind. In other words, for every general surgeon, the biggest fear is bleeding. For every laparoscopic and robotic surgeon, the only fear is bleeding. If you can handle blood vessels, you can handle anything in any part of the body as a surgeon. Now comes the concept of making the more aggressive or the larger and the complex tumors operable. I've been a part of this where there is a defined concept of extended lymphadenectomy published in 2014. Yes. My father passed away 3 weeks ago. He was 93 years of age. And he always said one thing, that unless you sweat in peacetime, you will bleed in wartime. So you should know how to do the simple operations well and learn some techniques of attacking the blood vessels. This simple video is not of a vascular involvement. It's a video which shows you how I stay to the right of the artery but expose the whole artery and get the whole tumor out. We ended up defining this as a superior mesenteric artery first approach. And this is one of my papers, which I can proudly say is one of the most well-cited papers in the British Journal of Surgery in the world, because you want to safeguard the artery, which is the critical structure. The vein can be removed and replaced. So that's what we try to do. The second thing is it's not only about uncinate first and SMA first. You see that difficult operation where we have done subadventitial dissection, post-chemotherapy, post-radiotherapy. This operation, without sounding arrogant, I can tell you if I look at the whole world, 90% of the times this is inoperable. But this is operable is what we have shown you. And this is fairly routine in our team. So what did we learn? That the smaller tumor stay to the right of the vein. Vein involved, go to the left of the vein, but safeguard the artery.
tumor involving the artery go on the surface of the artery or go subadventitially, as described by Professor Yi Miao from Nanjing. He does about 700 pancreatic operations a year. So this is what is surgical excellence and not surgical exercise in the era of multidisciplinary care. So operation which was not done routinely in Tata and almost impossible from 2002 to 2010, slowly started doing more, and now this is so routine. Tumor hanging on the vein, 2 vascular clamps, 150 Prolene suture, 13 millimeter or 17 millimeter needle, round body double-ended. In 13 minutes, you are able to do a primary vein resection and the tumor is completely removed. Sometimes the vein is not available below for reconstruction. Not available. Your CT angiography, that this was a lawyer, tumor involving here, but there were collaterals helping me. So if you don't have a vein to reconstruct below, what do you do? She was told operation can't be done. I've gone below the neck of the pancreas, safeguarded the splenoportal junction, gone to the tumor till here, resected the vein, but before resecting the vein, I have made sure that I have put bulldog clamps. You can see these bulldog clamps. I took a break, came back 10 minutes later, and I knew that the bowel is pink. So you do a vein resection without reconstruction. So this is something where you start to realize you can do more and more. But I spoke about everything about anatomy and surgical skills. Please don't forget the patient and the tumor biology. So this doesn't happen in every case. And we can do this. This is an example of a tumor involving the vein or touching the vein. For me, surgically, this is possible to be operated upfront. No problem. We will take this out. But the pancreas clinic, a multidisciplinary clinic, rightly said that CA19-9 is high. There is involvement of the vein. We should first give chemo. We did that. CA19-9 came down. Patient was doing fine. This is that same patient. That white area is the portal vein involved. This is the area of involvement of the uncinate process tumor with the vein. The triangle tissue, the tissue between the celiac axis and the SMA where the tumor spreads in the retroperitoneum, should be taken out completely. So the triangle operation is an area of big interest in Whipple's, all done, tumor completely out. Now we have a series all of a sudden. Remember till 2010, hardly doing any of these. Then 201 operations. 148 of them have received chemotherapy first. Some of them have got upfront surgery, but now in our team, almost everybody for borderline resectable and locally advanced disease will get proper, appropriate chemotherapy. Requires a lot of teamwork, but it's possible that patients can get good survival. Next phase was if artery is involved. This is a case where the hepatic artery was involved. I divided the splenic artery and used the splenic artery to join here the right and left hepatic arteries. Vein was not involved, pancreatic neck was easy, bile duct was divided. So we began with a small artery resection. And in the initial period of 8 years, we have done 63 of these extended pancreatectomies. We have had 6% mortality. We have done 31 vein resections is our data. But now just see what we have published this year. After that period from 2016 to 2019, we have almost doubled our vascular and multivisceral resections to answer your question. And in that period, our denominator of pancreatic resections has also increased. It's an open access. I was angry with British Journal of Surgery. I got a good review from a top-notch editor. And the review was good and I could have answered all the questions. And yet they rejected it. And then they sent it to British Journal of Surgery open. Fine, it's still a good journal. 3.9 is the impact, but I think it was meant for something better, as all authors feel, that apart. So, but I know this is good work. They also know it. So the Whipple resections are so many. We have distal pancreatectomies and we have a small percentage where for such vascular resections, we have to take out all the pancreatic, entire pancreas as well. So the next phase is this tumor. This was a 2-minute joint clinic decision for me till 2010 or 14.
Celiac axis completely encased, splenic artery gone, common hepatic artery gone. 3 to 9 months survival, leave them alone, don't trouble them, involve palliative care early, and we are fine. Now, this is the same patient who has got chemotherapy and radiotherapy. This is not me, this is our entire disease management group of chemotherapy specialists, radiotherapy specialists, 12 cycles of FOLFIRINOX, radiotherapy, right crus of diaphragm, aorta, left renal vein. Now you remember the superior mesenteric artery first approach, which I learned in simple operations in 2009. Now it is helping me. So step by step, vein resections is not a worry, but vein was safe. The gastroduodenal artery is supplying blood to the liver. Liver is pink and nice, despite 12 cycles of chemotherapy. If you have a worry, you can always take a vascular surgeon's help and put a graft from here to the common hepatic artery. In this case, we have just divided it and done a complete radical resection. The lady has lived for 4.5 years. She has a recurrence now in the liver. Her daughter incidentally had a cystic tumor of the pancreas, which also we have operated, and the daughter has got operated. So she's from the state of Rajasthan. Is this anecdotal? This is not. So this is what I realize, that you tell me and I forget, teach me and I may remember, involve me and I learn. This is teamwork. Now, this is one more case where I have harvested the splenic artery tissue from the resected left pancreas on the bench and put that over here. This is the resected common hepatic artery. This is the sleeve resection of the portal vein. The thicker left gastric artery becomes thin because I have saved by remembering the technique of Yi-Meow subadventitial dissection. Why did I do this? Because I wanted the stomach to also be pink. We have done about 40 of these operations, and as luck would have it, we have lost a famous cancer surgeon in India. And why did we lose him? Everything went well. We reconstructed everything fine. 2 months later, he was a diabetic and obese patient. He didn't respond well to chemo. He had other challenges. 2 months later, he developed a fundic ulcer, which perforated. Obviously, this is hypoperfusion, microangiopathy, etc. So since then, what did I learn with one example? Either have a low threshold to do a total gastrectomy or have a low threshold to reconstruct the blood supply to the stomach. Don't depend only on the right gastric from the hepatic and the right gastroepiploic from the gastroduodenal to supply the whole stomach. So offer a subtotal gastrectomy. But such patients are now routine, and look at the fact, residual disease, node negative, patient getting home after having received enough neoadjuvant treatment. Becoming better pancreatic surgeons has also enabled us to offer resections for a better tumor in young women. I've also operated on a couple of young patients from Africa as well, where you see the average size in India, like I'm sure in your societies, the first point of contact between a patient and a doctor is pain, and tolerance and not going to conventional doctors is routine. So they come to us with much larger tumors. And the end result is I have to do vascular resections, multivisceral resections, total pancreatectomies, difficult operations, but patients live long because solid papillary epithelial neoplasm is a better entity than pancreatic ductal adenocarcinoma. As I come to the end, beyond chemotherapy and surgery and radiotherapy, we start to look for biomarkers. It perhaps takes 10 years for the first pancreatic cancer cell to develop into finally a tumor and then metastasize. It means we have so much of research to do, and there is a large window for identifying biomarkers, and that's what's going to come our way in the near future. We are still using CA19-9 and our available data, and it just shows that there is a prognostic significance. But in patients with high CA19-9, surgery should be offered if technically and conditionally feasible, only when a response to CA19-9 level to neoadjuvant therapy is achieved. So please do these grand, complex, long-haul surgeries in selected cases. Otherwise, developing skills and confidence can be a dangerous thing. You need to blend it with every single patient's requirements. I presented this. I won't show this to you again. Is this worth it? Whatever I showed you. Most of you might perhaps get out of the room and have coffee and say, yeah, they do all this, but 9 months later they die. Yeah, true. Part of them do die. I don't deny that. But you also have a senior colleague of mine, an ophthalmologist, who has undergone this operation, not a vascular one, but a standard Whipple resection. In 2015, he's running marathons. He's practicing, a busy surgeon. I've taken their permission, so there is no issues. And that case which I showed you is a 38-year-old young man from Gurgaon, from near Delhi, who is in regular touch with me even now. And this is not anecdotes. These are people who do well. What are the newer concepts which come in? I'm closing with this second last slide. The newer concepts is what Dr. Banavli enlightened me about. And that is about using novel approaches to try and see how we can enhance the benefit of treatment for locally advanced pancreatic cancer. Admittedly, this is phase 2, but this is losartan, small number of patients. We are trying to repeat this story to see whether we can treat many more and make them resectable. Again, to answer your question about what happens. So what is the future? The future to me is this. If this is what the situation is, 20% resectable, many metastatic, but many of these are borderline resectable. You give better chemotherapy, sometimes detect early, you are going to reduce borderline resectable to resectable, provided surgeons are ready and trained for it. So it's also a mental approach and a practical approach, where you will start realizing that we will do more surgery for such an aggressive tumor. And one should not fall into the trap that precision oncology and medicine is becoming so fast that pancreatic cancer is going to melt like a GIST tumor, which happened at the turn of the century. Science is not so easy. If that was, then many of us would get a Nobel Prize, but it's not so easy. Thank you very much for your kind attention.
So next, we are welcoming our next presenter again. It's our mom, Amita Maheshwari. She's going to talk to us about surgical management of advanced ovarian cancer.
So good afternoon and thank you very much. So after those two mesmerizing presentations post-lunch, let's discuss something about ovarian cancer. And as we know that majority patients actually of ovarian cancer present with advanced stages. So when he asked advanced and when he asked ovarian, it was same number of hands up, because anyway, ovarian cancer by and large means advanced ovarian cancer. So again, I like to start presentations with a clinical scenario because we are clinicians. So a 63-year-old lady with abdominal distension, no comorbidities. On examination, her PS score was 2. Ascites was present. She had bilateral adnexal masses. And this is her CT scan. You can see disease at multiple places. There is ascites, there are deposits, there are masses. So this is a typical CT scan of an advanced ovarian cancer patient. And CA125 was elevated. We routinely do CEA and CA19-9 because advanced cases, you don't want to miss GI malignancy and treat them like primary ovarian cancer because you never know. And albumin, very important for us to manage the patient and decide treatment plan. So in her case, albumin was 2.8 only. So she had hypoalbuminemia, PS was 2, elevated CA135, CT scan showed extensive disease. So the question is, and those of you treat ovarian cancer, the discussion will be, is she okay for upfront surgery or should we give her neoadjuvant chemotherapy? And if whichever way, is she a candidate for HIPEC? I don't know how many of you have heard of HIPEC. It's heated intraperitoneal chemotherapy, which is something new. So coming to the ovarian cancer incidence in your country, it is actually surprisingly the 5th most common cancer in women, while in India, it is the 3rd most common cancer in women after breast and cervical cancer. As I mentioned, majority patients would present with advanced disseminated disease. You will have disease all over. And the basic principle or management of advanced ovarian cancer until recently actually was that you do surgery, do aggressive surgery, remove whatever you can remove, and be a little aggressive, extensive surgery, because studies have shown that the amount of disease left at the end of surgery, that's defined as optimal cytoreduction. The definition keeps changing. The most recent is no microscopic disease. But if you are able to remove almost everything or make the maximum tumor diameter, which is left behind less than a centimeter, it has survival advantage. So there is a study which showed that every 10% increase in cytoreduction was associated with 5.5% increase in median survival. So you spend extra hours in theater, and Dr. Shailesh showed some wonderful videos, and we know how challenging pancreatic surgeries are. But in ovary, actually, it's at multiple places you have to operate. It's just not one organ. You don't have to focus at one place, but you have disease all over, and you have to remove, put little extra effort. But the important point is, even despite all of this, of course, one is surgical mortality and morbidity, which has been quite reported to be quite significant if you do upfront surgery. And the other and very important concern here is that despite maximum effort, studies have shown that 40% patients only, or maybe around 50%, you are able to achieve optimal cytoreduction, that is individual tumor less than a centimeter. And here comes the concept of neoadjuvant chemotherapy. Since morning, we have been hearing about neoadjuvant chemotherapy in various settings. And Dr. Srikhande just mentioned how in borderline resectable tumor, it has a very important role to play. So likewise in ovarian cancer, we know that primary debulking surgery is not for every patient and not by every surgeon. So you have to select your patients, and those who are not suitable, you give them neoadjuvant chemotherapy. This table summarizes evidence for neoadjuvant chemotherapy in advanced ovarian cancer. We have 5 randomized trials, so which showed that neoadjuvant chemotherapy is not inferior to primary debulking surgery and is associated with less morbidity, less perioperative complications compared to primary debulking surgery. So am I trying to say that every patient of advanced ovarian cancer undergo primary debulking neoadjuvant chemotherapy? The answer is no. We really need to select patients, and that's what I think Dr. Srikhande also mentioned. Extremely important to select patients for any particular treatment plan carefully. So how do we select patients when we talk about advanced ovarian cancer? What are the factors we need to take into consideration? So most important is disease related. So the probability of you being able to remove everything or almost entire disease based on preoperative assessment, and that is generally a CT scan, contrast CT scan. So if there is extensive disease in upper abdomen, there is mets at porta hepatis, carcinomatosis, stage 4 disease, that means you have extra abdominal disease or liver parenchymal metastasis. All these are indication for they would point towards you will not be able to achieve R0 resection. And if you are not very clear, you can do a diagnostic laparoscopy in borderline cases. Another very important point to consider is patient-related factors, including performance status, albumin, age, associated comorbidities, which is also important. And I think in our kind of setup, because we read Western literature, we have to see infrastructure. What facilities do we have? Surgical expertise, anesthesia, ICU facility, intensive care facility, and patient's pocket. You do extensive surgery, you spend 12 hours, and next day patient says that they don't have money to get antibiotic or albumin. So all of these you have to be taken into consideration when you plan treatment for the patient. This is a laparoscopic predictive score to decide upfront surgery versus neoadjuvant chemotherapy. This is our own experience with neoadjuvant chemotherapy. What I want you to look at that perioperative complications have been very less than 4% with neoadjuvant chemotherapy, with median PFS 15 months, which is comparable to what has been reported in the world literature. Whether we do surgery upfront or neoadjuvant, ovarian cancer surgery usually require extensive, multiple organ needs to be addressed. So maybe disease at omentum, diaphragmatic resection, if there is, and all of this, we should take efforts to remove everything, because the most important prognostic factor in ovarian cancer is the amount of residual disease we leave at the end of surgery. So if there is disease in diaphragm, we can excise, do resection, primary closure. If defect is very big, we can put mesh. So this patient had a large deposit, but we could do primary closure after resection. And so little extra effort, little on the part of, surgical team, and you can achieve R0 resection. So these are various surgical procedures one might have to do. And of course, we are fortunate to have GI team and urology team to back up, as he mentioned about vascular surgeon, which we have to call, but all these guys are around and they never refuse. So these are various surgical procedure. I have to be nice to him. So otherwise he'll not cover my theater after we go back. Okay. I think one big doubt those who treat with ovarian cancer is about retroperitoneal lymph node. Do we remove them or no? So at the time of primary debulking surgery for an advanced stage, so there has been a large randomized trial called Lions trial, which looked at whether we should remove normal looking lymph nodes or not. And in short, the results of this trial showed that although nearly 56% patients, when you remove normal looking lymph node, will have disease, 56% patients will have microscopic disease. But the important point is removing lymph nodes does not add to survival. So if there are no nodes are not enlarged, and if you are able to achieve optimal cytoreduction in the peritoneal cavity, no need to remove non-enlarged nodes. If nodes are enlarged, you will remove, because it adds to procedure-related morbidity, but does not give any survival advantage. So it's not recommended to do remove lymph nodes. How about if you have given neoadjuvant chemotherapy? The question is, do you remove lymph nodes then? Again, the recommendation is if nodes were not enlarged, and they are not enlarged, although you will find positive nodes on microscopic examination, but there is no survival advantage of removing normal looking lymph nodes. So these are guidelines. So this is a little controversial question, which is always asked. So if nodes are not enlarged, you don't have to remove in cases of advanced stage. In early stage, we do remove as part of staging, because if nodes are microscopically involved, it becomes stage 3 disease instead of stage 1. So if you have to do lymphadenectomy, I'll just give this thing. What are the tips and tricks? I mean, after Shailesh's wonderful videos, this will look little low level. But the most important thing is adequate exposure. Unless that's very basic knowledge of anatomy and adequate exposure. Don't compromise on exposure if we have to do extensive surgery for ovarian cancer. And that is, I have seen one very, very important rate limiting step. We are very hesitant to take incision above the umbilicus. We are very, miser there. So liberal incision, proper exposure, to be ready. He mentioned about all those vascular complications. Even when we are doing lymphadenectomy, you can face all those vascular injuries. So be ready. If required, use loop. Keep all these things ready. And what we generally use for RPLND is split and roll technique. You divide lymph nodes in various stations, divide them and roll the vessels and remove the lymph nodes. So I don't know if your video will work, likely, whatever we do. No, it's working. Okay, you have to click on that. So this just to show adequate exposure. A very simple thing. Pack the entire bowel away. Bowel preparation is generally required when we anticipate RPLND. So that's, and how we do it, it is, yeah. So this patient had one enlarged node, early ovarian cancer, clinically otherwise, bilateral adnexal masses. What I'm doing on the right side, the structure in forceps is ureter. So take the right ureter away. There was one big node. This is a very useful instrument, mixture or right angle forceps. And I think Shailesh and I both are quite fond of this instrument. We love doing dissections. So idea is to, although it's not infiltrating, but we don't want to injure the vessel. So just take care to mobilize the node well, but it's just not that we will remove one node. If a node is enlarged, we have to do a complete RPLNT. So what I'm using is monopolar cautery. You have to have a good quality electrosurgical unit. I prefer blind current, 30 coag and cut. So what you're seeing here is ureter. IVC and aorta. Generally, in ovarian cancer, we don't need to go retro-aortic and retrocaval. Generally, nodes are either in front or to the side of vessels. But if they are in germ cell tumor, you may find case nodes behind the great vessels. Take care of not to injure IMA, but if it gets injured, just watch for vascularity. The another important point is when we are doing for ovarian cancer, we have to go all the way up to renal vein. Okay, just not inferior to IMA is not adequate. We have to remove lymph nodes all the way up. So you can see IVC, aorta, and this is a common site for nodal metastasis along the left gonadal. As we know, it drains in left renal. So bipolar is another useful thing. If you have bipolar forceps, that helps in in critical areas. It's very useful. So always remove this node. And this is at the end of a proper lymphadenectomy. You can see IVC, left ureter. This is, right ureter, left renal. You can see some lumbar veins. This is right gonadal draining in the IVC. And that's important for gynecologists. If there is any injury or slip of right gonadal, you have to go in retroperitoneum to secure it. This is left on the left side, draining in left renal, and this is hypogastric nerve plexus. The next question is, do we always, I don't know if you have this HIPEC thing in the country or no. HIPEC is essentially heated intraperitoneal chemotherapy, and it has, it's controversial, but both in GI and ovarian cancer, there are studies which have shown that maybe HIPEC has some role, but it's highly, highly controversial. So in ovarian cancer, this was a phase 3 trial, which compared HIPEC and no HIPEC and had shown some survival advantage with the use of HIPEC. But I must admit that at this point, HIPEC is controversial. There was another study which failed to show any benefit from HIPEC. And in primary debulking surgery, role of HIPEC is still under investigation. So we are doing a large phase 3 trial comparing hyperthermic intraperitoneal chemotherapy, normothermic intraperitoneal chemotherapy, and no intraperitoneal chemotherapy. So this is our ongoing trial. We call it Rohini and trial. We have recruited, the sample size is 440, 112 patients have been recruited on the trial. So coming back to our patients, I just gave you a brief philosophy of management of advanced ovarian cancer, who was 63-year-old advanced ovarian cancer. So before starting neoadjuvant chemotherapy, it's absolutely necessary to have a diagnosis of cancer. Don't start neoadjuvant chemotherapy unless we have either cytological or biopsy evidence of ovarian malignancy. So not based on CA-125 and CT scan picture, because we have seen tuberculosis can have similar picture. A primary GI malignancy can have similar picture. There is a very overlapping tumor markers and imaging findings. So after confirming the diagnosis of advanced malignancy, we gave her 3 cycles of chemotherapy because she was performance status 2, and poor nutritional status, extensive disease. She had good response to chemotherapy. We planned her for surgery. And what I want you to realize that surgery after neoadjuvant chemotherapy may not always be a simple one. So this patient, this is her video. You can see disease at the base of falciform ligament. She had extensive upper abdominal disease in the diaphragm. So she required diaphragmatic resection. Now for gynecologists and for surgeons, ovarian cancer generally does not infiltrate. Disease is generally on the peritoneal surface, and often it is easy to do peritonectomy. So in this patient, we did diaphragmatic peritonectomy. There was disease at the base of falciform ligament. And this is a common site for residual disease in advanced ovarian cancer. So if you start carefully looking at this site, you will find disease in many cases. So we removed the entire falciform ligament. There was little darkening, but there was no concern. So continued with diaphragmatic stripping, diaphragmatic peritoneal stripping. You can see the entire peritoneum is like, post chemotherapy. You won't see big disease, but there was carpet-like disease all over. Now, this is just to show if you have a bipolar scissors, you can use that, or blunt dissection if you are in correct plane. So this is entire diaphragmatic peritoneum. We continue with, there was disease in hepatorenal pouch also, peritoneum. So removed that also. So the idea is unless we take adequate incision and go upper in the upper abdomen, you will miss all these things because CT scan often will not show all this. So what is very, and there was a small deposit on liver surface. So had we not mobilized, we would have missed this deposit also. This was a superficial deposit. We didn't call Professor Srikhande, we just removed it ourselves. It was so small. The other thing is if there is disease on the liver surface, in this patient, Gleason's was looking little irregular. We can remove Gleason's capsule also partially or complete based on the disease extent. So there's no concern. All these peritoneum, we are very, very comfortable. Even my 4th year residents, these surgeries. So the other thing, what we did this patient and for every patient of advanced ovarian cancer, for epithelial ovarian cancer, we do counsel them for genetic testing and send them to genetic clinic for testing. We tested this patient also, and she was actually found to have a mutation in BRCA1 gene, and it has implications for her family as well as for her adjuvant treatment. So we did complete her chemotherapy, 3 more cycles, and then put her on PARP inhibitors because she was BRCA mutant. And PARP inhibitors, I don't know if you have access to olaparib or rucaparib or any of these drugs. These are FDA approved drugs. In India, fortunately, we have generics available. Originally, these drugs were very expensive, but now they are highly subsidized because we have, these drugs are made by Indian companies and majority patients have access to. So I think there was discussion on laparoscopic surgery in the morning, and we both said that what is very important in oncology is oncological principle and not the fancy. And before I close, what I want to show what we must not do in a patient who is suspected to have ovarian malignancy. So this was a young girl who had a large ovarian mass, unmarried. A gynecologist decided to do laparoscopic surgery because it was so huge. There was no way to remove it intact through laparoscopically. So first puncture was done. Then the entire fluid was sucked out of the mass. So because she was young, unmarried, thought of cystectomy, opened it, but saw some papillary things coming out. So plan was changed, I guess. And then salpingo-oophorectomy was done instead of cystectomy. But what was done at the end? Look at this. This is not somehow you want to do laparoscopy. So the whole tumor was morcellated because power morcellator was available. And this is not, some rare or unusual nowadays because general gynecologists, they have access to laparoscopy. This has become very, very routine. So we see 5 to 7 patients every week post laparoscopic surgery with inadvertent injuries, spread of tumor coming to us. So what we must not do, that's also important as we grow. First, we learn what to do, and then second step is what not to do, and that's extremely important. And this is my favorite slide because in oncology, what I have learned is biology is the king. Selection is the queen. And what Shailesh also mentioned, that all these technical maneuvers, I'm a laparoscopic surgeon, I'm a robotic surgeon, I do this and that, those I think are of lesser importance. It should be for doctors as well as to the patient. And at the end is multidisciplinary teamwork. Every patient, actually, we have a joint clinic and every patient undergoes through joint clinic discussion. It's not that I'm a surgeon and I have decided no. You have to take opinion from everybody in the team and make the best plan, which is in the best interest of the patient, rather, having your ego deciding what should be done. So thank you very much for your kind attention. Thanks.
Now I'm calling upon my very colleague, Dr. Christina Marichewe, the Queen of Karga. She is a lecturer with me at my building. Welcome, Christina.
Thank you. Thank you so much, Dr. Koko. As he said, I'm a Merck Foundation alumni, and I was in Tata around 2016, 2017. Yeah. So I'm happy that I'm seeing Dr. Amita. You can send my regard to Dr. Jaya, yeah, Dr. Manju and Priya. Yes. So they are all, and Dr. Prabhash Kumar, yeah. They are my mentors and they are so helpful to me, yeah. So I would like to know how many people are working in the palliative, apart from Dr. Zipporah here.
So
All of you. Okay, you might not know what you are doing. Okay. Okay. Once when Dr. Larry came back from TMH, he said one day the saying which moved with me every time when I talk to healthcare professionals, that wherever you do, especially cancer professionals, you do your surgery, you do your chemotherapy, you do your radiotherapy, but if you don't have palliative care in you, then you are doing nothing. That is from Professor Professor Larry Akoko, yes. So palliative care is part and parcel of oncology, but not all oncology that we practice palliative care. That's why I'm a clinical oncologist and palliative care specialist, but we don't do palliative care only to cancer patients, but we have other people with serious illnesses. That's why I think I was given capacity building for provision palliative care for patients with NCDs. So not only cancer, but other NCDs like cardiovascular diabetes, such kind of thing. Yeah. So where are we as a region? So this is an outline of my presentation. And as my colleague said, Dr. Zipporah, this is just a definition of palliative care. All of you said you are working as a palliative care specialist, but also oncologist. So you know what it really means to improve care of our patients, but not only patients, also their families with life-threatening illnesses. And we do not only look at the physical issues, but also we look at as a totality of these patients, physical, emotional, psychological, financial, and all these things. So why NCDs? So these are the facts from WHO. NCDs kill about 41 million people each year worldwide, and which is equivalent to 74% of all deaths globally, not only cancer. So each year, 17 million people die from NCD before the age of 70. And 86% of these, they are premature deaths. And these are mostly occur in our settings, in low and middle income countries. So of all NCD deaths, 77% are in our area where we are working, where we are living. So as I say, it's not only cancer, but cardiovascular disease account for the most NCD deaths, and 17.9 million people annually, they die from cardiovascular diseases. So you can see that cardiovascular kills more people than even cancer, where most of us, we are working in that area. 9.3 million people from cancers, chronic respiratory diseases, but also other diseases like kidney disease, death from diabetes. So these groups of diseases account for over 8% of all premature NCD deaths. So detection, screening, and treatment of NCDs, as well as palliative care, are the key components for the response to non-communicable diseases. So WHO continues that each year, estimated 56.8 million people, including 25.7 million in the last year of life, are in need of palliative care. So there's a lot of people that need palliative care. And worldwide, only 14% of people who need palliative care currently are receiving it. That is globally. You can imagine now in our setting, so approximately 9.67 million people need palliative care in Africa, but a pinch of it do receive it. So why do we need palliative care in Africa? As I said, there's an overwhelming need of effective palliative care in Africa. There's a lot of burden of disease. We have HIV/AIDS, and I know when I started being in a palliative care setting, majority of us, we thought palliative care is only for HIV and cancer in our environment because of the burden of cancer in Africa. But there's an increasing incidence in mortality due to other diseases, as I said before. So the deaths are attributed to increasing and aging populations, adopting of risk factor lifestyles. Now we are changing our lifestyle. We are going like westernized people. So even the diseases that are in the West are coming to in Africa. The deficient of diagnostic, preventive, and curative treatment services. So we cannot sometimes diagnose the disease early. That's why the burden is high. But we also have unmet needs in Africa. As Dr. Zipporah said in her presentation, we have cultural differences in African region. You can see like in Tanzania, we have like 120 tribes just in Tanzania. In all of us, we have different languages, we have different cultural practices. So all of this, they make us having the need of having a culturally appropriate palliative care to our setting. But there's a survey on health hospice and palliative care services in the continent, which shows that 45% of African countries had no identifiable hospice or palliative care activity in African region, and only 9% could be classified as having some measures of integration. So according to African Palliative Care Association, to date, only 11 African countries have palliative care plans or programs somewhere, somehow. These countries like Botswana, Ethiopia, Guinea, Libya, Malawi, Mozambique, Zimbabwe, South Africa, Swaziland, Rwanda, Tanzania, Kenya, and Uganda. And maybe some of the countries who are here, you know, in your country, maybe have some kind of activities of palliative care. But among these countries, only 5 countries across Africa have palliative care integrated into their curriculum of health professionals. So these two are Uganda and South Africa. So majority of us, when you want to study like a degree in palliative care, you have to go maybe to Makerere. That's where they've integrated it, and palliative care has been taken as an examinable subject. Uganda and South Africa. But majority of us, we haven't yet integrated palliative care into a curriculum of professional, including Tanzania. So current status in Africa, I took it from a study that was published by Emmanuel Uirika, and one of the authors is Dr. Zipporah, who is here also. And this, they look at a progress update, palliative care development between 2017 and 2020 in 5 African countries. These were Rwanda, South Africa, Kenya, Uganda, and Tanzania. And in their report, in this paper, they presented that the current status of palliative care in Africa shows disparities in access and quality. Many countries have limited resources, trained professionals, and public awareness. So addressing these challenges is essential for improving patients' outcome and ensuring that palliative care is integrated into national health policies. So in this paper, they showed that since 2000, palliative care has developed significant continent-wide. It has developed significant continent-wide. By 2016, 8 African countries had developed or were in the process of developing national palliative care policy or frameworks across Africa, among those 5 countries. So by 2017, 50% of African health departments had a focal person for palliative care. And by 2020, hospice and palliative care departments had been established in many hospitals and training institutions in Africa, with a total of 10,085 palliative care services, despite economic challenges and the COVID-19 pandemic. So this was published in 2022, just recently. So palliative care is seen as a new discipline in medical professionals. And being a new and being perceived as a new discipline, it faces a lot of challenges that they were presented by the authors. And one of the challenges is lack of awareness of healthcare professionals and the public. Majority of my colleagues, when you tell them about palliative care, they always think of end-of-life care, as Dr. Zipporah also presented in the morning. So they don't think of starting palliative care at the time of the diagnosis, and they think maybe it's too early. You can still do surgery, you can still give chemotherapy, you can still do radiotherapy. That's why they think there is kind of hope of treating and curing a patient. And they wait until the patient is at the end, maybe, of life. That's when they think that patient needs palliative care. And as we were hearing from Professor Akoko, he said palliative care starts when you're still okay. Not only at the time of diagnosis, but even now we need palliative care somewhere, somehow. Yeah. So a lot of healthcare professionals and even the public does not understand the meaning or the importance of accessing palliative care to their patients and even to the families themselves. So major challenge of dissemination of palliative care as a mainstream of discipline of healthcare is serious shortage of qualified and well-trained healthcare professionals and support staff. So we have that lack of trainings, we have that lack of skilled people that can deliver a quality palliative care service. So what do we need in capacity building? So we need human resource development, we need infrastructure and equipment, not only having pain drugs. For example, Dr. Jerry said in the morning, like in our national cancer control strategy, nothing much has been done in palliative care, but there's a morphine that has reached in different districts. But you take morphine to a hospital where there are no skilled person to talk to the patient, to tell them how that morphine is going to help them. And not only the physical part, but we know we need to also talk about the other side of a patient, because as human beings, we are not physical, but we're supposed to be taken care of as a whole. So we need also capacity building in education and training, research and evidence-based practice, as it was well elaborated by Dr. Zipporah in the morning, and also national policy and advocacy program that will help us in the integration and giving services palliative care into our respective countries. So what are the challenges for capacity building faced in our environment in Africa? First of all, limited resources. Many African countries face resources constraints, limiting the availability of funds, equipment, trained personnel for palliative care services. We do not have skilled personnel, trained people, and even, as I said before, trained curriculums to train skilled people to deliver palliative care. But also lack of awareness to healthcare professionals, but also to the general public, to the patient themselves, to know that they have they need to know the benefits of palliative care to the patients and also to their families. Cultural and religious barriers. As I said, we have disparities in the cultural beliefs and all such kind of thing. Also, they kind of give us challenges in the capacity building for Africa. Access to medication. We mentioned about morphine, but not only morphine that we need in the treatment of palliative care, but this is an essential drug that is needed for pain management. But there are other drugs also that are needed in the management of pain and other symptoms that are affecting serious illness, people with serious illness. But additionally, the legal framework in many countries does not support the provision of palliative care, further complicating efforts to improve services. If the government or if the policymakers, then they're not in line with your palliative care, then it's difficult to implement it. But with all these challenges, there are some initiatives that have been done in palliative care for building capacity in Africa. There are some government policies and strategies. Several African countries have developed national policies. For example, I know Kenya, they have a national palliative care policy. Even Tanzania, we have, and strategies to promote palliative care, including establishment of national palliative care associations and integration of palliative care into healthcare systems. There are also some NGO and civil society involvement that took this role in advocating for palliative care, providing services and conducting also research. We have also international partnership, which people, they collaborate in different countries. That helps in supporting palliative care development in African countries. Training and education efforts are underway to train healthcare professionals in palliative care principles and practices, including the development of curricula and training programs. So, for example, in Tanzania, we have some short courses for healthcare professionals, but we haven't reached that stage of having professional like a master's or degree curriculums for palliative care, but still we are in the plan of introducing that into our university. Community-based palliative care approaches are being implemented in different countries, especially in helping individuals in rural and remote areas. So what are the future directions and recommendations? Training for healthcare professionals, that is first. This is very crucial and it's important for enhancing quality of palliative care services. Comprehensive training programs can equip providers with the necessary skills to manage pain and other distressing symptoms. So we need training so that we can capacitate more healthcare professionals in this new field of palliative care. But we need also policy development in different countries is vital for the integration of palliative care into national healthcare systems, as integrating palliative care in primary healthcare as it is recommended by WHO. So governments should prioritize creating and supporting frameworks that supports access to palliative care services and ensure that they are part of continuum of care for patients with serious illness. But we need also to engage communities, as communities are essential for raising awareness about the benefits of palliative care. As I said before, a lot of healthcare professionals, but also general population, they are unaware of palliative care. We need also collaborative efforts, not only for government, but NGOs and international organizations to enhance capacity for palliative care in Africa through shared resources, knowledge, and best practices. Promoting interdisciplinary collaborations for doctors, nurses, pharmacists, social workers, and physiotherapists. But we need also to use technology. We know technology now has advanced and we can do a lot with technology. A lot of trainings, they are online and people can access these trainings and get knowledge on palliative care. So, for example, telemedicine, mobile application, and online training resources can help bridge gaps in access and education, especially in remote areas where healthcare services are limited. But research and evaluation, as this was well presented in the morning by Dr. Zipporah, we need an ongoing research in palliative care. As she said, we have very lack of research in palliative care in Africa. A lot of research is coming from the West and other areas. And data-driven approaches can inform policy decisions and help allocate resources more effectively to meet the needs of patients and family. So in conclusion, building capacity for palliative care in Africa is a multifaceted challenge that requires collaboration, innovation, and commitment. By prioritizing education, policy development, and community engagement, we can significantly improve the quality of life for patients facing serious illness across the continent. Asanteni sana. Thank you.
Thank you so much. Thank you, Christina, for enlightening presentation on what we need to do on palliative care. Our last presenter in this series, then we'll take questions, is Dr. Caroline Hayhurst. She's a consultant neurosurgeon at University Hospital Wales, Cardiff, United Kingdom. She'll be joining us online with the topic management of low-grade gliomas. So the presentation is recorded, but after the presentation, we'll be opening for questions.
Thank you for the opportunity to present today. It's an honor to share this on the notion of battle low-grade glioma that is prestigious. These tumours have historically been viewed as benign, with a watch and wait policy often adopted. Recent advances in our understanding of molecular biology, natural history, and importantly, advances in our surgical technique and technology radically changed our view, which I'll show today. Of interest to disclose, I'm specifically talking today about adductive use of gliomas, the most common CNS tumours, which arise from the small T cells of the brain tissue. They represent a highly invasive disease with broad spectrum ranging from low grade, so these are WHA grade 2 gliomas. Note, some grade 1 glioma is generally reserved for certain well-scanned and discrete tumours, mainly occurring in children and women today. In general, have a survival rate of over 80% at 5 years, compared to high-grade tumours, which are grade 3 and 4, radically different overall survival of 5% at 5 years. The reason to highlight this specific tumours today, general impact patients in the primary low-grade lives, significant impact on quality of life. Common age onset between 35 to 45 years of age, and all common names resulting from abrupt onset of debilitating seizures, emotional deficit, disease to occur, functional brain areas. Students late surrounding structures, and over 90% progress to high-grade glioma, resulting in progressive neurological disability and ultimately death. Brain tumour with an incidence of 6 to 100,000 of the population based on European data, could make the vaccine most of the population alive at any one time, and significant impact on society. So we will look at how there have been changes to some our understanding of natural history, treatment can potentially alter the natural history. Directions, mainly progress in changing foundations, and specifications that this may involve. That's 2060 classification of diet based on C numbers, research dating 2021. Now, a molecular classification and integrated diagnosis. So that goes on our understanding of the isocytric hydrogenated mutation, which is present in low-grade gliomas. Much worse prognosis than these animals. It was often believed that low-grade gliomas were indolent. Even without molecular genetics, we have a number of factors. Based on European data, that is for same as the age group, but includes tumor or decline, This knowledge, our interventions are aimed at prolonging overall survival, importantly to progression, procedure control. I mentioned earlier, intervening at an earlier stage, patients possess fewer and high-risk prognostic factors, but ultimately lead to a longer overall survival with a better quality of life. Historically, attempts at aggressive treatment of these tumors was tempered by the risk of new neurological deficit with surgery. Therefore, watch, wait, and rescan approaches were often used, or in some cases, biopsy followed by watch and rescan. But with some advancements that I will discuss, there has been a move towards attempts at maximal safe resection of tumor with the use of functional brain mapping and wave craniotomy techniques. It was these two pioneers of functional brain mapping tumor resection that's changed. Snitchberger from University of California, San Francisco, from Montpellier in France. In this type of tumor, is that they are very difficult to differentiate from normal brain tissue. There is no clear link between them like other types of tumor elsewhere in the body. We have previously not aimed for a wide margin of resection. It was through these two pioneers and multiple retrospective single institutional series that demonstrated that the greater extent of resection is independently associated with a significant improvement in overall survival and progression-free survival, that the world changed its opinion. Firstly, in 2008, publication by the California team demonstrated with a 5-year overall survival was significantly better than those patients who had less than 90% resection. Similarly, the French player network data 5,000 patients. Similar, much better than progression-free survival. It also demonstrated that where complete resection was achieved was then influenced when they agreed to the time of recurrence. Most significant study today was the Norwegian postcode stratification to form two observational cohorts by taking advantage of the geographical levels in Norway. The distribution of the entire population of 22 centres, one centre on biopsy, scan approach, and a second centre gave no resection. Comparison takes between the respective non-style resection. Median survival median survival was the registered resection time analysis. Unfortunately, there was no significant difference in rates of neurological deficit. There was a significant difference in rates of neurological deficit. Resection rate. This gave powerful evidence for our oncology to favor early resection. The ability to reduce the rate of deficits following surgery comes from the increased adoption of functional brain mapping. This shows self-regulation of the brain. One of the fears of adopting neurosurgery approach is the risk of reducing significant functional deficits in otherwise healthy patients. And also be control of the loss of medication. In our centre, we use a sleep protocol, functional brain stimulation, experienced team of neurophysiologists, procedures. Options, including our executive functions. You may see Trapping is the most common paradigm, the type of speech disturbances that can occur during functional stimulation, loss of speech, quite a specific dedicated team to perform this plan. So in this example, this is a 30 seizures, actually had a biopsy at another centre showing mastocytoma, and after the biopsy had speech impairment. She attended our centre where we performed the speech mapping, and she was a complete resection of tumor. She brings tumor brain, seizure brain. The second example, this is a 28-year-old who presented with classical speech and note mapping. histology demonstrated not only insular gliomas are exceptionally challenging tumor. They're located deep within the sylvian fissure, surrounded by highly elegant tissue, usually traversed by deep capsule capsule. Maximal safe resection has been shown to be beneficial with increased median survival with resection versus biopsy alone. But it should be noted that complete resection are highly variable. High-risk procedure. Patients do need to be counseled with their transient deficit, which is very high percent. Using mapping techniques, the risk of this example, this is a 24-year-old driving he presented with sensory seizures, counsel his options wanted, ready to be attempted in complete reception. She can see from the scan of the right. It was a complete reception. He did a long term paralysis and 4 weeks of so So not all low-grade gliomas can be resected to that kind of outcome. However, we do know that the increasing percentage of resections does increase survival, so that it's benefit resection. In terms of seizure control for quality of life, there is evidence using early radiotherapy, seizure outcome. So with that, what is the role of adjuvant of using radiotherapy at the time of diagnosis, at the time of tumor progression? Didn't show any survival benefit. Historically, treating issues are from radiotherapy. For many years following intervention. However, there was a game-changing study published in 2016, which looked at high-risk patients, i.e. those over 40, stratified them between radiotherapy alone, post-surgery, to radiotherapy plus PCB chemotherapy. And there was a dramatic increase in overall survival in the radiotherapy chemotherapy group. And this was particularly noted in the oligodendroglioma group and really became standard of treatment following publication. So this is our current management in patients who present with either even incidentally found low-grade. Our first option is generally radiography with functional mapping. So tumor of the immediate post-operative imaging, then signal imaging, and chemotherapy. And it should be noted that we should consider enrollment in active clinical trials in all these patients, given the rarity of these tumours globally. One thing to note is that there is no major studies to date on temozolomide versus PCB chemotherapy in low-grade glioma. However, most centres have assumed that there's at least equal efficiency with less toxicity, so temozolomide is frequently used. Moving forward, further refinement of tumor currently increasing excitement about the use of IDH inhibitors, which have shown great promise in early phase trials. The recently reported Indigo trial showed a 61% reduction in risk of tumor progression with IDH inhibitor. It's really the first drug, direct targeted treatment for low-grade glioma. From a surgical perspective, we seek to refine our mapping techniques, view of enabling supramaximal resection with a margin of tumor-free tissue into cancer surgery elsewhere in the body, using functional boundaries, not tumor boundaries. There's a great phrase used by Hugh Defoe to see the brain tumor in terms of our resection techniques. Obviously, all of this does have resource implications. It does require advanced imaging, interruptive monitors and staff and access. And one of the ways to tackle this, learning is adjuncts in Canada. It's a great thing taking his simple wide range of techniques, the training people applied on these. So the opportunities to develop a range of pathways. Patients have the best access to intervention at the time of life. So thank you for listening today. More questions, so reach out to me directly after the meeting. Thank you very much.
We are going to have a session on discussing cancer care management and palliative care. So basically, we are touching on just one aspect of palliative care, because pain management is part of palliative care. So we are going to get 2 to 3 minutes to give our insight on what our multidisciplinary approach to cancer pain management and palliative care, their importance, and approaches that we can use involving oncologists, pain specialists, if you have them in your country, and the role of other health professionals in effectively managing pain in cancer patients. So just to kick off a discussion, many a times we diagnose cancer in Africa and in Tanzania specifically because of pain. That's when patients come to hospital. So they don't come before pain, even if it was a breast cancer. It's a swelling in the breast, it's a thyroid. They will not come. And I normally look at it as being very bad because as a healthcare professional, you think of this patient will have come. But this patient as an individual is having access issues, so they will not come. The money they have don't use it somewhere else, maybe they're seeking alternative care, but exchanging goods they have for some local remedies. And some cultures are just tolerant of pain. In Tanzania, we have the Maasai group where having pain means you are a kid. So as you grow up, you're supposed to endure pain. So they will never scream even in labor room. Because we were taught that's the most severe pain. The Maasai lady will push without a noise. You will never know that there's somebody pushing. So they would tolerate pain. And I think if you're anticipating pain, you'll also be able to tolerate pain. But at the end, who would manage this pain? And my panelists are a mixture from medical, surgical, and we are all walks. So how do we manage pain in a multi-modality, multi-teamwork approach? When do we begin pain management? So we'll move the mic from where I sit and it will end there. So when you take mic, you introduce yourself, the role, and just give your insights on multidisciplinary approach to pain management. You can pick whether it's oncology, surgery, or somebody else you want to manage this.
Thank you so much. Dr. Judith Mukwaira. I'm a general surgeon with a subspecialty in surgical oncology. I'm based in the northern part of Malawi, in a smaller central hospital, a third largest from the other 4 central hospitals that we have. So my role in terms of pain management as a surgeon, I'm part of the multidisciplinary team when it comes to pain control. But just to give you a background so that you understand the team that I have in my hospital, we offer surgical oncological services and medical oncology services. We do not offer radiation therapy. I do not have a radiologist, neither a clinical oncologist in the central hospital. I also do not have a medical oncologist in the although we offer chemotherapy and other hormone therapies. Our medical oncology service is run by a medical officer who we mentored through another central hospital to continue. We do not initiate chemotherapeutic drugs, but for continuation of therapy. But we also are supported by the nursing services in both palliative care team, where there are non-physician officers offering palliative care services and also nurses. We do also have a psychosocial team offering also medical social worker services. So my multidisciplinary team would compose of the surgeons and the medical oncology team, palliative care team, and the medical social workers. So for our experiences, commonly the discussion of pain would start in the preoperative period for surgical oncology patients. So we'll have some patients who have been already studied on morphine from the palliative care team. So the issue now is understanding the goal of their care. Is this, if they're coming to surgery, is this, are they coming for a curative radical surgery, or they're coming to us for a palliative care type of surgery? And that determines how we flow. And my role as a surgeon now is to, of course, fully examine and take the clinical assessment to understand the age and the functional status of the patient and create clear goals for their surgery and understand the approach, the surgical approach. Unfortunately, the surgical approach is just open. So even though we understand that minimal access surgery to provide better pain control post-operatively, that's not an option in my center. I mean, open surgery, but then that means that I'll have to go for incisions that are good enough, just enough for the surgery to be complete, not the keep to kind of incision that we are taught at the time that we find So basically, I do rely on my palliative care team mainly to manage patients, and we just as surgeons just getting up, like I'll say co-offset, although we're not supposed to be co-offset, but that's how it's
Thank you very much. Next. Thank you so much. I'm Paul Kangwa. I practice as a consultant in the division of oncology at Cancer Research Hospital. It's the only comprehensive cancer hospital which is in the country. But come February, we shall have 2 other centers in the country, making 3 in total. At that hospital where I practice, there are only 2 gyne-oncologists and 1 surgical oncologist. And of course, I'm part of the multidisciplinary team, where there is an involvement of the palliative specialists. We have got 1 doctor who is specialized in palliative care. Then we have got 4 nurses who have done specialized palliative care. In addition, we have got the psychosocial counselor. Reason being is that if you look at all these people that I've mentioned, and when you look at palliative, it means that they have got roles to play. No wonder we say when it comes to pain, our focus is on the management, not just pain control. Because when we are talking about pain management, it shows that it becomes an integral part where all these players that I've mentioned have got a role to play. We have got a role to play, and it mostly starts with us, the clinicians, who are the first contact with the patient, in the sense that we are the ones who first identify the pain that the patient is going through. And at the same time, it's us who come up with the assessment of that pain in terms of the severity or the intensity that the patient is having. Then we sit down with the team when it comes to standard of treatment that we are supposed to ensure that this patient gets. No wonder it is about disciplinary approach on our part. And the other thing is that we ensure that we try, especially on our side who are surgeons, we try to ensure that we take sometimes pain through surgery, but at the same time, there is also pain which is going to come through surgery. Reason being, if you look at the entire constellation, the pain that the patients are going to experience, those who have got cancer, it could be that that pain is going to come because of the same tumor or the same cancer that the patient have, or it could be that pain that the patients are experiencing is because of the infiltration or malignancy, so it could be the emboli. So when you look at all those facets that I've mentioned, it requires different players who are going to help. So that's how we tackle it multidisciplinary. Again, we come to fragment what the patient is having. Is it acute pain, which we can quickly relieve either pharmacologically or non-pharmacologically, or is it chronic pain? And even that, are we going to use surgery, or are we even going to use radiotherapy, which is going to give again relief in as far as pain is concerned? But even then, sometimes the radiation therapists or the oncologists say no, say we can still, the patient can still start having pain because of complications which are associated with radiotherapy. So in order to ensure that there is quality of life for the patient, this has to be multifaceted so that we act as a multidisciplinary team to ensure the best for the patient.
So do you think you are the nurse?
We are
What are you missing?
we are still missing certain players. If I look at we have got 2 physiotherapists who help us in as far as some form of physical pain is concerned, but when it comes to what they are supposed to do, we find that it's still a problem on our part. That's why I was talking about the non-pharmacological is still, I think, a big challenge when it comes to pain management.
So let's hear some central aspects of pain management.
Merci. Ça va poser problème parce que il n'y a pas d'interprète. C'est pas comment ça va.
After a moment, where is my friend, the translator? So, what is so?
I'm from Mauritius.
You can translate. Okay. Congratulations.
Yeah, I'm Dr. Jasmine. I'm from Mauritius and I'm a pathologist with specialty in molecular pathology. So I'll be translating.
Je suis Dr. Jean-Paul. J'exerce dans un centre hospitalier universitaire formateur.
So he said his name is Dr. Jean-Paul and he's the director in his university and hospital. And he's a gynecologist and obstetrician.
La particularité de ma situation, c'est que nous sommes un pays post-conflit. Nous sommes un pays post-conflit et quand j'ai été en Inde, j'ai suivi une formation sur la gynécologie, oncogynécologie.
So in my country, we didn't have a complete course. So now I have been to India and been trained in oncogynecology.
Quand je suis rentré, nous sommes une population au moins de 10 491 habitants. Et puis, nous sommes caractérisés par ce point-ci. Nous n'avons pas un programme national de lutte contre le cancer dans le pays. Nous n'avons pas un centre de la prise en charge du cancer dans le pays.
So in my country, we have a population of around 6 million, of around 6 million inhabitants, and we don't have a designated cancer program or a program to fight against cancer or to sensibilize and sensitize the population.
Nous avons que des oncologues médicaux, donc des oncologues médicaux pour le pays. Puis, des oncologues médicaux, nous n'avons pas un centre reconnu pour la prise en charge du cancer dans le pays. Ça fait que le cancer, un seul laboratoire national là où on peut diagnostiquer le cas de cancer, un seul laboratoire national pour le pays.
So we have got only a central health laboratory for the whole country. And we also don't have a cancer-centered patient medical center right now.
Ça fait que les malades qui sont dans les régions, en province, donc ces malades, pour la plupart des cas, c'est des cas de suspicion. Même au niveau des capitales, là où nous sommes, la plupart des cas, c'est des cas de suspicion parce qu'il y a des barrières géographiques, il y a des barrières financières. Vous pouvez prélever, vous envoyer, la malade n'a pas le moyen pour réaliser un examen du laboratoire.
So all the cases of cancer that they have, even though in the capital and in the adjoining regions, they're only suspicious cases. They are not confirmed cases because they have the geographical, financial, and some other governmental hindrances that cannot make them progress forward.
Parfois, vous faites le prélèvement, vous remettez au malade, mais parfois, pour question de moyens, il jette. Il n'a pas de moyens pour pouvoir réaliser ce travail.
So whenever there is some procedures or operations that are going on, due to lack of financial criteria, the patient is not able to afford a histological examination. So most of the post-operative surgical specimens, they are being thrown away.
Ce qui fait que c'est un peu difficile. C'est tout un problème parce que quand on m'avait demandé de parler un peu de cette question, je me suis dit, ben, qu'est-ce que c'est? En réalité, pour le moment, la priorité du gouvernement, le gouvernement mène une lutte acharnée contre le cas de décès maternel. Même le cas de gynécologie, là, c'est un peu, il n'y a pas de soutien pour ça.
The government is mostly focused on maternal death, but there is no support for gynecological tumors as such. So when he was asked what to say, so he's bringing forward whatever he listed down.
Il fait que nous sommes à un hôpital là où nous exerçons. C'est un service obstétrique et de gynécologie. Vous allez vous rendre compte que le côté obstétrical est bien soutenu. Et puis, nous avons au moins 100 et quelques lits pour cet hôpital-là. Mais la partie gynécologie n'a qu'une seule salle et 7 lits où tous les cas, y compris les cas de suspicion de cancer, sont
So the medical center where I am based, it has got only one ward, and that too there is only 7 beds, including for gynecological patients, obstetrics, and suspicious cancer cases.
Les complications obstétricales sont prises en charge gratuitement, mais les cas de gynécologie, donc il y a un coût lié à ça, et ça fait que nous avons eu énormément de problèmes. Nous ne disposons même pas de même colposcope pour réaliser des examens pour la prévention, on n'en dispose pas. Vous pouvez voir un cas de cancer du sein. Sur le plan clinique, vous voyez que c'est du cancer, mais prélever, c'est tout un problème.
So usually the government is freely supporting the obstetrics department. So there is no charge. This is free of cost, but however, all gynecological cases related to tumors do have a cost. Even if someone has got a breast lump and they are not able to do the biopsy.
Et comme la nature aurait de fixe, bon, nous on pratique beaucoup plus cas obstétricaux que les cas de cancer.
And he previously also said that they don't even have a colposcopy, so they can't be able to do either in cases of screening or diagnostic or biopsies.
Donc, ce qui fait que quand vous imaginez les cancers, les cas de cancer, c'est des douleurs très. Une femme atteinte de cas de cancer a différents problèmes. Il y a des problèmes liés à la féminité, des problèmes liés à la sexualité, des problèmes liés à l'infertilité, mais ces problèmes-là ces problèmes ne sont pas encore circonscrits.
someone, a lady in his country who is faced by cancer. They've got a lot of collateral problems, including their feminization, sexuality, but nothing is taken into serious consideration to help them and to make them sort out any diagnosis.
J'avais trouvé que c'était l'occasion de lancer un cri d'alarme parce que quand on forme aussi, il faut accompagner. Nous avons été formés, mais nous manquons totalement du matériel pour nous permettre un peu de nous appuyer sur le terrain.
He said that he wanted to pull the alarm because he has been formed, yes, but he's lacking everything to go forward for his practice for diagnosis and to help those suspicious cancer patients and to make the correct and right diagnosis and to go for further investigations.
Même le malade, très souvent, ceux qui, parce qu'ils arrivent souvent des stades très avancés de la maladie, et puis parfois vous suspectez les cas, même pour les opioïdes, donc les antalgiques des troisième palier, on a disposé un cas. Donc, pour la plupart, la prise en charge du cancer n'est pas subventionnée. Et vous voyez un peu tous ces coûts-là, ça fait que ces malades vraiment vivent une histoire difficile. Les molécules, les chimiothérapies ne sont pas disponibles pour quelques rares qui sont disponibles. C'est très honoré que les malades ne peuvent pas acheter. Et puis, parfois, nous sommes désarmés devant ces malades. Et puis, voilà la situation à nos niveaux.
Most of the people in my country, they can't afford even chemotherapy treatment or any diagnostic because all these bear a cost. There are few cases who can afford this, who is able to get the treatment, but that too, it's not very exposed and they don't have everything to be able to treat these cancer patients. So it becomes very difficult for them to manage in the setup.
Nous, on avait fait un projet. Nous avons essayé de rédiger un projet pour que, si on peut trouver quelqu'un pour le financer et nous aider à faire quelque chose, mais on ne sait à quel sens vous pouvez avec ce projet-là, nous sommes restés à quelque part.
So he's tried to bring this problem forward to some organization and companies to help them, but unfortunately he's been stuck with whatever is here. So he doesn't seem to see the light at the end of the tunnel.
Thank you so much, Jim. So some stories are very sad. The North Central African Republic is besieged. So the government is only running like the capital city. I know our army is there to help stay the government. So that's the biggest problem they have. So I will skip Malicha for good reasons. She knows everything that we are discussing. So in the end, I will ask her, what did we not say?
Thank you. I am proud to contribute on the state. And it's a production and the in Addis Ababa University, in the Salaam Comprehensive Specialized Hospital. I'm the head of the Oncology and the division. And currently, my hospital.
Loudly.
In my hospital, in my hospital, there is a well-established curriculum. That is what we use. Yeah, the sedation, the sedation, this was the first discussions. We also discuss how to provide patient this. Sometimes the patient has single pain, tumors, which are breast cancer, breast cancer, the mouth and breast cancer, that can be used to support for care, and also the breakout from this for Parkinson. They also remove the money of pain by the and the therapy outside of the cases. So in general, what I can say is what the adult can do in terms of biologic care unit, but in each department working as with efficient working because there's my part zero and they will train. Other thing which answers the future and hope you have reviewed of political care because what is working like that and some of the physicians are on training. So for the training, we get started. So but we have having political care on thank you.
Good evening. I'm Dr. Dusan Balanan from Mauritius. Like my colleague, Dr. Jasmine, I'm a pathologist, not an oncologist. So before talking to you about the Mauritian context, I just refer to the words of Dr. Jean-Paul. C'est un teacher. He opened his heart today to tell us he has been trained, empowered to do something positive for his country fellows. But unfortunately, due to lack of resources and finances, it's difficult for him to cope with all what he can do, but he's unable to achieve so. And now I come to Mauritius. Mauritius, we are a welfare state, and our public hospitals, our public health institutions are free of cost to the Mauritian population. And it's quite beautiful when I'm hearing these words from our colleagues of African countries that they have to suffer, they have to pay for services sometimes that are not available in their country. And then we have a Mauritian population which takes everything for granted because it is a free service, free healthcare services in the public hospitals. It's only when they travel abroad that they know the importance and the value of what they are getting at home. So now I've come to the MDTs in our oncology services. MDTs usually, traditionally, they are there for a team to assess and evaluate the best options of treatment for each and every patient. But in our context, in the oncology services, we have customized and adapted these MDTs as per the requirements of the departments. For certain patients, we do have an intra-departmental, formal or informal meeting among oncologists to decide upon the best treatment for their patients. But coming to specific MDTs, we have two types of MDTs in our oncology services. The first one is clinical. It is set up of co-members having the oncologist, the pathologist, the radiologist, and the surgeon. And if, depending on the case, sometimes we call on the orthopedic surgeon or the physician or the gynecologist. But the co-members of these four specialties mentioned. And these entities are set up when they have complicated or difficult cases. Usually cancer patients who are not responding to conventional chemotherapy or radiotherapy. Or you have patients who are having recurrence of their cancers and might need another surgical intervention. Or we have another group of patients for whom local treatment is not available. Then we set up an overseas board so that they can be sent abroad to get the required treatment. This is one type of MDT we have for our cancer patients. Then coming to palliative care, we have another multidisciplinary team for palliation, consisting of the treating oncologist, the psychologist, the nutritionist, the nursing officer, and the medical social worker. They take in charge the quality of life of the patient. They take in charge the social aspect of the patient. Financial aspect, there is no need because it's free. And they also look after the pain management. Pain management in our oncology services, we use both opioids and opiates like morphine, codeine, and tramadol, depending upon the intensity of pain of the pain. So accordingly, we use these drugs. And then we don't have a specific pain specialist or pain clinic in our government services. I don't think it's there in the private sector or in Mauritius. So we try to deal with what we have. And then I've written also about our pathology services, but I don't think it will be helpful in this program. So I'll just conclude here that we are working with what we have, with how we can deal with these patients, and as far as we can, we give the proper recommended protocols. And now we are shifting from conventional chemotherapy towards targeted and immunotherapy to the future. So that's it on the operation side. Thank you.
Thank you. Good evening. My name is Kofi Adum Atta. I'm a family physician and a senior resident in palliative medicine. Before I answer the question on pain management and palliative care, I would like to add a little bit towards my senior colleague spoke about when he did a presentation about training centers across Africa. Ghana has a well-established postgraduate training in palliative medicine. The Ghana College of Physicians and Surgeons has a fellowship training program in hospice and palliative care. I am one of 4 senior residents in training. The Ghana College of Nurses and Midwifery has a specialist program in palliative care for nurses, and they've trained a lot of practitioners across the country. Again, recently, there's been several training in child palliative care, which is a collaboration between child palliative care in Ghana and then the International Child Palliative Care Network Association, training a lot of nurses and other healthcare providers across the country. Actually, next week, there's going to be the Southern Zone training, a workshop, a whole week workshop. They've already been doing clinical rotations, so they're going to do an in-person interaction with the facilitators for a whole week in one of the historic cities in Ghana, Cape Coast, and it's scheduled for next week. Palliative medicine and then pain management it's a specialty in family medicine. So it's usually handled by family medicine practitioners. All right. So the concepts of family medicine are quite important when in pain management and in palliative medicine. Notably, is that the care that you're providing is holistic. You have a holistic approach to the care that you're giving, and then you provide what we call increased access to specialist care. The care is continuous, which means that you follow the patient through and through. If it's comprehensive, means that at the primary care level, the care physician should be able to comprehensively investigate the patient fully and be a central point to coordinate and collaborate with other care practitioners in the care that the patient needs. Again, when we talk about pain management or palliative care management, we have what we call in family medicine. I hope my senior colleagues, I know my senior colleagues will bear me out, is a concept of the 3-tier diagnosis and 3-tier management. A lot of other clinical practices will only dwell on the clinical presentation that the patient has, but the holistic approach to care that family physicians have, we do what we call the 3-tier assessment, which is the physical or clinical diagnosis that we make, and then we have the individual experience or assessment, which deals with what the patient fears or is worried about, his or her ideas or perceptions about the disease, the functional loss that the patient experiences, and then the expectation or the goals of care that the patient has are all captured in the care that we give to the patient. Okay, so then chronic pain usually does not present with just physical pain, but it's multi-faceted. You have patients presenting in addition to the physical pain, which also has several subsets of it, whether it is nociceptive or inflammatory or neuropathic, or it's a mixture as it relates to cancer pain. They can also present with psychological pain or psychological distress that will manifest physically as pain, and it needs to be properly assessed and then properly managed. They can also present with social pain. In the clinic, we've seen several cases where, because of dysfunction in the family, it creates a lot of distress for the primary patient, and it causes pain for such a person. So a way to approach that is to have a family meeting, family conference, address any little problem that's or tension between the family members, and it causes pain relief for the patient in question. The other one has to do with the spiritual pain that the patient can sometimes experience, as my senior colleague spoke about. Patients who are faced with existential issues or life-threatening conditions, especially if they are the spiritual type, are faced with spiritual conflict where they ask themselves, why am I going through this? Why me? I thought I had a God who can deliver me from this or from that. It creates a lot of spiritual conflict that needs to be properly identified, assessed, and then managed as part of the pain management process. So you realize that the approach to pain management cannot be done by just one person or by one discipline, but by a team who are needed to form part of the approach to the pain that the patient is presenting with. So in our clinic, we have the family physician, we have a pain specialist, we have a pharmacist, we have a dietitian, and then we have a clinical psychologist as the core of the team. We do weekly multidisciplinary team ward rounds. We go around the patients that have been admitted for palliative medicine, and we assess the patient. Everybody has to contribute, and then an appropriate treatment measure is given to the patient. In instances where we need the input for other specialties, we coordinate the care, and then we collaborate with other care practitioners to also put in their input, whether it is interventional radiology, for example, if you have a spinal cord invasion, tumor spread to the spinal cord that causes a lot of pain for the patient, or you have tumor metastasis to the bone that is causing pain that cannot be controlled on strong opioids, then palliative radiotherapy can play a major role. So we collaborate with the radiotherapists to also help in that regard. All right. So depending on the care needs of the patient and the treatment goals that the patient has and the problems that have been identified, we involve an appropriate care practitioner to help in that regard. So you've had instances where you had to involve imams, we've involved the chaplain, we've involved even traditional believers in the care that we give to the patient. And it gives a lot of relief and respite to the patient. And it's not just the prescription of medications, whether it is the opioids or adjuvants alone that helps with the patient. So that is the approach that we have. We have to explore fully the nature of the pain or the palliative problem that the patient is presenting with. And then based on that, we can refer appropriately or coordinate to the care or collaborate with other care practitioners to provide the care that the patient needs. Thank you.
Thank you so much, Salvana. Now let's hear from our very own General Chair. What is this team approach in Tanzania like, and what are we missing? Are we there?
Thank you, Professor. I think Dr. from Ghana has said a lot of things that they are missing from the past. And as you say that we look at what was missing, and it's a difficult for all of us. So I was like scaling out, like I was putting the scale. And I saw that in all our discussion, there is, for those who are having
nothing like your resources and everything. And the other side where they have everything. And there are some of us who are in the middle. Yeah. Where we have something that we are missing other things. And care of cancer patients. So that's how it is. I think that's how I presented in the capacity building my presentation. We have disparities in our content. There are some countries that have a lot and some they don't have. So even within the country, yes, even within the country. For example, in our country, Tanzania, we have some palliative care activities, yes, in different areas, but for cancer patients, we have open cancer, which is well structured and is well structured multidisciplinary clinic for cancer patients. But you know that we are establishing other cancer centers in the country, in Dodoma, Mwanza, Bugando, and Kilimanjaro, yes. And in all these areas, still they don't have that team that is well established, like the way it is at the Ocean Road Cancer Institute. So the challenge is in creating this team. As Dr. from Ghana said, the team comprises of physician and nurse, and there's a lot of people that are caring for this patient. And it's not that supposed to be like the whole team should be in one place. You can find like at Ocean Road, they don't have physiotherapists, but physiotherapists are at the Memorial National Hospital. These are different hospitals. So we kind of share and refer patients to that area. So pain management is kind of patient-centered. Not all patients will need physiotherapists and not all patients will need psychotherapy, or not all patients will need spiritual care. But we take all these patients into their totality, into their wholeness, and assess their need at that moment. And that person, the first person to assess is the physician. Then when you think that this patient has this issue, then you refer to a colleague or a person who thinks that can handle that need of that patient. That's how we work together. So the importance is creating the teams in our hospitals. And for example, in our country, as Dr. Larry said, coordinating a short course in palliative care. And in this course, we always advise people to come in teams. Like we don't come from the district hospital or the doctor to learn about palliative care. You go back and the rest of the team will not understand what you're doing. So we usually advise them to come as teams, as a doctor and nurse, a pharmacist who will help you to procure your morphine, a social worker, and that kind of a team. That when you start together in one band, when you go back, it's easy to start implementing the services in your area. So it's important even for us when we take for palliative care, to send them as teams so that when they come back, at least they can start immediately giving services to our patients. And another thing I can say that the importance of teams, it helps to help each other in our everyone's special expertise. Because a doctor cannot do a work of a priest, and the priest cannot do a work of a doctor. So we kind of complement each other. Yes. And at the end of the day, we get the best outcome of our patients, but also their families, because we don't work with families alone, patients alone, but also we need to care of the carers who are caring for the patients.
Thank you. So UNICEF and WHO are pushing an agenda of patient-centered care. And if you offer patient-centered care, then you want to take care of this children. I think one of our biggest problems is incapable of working together with different funders, different interests. When they fund the oncologist doesn't want to work with others. And when the surgeon is funded, doesn't want to work with the oncologist. Everybody wants to be the boss and the in charge. And so the type of clinic I saw at TMH is not seen in most of our countries, if not all, where a patient walks through one door in a disease management group and he'll get all services offered in that. When we try that, we start charging. And so a single patient will find so much consultation fees in seeing everybody that is needed in the field. So if I may just get a comment or impression from the Indian delegation, how you succeeded with your pain management multidisciplinary approach, who would be best for that? Yes, please. Tell us your success with the experience and your advice on how we should go towards establishing a multidisciplinary approach.
You know, first thing, we depend a lot on the governments. The same thing, I was at St. Jude for 8 years. I was in USA, everything free. St. Jude in Memphis, Tennessee. And I come back fully, ready to take care of pediatric patient, fully trained. 5 years I was there in St. Jude. So when I come back, this is, I'm talking about 1990. So there was basically government was there, Tata was there. It supported the patient, not like today. That time it was much less. General patients were treated free, but not free, but at much lower rate. Medicine then all they had to buy. But finances were a problem. But second thing, accommodation. We get patients from all over the country, pediatric cancer. They have to stay for 7, 8, 9 months sometimes for the initial treatment. Accommodation was a problem. Leave aside, patients had money and accommodation, but they could not arrange blood and blood products. We had to say no for the treatment. So many patients we had to say no. And after learning and doing, it was such a disaster that you feel you can help the patient, but you cannot. So we didn't wait for the government. Tata was helping and all, but we thought we have to do something on our own. And we established a foundation, or NGO called Impact Foundation, improving pediatric cancer care and treatment. And through that, we started raising funds right from an individual donor to corporate. But now we raise nearly $1 million in Indian rupees, so 60 crores, what you say, around $1 million per year, so that no child will go free, go without treatment because of reason. So I think we have government support, Tata supports us a lot, but sometimes I think we have to take it in our hands and try to do something. If there are people who want to help out, it may not be that much, but slowly when we see our work, when they see our this thing, and you have to create awareness. So along with that, we always give in papers and all our success stories of what we are doing, so that when our needs, so when people read that, they come and help us out also. So this I'm talking about, there's the pediatric section, but the same is being done for the whole hospital by the hospital now. So I think government supports, but government has limitations. No government is like Mauritius, where everything is free, or like United Kingdom. But for example, UK, you see, they will give you free, but you have to wait for a month. Radiation appointment is for 2 months, 3 months. So there are limitations. I think we have to work for that on our own. And together, if we do that, there are a lot of help is available from the community, and it will help us to take care of our patients better. So please do not wait entirely for the government. Let them do, but we can't just say the government is not doing this or that. Start doing it. Every government also helps them. Now we are in a position to tell the government what to do because they know the work we are doing.
Thank you. Thank you so much to participants. Thank you so much to my panelists. And you have a burning question? Oh my goodness. A comment or a question? Okay, then say.
Yeah, I just wanted to thank you so much for that. I just wanted to say that one of the things that I also have a problem with access to essential medicine is advocating for your government to increase and bring medications into your essential medicine list. And most countries have now advocated to the WHO recommendations that for oral morphine, which is relatively cheap, very effective, should be part of the essential medicines in each country. And that's how you make able to have small patients accepting it. There's a program in Uganda, we have a central production of morphine. In Kenya, we have central production of morphine, which is a government project that ensures that it's available for the governments government hospitals that need it. We're also working with the pharmacy, or I don't know what you call them in your country, but the regulatory bodies to ensure that you have a balance where they're not focusing a lot on the illicit type of office, but also focusing on ensuring that's available for pain management and for research as well. I was going to ask that question before this team came on board. My question was, how many people in this room are not doctors? People in this room are not doctors, medical doctors. Everybody is a doctor. So really, so we're only doctors. If we talk about multidisciplinary, interdisciplinary, multi-professional, I just want to remind that most of our patients are taken care of by nurses. Dr. Kumar is in there. Where are nurses in this room? When you're done with the patients, they go to the bedside, gives them those medications. If the nurses don't understand how to provide medication or even not dispense medication, those patients will be paid. Before you train our nurses, you will find them not still involved or not being given patients are kindly paid. Because the nurses are not trained to, we are supported to train nurses. But nurses spend most of the time with patients and they're very important. We have pharmacists in this room. So when we actually talk about working together as a team, we shouldn't assume that doctors are going to take care of the patients alone. Doctors spend very little time with patients. What they've done, what they need to do, the patient is pushed to the ward. And the nurse, the psychologist, the nutritionist, and all those other people become the main people taking care of the patients. So next time when we have this session, remember it's not only doctors, there are many other people behind, chaplains and the rest, who actually make it possible for patients, probably quality of care, including even their caregivers.
Yeah, thank you for reminding us. I know Merck has sent lots of nurses, lots of the data, but that's part of building multidisciplinary approach. So to us doctors who are here, when we go back, let's champion pain management. We start by asking, checking them as a fifth vital sign. That's what I normally tell my students. Always ask, are you in pain? Visual analog score has been difficult to use for students and doctors, but just ask whether the patient is in pain, and you will know how to address it. Otherwise, you don't ask, they know it's normal. So when you are poor, you take lots of things as normal, so they will not say. But if you offer to ask, they will tell you, I am pain. And so you will decide how best to handle it. And don't hesitate to call the priests and everybody. We just call them also to be talking to them. Most of our hospitals have church and a mosque, and there's somebody there 24/7. Unfortunately, we call them when patients are in their last breath, and they come and give them the final blessing. Call them, let them be part of the ward round with patients. Otherwise, thank you very much, and you might go back to your seats. And now I give back the mic to so this marks the end of our beautiful session. And I don't know if I want to say it in Swahili, because we all taught yesterday how to piga makofi. You know piga makofi? Yeah, so to piga makofi, ya nguvu. So I don't know where Merck takes us next year, but until then, if we are lucky, we'll meet again. So otherwise, for those of you who are extending your stay in Tanzania, somebody was asking me where to go. You have 2 days.
No,
you are
going to the hospitals.
You are going to the hospitals. Okay, I'll pick you. Maybe tomorrow. I'll give them. How many are remaining tomorrow?
We are visiting your hospital.
You are visiting my
Your-
hospital. My hospital. Okay, so I'll be there. Then Christina will be waiting for you. How many are staying again on Friday?
Friday, I'm leaving Saturday morning.
You are leaving Saturday morning. So it is always easy to take ferry in the morning and cross to Zanzibar and come back in the evening. It is possible. Just book your return ticket when you are buying your ticket so that you don't rush
in the evening to buy a ticket on your return. So you go with the first boat in the morning at 7, just opposite your return. So you just walk, you don't need to book a day before. You just go to the ferry in the morning and get your ticket. And you go to Zanzibar, get lost in the stone town. It's a very difficult walk. I never know which passage to take, but finally you just keep one direction, not. And you are outside in the beach and you ask, which way do I go? And you keep walking. It's a nice town. It was built without any technology. It never floods. The sewage never blocks. It's wonderful. You look at it and you say, I think technology was there before and now we have abused it. Because Dar es Salaam floods, Stone Town can't flood, however big it rains. And the toilets will never flood. So it's if you have one extra day, you go to Zanzibar. If you have tomorrow and Friday free, you can take a flight to Arusha, drive to Ngorongoro. And in Ngorongoro, you'll see all the big 5 animals, all in ones, living with the Maasai, with their cows, not attacking each other. Wow. Yeah. So you will see all the big 5 animals, Maasai cattle, and the Maasai, and the children, walking between the lions and the leopards. They don't attack each other. Huh? So it's a wild wonder at Ngorongoro. You can't go to Serengeti. Serengeti is an open field. So you can enjoy Serengeti if you have time, if you can drive through safari, because you might drive the whole morning without seeing anything. Yeah? So Serengeti, where you wanted to go, is not. If you want to go to see animals, go to Ngorongoro. And fly to Arusha, take a car to Ngorongoro, come back, fly back to that Friday night, fly out Saturday. So that's being a tourist guide.
Personally want to thank Dr. Rajkumar. He has been, we have been traveling in so much. Thank you for running everything so well.
Yeah, so finally, thank you all to the Indian team. My advice to Mike next time, you saw the questions that were being asked here because you gave limited guidance on what to be presented. So like my chief Shailesh would have been told, how do you work up a patient for pancreatic cancer? So that it gives like a lecture. You give him 45 minutes, take the floor, give a lecture, and so you can make it a lecture so that young people learn from a lecture where you take the patient from when they are seen, how you investigate, how you make those decisions, and post-operative care. My worst experience was an American, very good pancreatic surgeon, came to a conference. We were hosting a COSEXA, the East African and Southern African College conference in Arusha. So he came a week before and visited a mission hospital somewhere close to Ngorongoro and found a patient with obstructive jaundice with poor CT scan, and he did a witness and came to the conference and was happy. I did the first peoples in Tanzania. And I was just a young surgeon. So I asked him, so how is the patient? And he says, well, they're taking care of him. And I asked, you did the first peoples in Tanzania. Do they know how to take care of that patient? Did you call back? It's a week. He didn't. So I said, can we call? And we called. The Whipple's patient died on day 2. So you can be skilled, but the center is not skilled. So I normally say that there's 2 different things: to be skilled and the center to be skilled to take care of the patient. That's the most important thing to go with. Even if you train, you have to come and do it back slowly. Try and recreate the circumstances of where you trained. Otherwise, right?